Veterinary Medicine Department for organizing this conference and the inviting us for this delivering the sessions on One Health. Basically, Trivandrum Medical College, I came to know that it has rich history and this response of the students for this conference has been enthusiastic. So, from medical graduates' point of view, it is very important that whatever the advances are taking at the national and international level on different emerging theme areas, health aspect areas needs to be learned, and if any research or any research acumen needs to be developed for that particular purpose, we must understand it. So I think it has been good from the point of the organizers' point of view that they have kept this session on One Health. So I would just like to explain you about what exactly is the One Health. Basically, One Health is the concept, is the way of looking to particular issue, that is disease. So what this One Health concept talks about is that human beings, since they are coexisting with the environment, with the plants, the animals, the wildlife, so the whole ecosystem is basically contributing to the health and disease in human beings. So if you want to look from the prevention of disease or control of the disease, you must adopt an approach where you look to whole ecosystem rather than just addressing that particular individual status of that particular health of that particular human being. The means by seeing that at present in medical colleges, teaching is mainly focuses on the persons maintaining the healthy person, that is prevention, and secondly, if he is diseased, then it's clinical management. What this approach basically talks about, that the health of the human beings is interlinked with the health of the animals, the environmental changes, with the diseases which are being transmitted into the livestock as well as the wildlife, and as well as the changes which are related to the biodiversity and environment. So this is actually a concept. Now this is actually not a new concept. This has been a very old concept. If you see the Hippocrates, the Greek physician, everybody knows it. He also mentioned about the airs and waters and places, that this is the concept which needs to be reflected upon when we adopt the prevention of the disease. Rudolf Virchow, he mentioned that between humans and animals there should not be any dividing line, nor there should be. The Dr. Willem Osler also mentioned the same. If you see the Indian context, the Bohr committee is also highlighted that the One Health concept, that is the human health and animal health, they are interlinked and they need to be adopt that approach so that the prevention can be done, disease can be done from the, especially from the diseases which are transmitted from animals. Now this is just example of what exactly why zoonotic diseases are important. So when I came into this particular area of One Health, before that I was not aware that this much of zoonotic disease have a burden. Almost 60% of known infectious diseases and the 75% of new emerging infectious diseases are zoonotic in origin. So that is actually a huge burden. If you see the recent examples of the pandemics of Ebola, Nipah, even the COVID was thought to be in zoonotic origin. They are all in zoonotic origin. If you see the global account, most of the 15% of deaths and 43.7 from the low resource country. These are from basically zoonotic in origin. Now, since this concept is old, this is being talked since so long, then why that it has now come into picture and everybody is talking about the One Health? Basically, this is actually a snapshot of what is being actually done at international level. If you just type in a Google, you will know about the tripartite and quadripartite organizations. Basically, tripartite means WHO, World Health Organization, which looks after the recommendations for human health. The organizational for animal health, OIE. So that is the second organization. Third is the FAO, Food and Agricultural Organization. Basically, when we talk about One Health, which issues needs attention of one through One Health approach? First is zoonosis. Second is the antimicrobial resistance. Third is the food safety, and others are climate change and many others. So these three organizations came and evolved the concept that there should be a tripartite action plan. So all these three departments should come together and prepare action plan in such a way that the roles and responsibilities are shared among these different departments. Now the UN agency has come, so it is not called as quadripartite. So these are the basically issues which needs to be addressed through the One Health approach. Now this might sound to be a very theoretical point for you, but when we actually implement, it is actually very practical concept. I will give you with the examples of particular diseases, but these are the themes or core areas where which needs to be addressed to the One Health. And not only this zoonosis, environment and AMR and food safety, others are areas that like mental health, chronic diseases, occupational health. This needs to be addressed through the coordination with different departments, which also requires the One Health approach. Now, the animal welfare is a concept where that if the domestic livestock, if they are not properly reared properly, they will develop disease, and that it will result in not only in the loss of income but also will result in a transmission of the diseases to the human beings. AMR, we do all know how the threatening is AMR is. Almost 40 to 60% of the infection, especially in Brazil and Russia and Indonesia, they are now of these AMR, these drug resistant bacteria. In India, if you see that the most of the outbreaks, most of the infections which are there, and if you see the routine cultures in your microbiology department, most of them are having the drug resistance bacteria. Now there is also economic angle also. If in the any policy level action, what is seen as the what is basically the economic burden also. So if you see the major outbreaks of zoonosis, they have estimated almost $18 billion of the cost to the whole of the countries. Secondly, it is, if we adopt this approach, we can save almost more than $90 billion. So that has been the importance of adopting a one particular approach. Now, if you see these pathogens which have caused pandemic over a period of few years, they have resulted not only the cases and deaths, but they also had significant economic loss. You must have seen in the COVID how much the devastating it was, not only for the in terms of morbidity, mortality, but in terms of the tours, tourism, then the major earning for all the individuals. Now this is actually a diagram which basically clears the relationship between the wildlife, livestock, and the human health. If you see the first diagram, the diseases basically are, there are millions of viruses actually which are circulating in the wildlife. Those, they are not but they never get transmitted to the particular human beings. Occasionally, when they come in contact with the domestic livestock, when the domestic livestock, the areas especially where located near forest areas, they get spillover from those wildlife. Example is obviously a KFD, a Kessner forest disease, like. And after that, if there is a spillover from that domestic livestock, because most of the population in the country is living in the rural area where there is India is the country which is having not only the highest human population but also having one of the largest livestock population, and they have a significant human to animal contact. So what is the importance is that the Ebola, it came from wildlife to livestock, and then came to the human being population. So what is important is that if we have a surveillance system which will detect the events or any outbreaks in particular, either in the wildlife or in the livestock, we will be able to take measures to prevent that particular outbreak, and we can subsequently decrease the impact of that particular outbreak in the human being. So that basically is the concept that we must invest in the wildlife surveillance as well as animal surveillance. When we must, as a human health stakeholder, we must know what is happening in our livestock. Just to give example, suppose I was just discussing about the I was being informed that the leptospirosis cases in Kerala, and so we must have the, when we undertake the meetings with the animal husbandry and we must know what particular type of leptospirosis reservoirs are prevalent in particular the through sampling of the domestic livestock as well as the rats. So we must, so even if we know that what particular seroids are circulating, we should be able to know which are more pathogenic, what particular is what is happening in that particular area, because ultimately these are coming from the animals. So basically this is actually a history of the pandemics, and if you see most of them are actually a zoonotic in origin. If you see the plague, the Spanish flu, the Hong Kong flu, swine flu, and the Ebola. COVID also was thought to be in zoonotic origin, but the source has not been clear. But it is thought to be in zoonotic origin based on what actually has it's shown based on the viral characteristics. So what can be done basically? So after the COVID, now everybody has realized that we must adopt the One Health approach and tackle this. The prevent next pandemic is obviously is going to be not 100% sure, but most probably it would be a zoonotic origin. And for that, if you see the globally, there is a pandemic preparedness plan, and this plan mainly focuses on One Health, and all these four agencies, they have come together and they are preparing a plan for tackling this issue of the zoonosis. Now, if you see, this is the right graph. If you see, there is issues about this red part. This highlights about the deforestation. So every state, this is having an area more deforestation. They are more prone to the diseases of the zoonosis and the particular relevant areas. So the deforestation, what basically it deals with, that deforestation results in the loss of habitat for particular animals, especially wildlife. They bring in more contact with the livestock, and obviously in human beings it results in the transmission of the diseases. So in COVID, what we saw basically was the one particular event in one particular area of the whole of the world globally. It transmitted rapidly across the world, and that was because of this the international travel. So globalization. So it is not that only the ecological changes or biodiversity changes will from particular Kerala forest, it will be impacting the human health of the persons living in Kerala. Any the any changes or any virus transmission in Africa in wildlife from human beings, it can have impact in whole of the world, and that is why whole world is basically concerned about the zoonotic disease events. Then unprecedented growth and expansion of the human population. If you know about Rift Valley fever and the West Nile fevers, they are increasing in most of the part of the countries, basically because of this deforestation and environmental changes. Because what it basically is that if you there are significant environmental changes, then the vector density in that particular area increases. If the vector density increases, it results in more of the mosquito-borne and other illnesses which are of zoonotic in origin. So these are the basically reasons. Another point is that we now have a improved diagnostic after the COVID. If you see, most of the districts, they are having the PCR facilities. Most of the microbiological departments now upgraded. So that also brings the improved capacity to diagnose the zoonotic diseases. Now, these are the priority zoonotic diseases in India. The brucellosis in human health, the brucellosis is presents with the chronic fever and joint pains, not usually suspected by the clinicians, but it has significant impact in the livestock, it results in the loss of basically livestock, result in abortion in particular cattle. So if you, I just want to give example of brucellosis from the One Health perspective. Suppose as a human health, as a clinical practitioners, when a patient with chronic fevers, because normally chronic fever comes, we normally don't suspect brucellosis. What we suspect is tuberculosis, any other pyrexia of unknown origin, or any the acute disease which is being superimposed on any other chronic disease. But what if that person is suspected for brucellosis based on the history of that, whether that person is animal handler, then in our system normally the veterinary department doesn't go and actually screen that particular the cattle for that particular brucellosis. If we clinician is updated that these are the pockets where the actually animal brucellosis is prevalent, then he will try to suspect those in those particular patients which are attending to this OPD. So as a medical officer of that particular PSC, he should be knowing what particular is prevalent in that particular animals in that particular area. So that is example of actually brucellosis, and that we are trying to address through our program. Rabies is similar thing. If you have a case of rabies, we must know what particular whether any dog, if there is a surveillance of the dogs in that particular area, and if there is a diagnostic facility for veterinary in that particular college in that particular area, they must diagnose rabies in that particular dogs, and the 80% of vaccination should be done around this area to prevent the transmission of rabies. So these are the examples of different cases, different zoonotic diseases. These are the priority zoonotic diseases. There are many zoonotic diseases, but these are the 7 to 8 priority zoonotic diseases in India. So if you see the burden, the green part is showed the Zika virus. So the particular part about the issue about these zoonotic diseases is that these are reported from particular area. So based on the suitability of that particular virus or bacteria to that particular local epidemiological situation. Now what does basically it means is that if you see the Kashmir forest disease, it is reported from Karnataka, Kerala, Tamil Nadu, and also being reported from Goa, especially because of that area which is located near the forest, the Western Ghat. Similarly, if you see the CCHF, it is only reported from the Gujarat and Rajasthan. Anthrax is reported from eastern part of the country, from Odisha, Jharkhand. So because of the propensity to live in that particular the soil pH and many other climatic factors affect the propensity of surviving that particular anthrax bacteria in that particular fields. So the zoonotic diseases are very characteristics based on their local microbiological adaptations. So but if you see the scrub typhoid, it has been spread all over the country. If you know about the glanders, mainly it is the animal glanders is being reported. Human glanders is not reported since 1940s. So this is the part which needs to be taken care of. Now the why as a country, obviously we need the attention because we are of one of the fastest growing countries and large surface area, almost of the 2.4%. The population we are having and the international travel and bordered with the 7 countries. This is actually transboundary diseases also affect the soil. Then we have the 3 biodiversity zones also. So that has a rich history of the livestock and the wildlife, and the huge wet market. So this is the one of the issue. If you see in the COVID-1, that one of the issue was about the wet market. So there is no surveillance. So if you see most of the countries which are using animal products, they have very good system for slaughterhouses. Their sampling is being carried out. In India, there is a big market which is not very unorganized, and there is animal trade where there is almost no surveillance. So that is actually can contribute to a different type of zoonotic diseases which may not be very difficult to handle. So this is actually basically at the NCDC we are running these 3 programs of the elimination of rabies by 2030, and we are asking all the state to prepare action plan where they should be vaccinating almost 80% of the dogs in that particular state. So we have asked all the states to form a state level zoonosis committee where there should be a representation of the animal husbandry, wildlife, and those government and veterinary colleges. So the one point I would like to highlight that the even if we are medical person, we normally don't sit with the veterinary persons for understanding the zoonotic diseases. So what we basically do is under this program is that we ask the medical person, take both medical and veterinary person from same area, and we teach them on the prevention of the zoonotic diseases. So once you start sitting and then learning about each other's field, then only we understand the impact of that particular zoonotic disease. So we are this zoonotic committee basically discusses about the issues in both the sectors and then prepare a plan accordingly. And I'm happy that the Kerala has also established the One Health Committee, and they are having those meetings, especially after the incidences of the leptospirosis deaths and COVID deaths. So this is what we want at the block level. If you see the block level, we have block level medical officer, but at the same time veterinary officers are there. At the community level, we have ASHA ANMs, but ASHA ANM never interact with the Krushi Mitras or paravets. So they are, so just to give example, if there is in particular village, if there is a death of particular livestock due to rabies, or if there is death of the livestock due to anthrax or brucellosis, then that is not being informed to the particular ASHA or ANM or that particular whoever is CHB. So that particular coordination needs to be established. If they are informed, then they will inform the medical officer, and then the actions will also be undertaken. We are asking them to link this all three stakeholders, and we are also having a sentinel sites. If you see the regional level, all the most of it is planned that 80 to 100 medical colleges, they will be detecting the burden of the zoonotic disease. So the patients coming with the fever, they will be screened for the zoonotic disease, and I am happy that the Trivandrum Medical College, this is being strengthened under this National One Health program. It is one of the sentinel sites, and madam is the nodal coordinator for that. And at the national level, obviously these all the stakeholders are there, and the standing committee on zoonosis also there. So what we are basically undertaking is, as I mentioned, we carry out the joint training of medical and veterinary people. But for medical graduates, if you really want to do some advanced training in the One Health, you are welcome in the NCDC. We also run the FETPV, that is called as Sector Connect program, the 3-month program. We have advanced courses also, 1 year or 1.5 years courses. You can go into the NCDC website, and you can get enrolled in this FATB V also courses. Then we are planning for basically the data integration is very important. In the human health, now we have the digitalized system, the integrated health information platform, where we'll be getting all the data on human health. But the same thing is being also done in the animal health. That is through National Digital Livestock Mission. They have enough portal. So there also animals, they have tagged more than they say about 20 crore animals they have tagged. So in that we can get to know what basically is happening in the animal health sector. So if we can have a data of both human health and animal health, then based on digital platform also, we will be knowing exactly the particular issue of prevalent in that particular areas. So this is basically a laboratory network. We are strengthening the regional coordinator. So we strengthen both medical colleges as well as veterinary colleges under this program for diagnostics and in the awareness activities. So this is basically a networking of the sentinel sites. In Kerala, we have strengthened more than 3 medical colleges, and we will be strengthening more 80 to 100 sites. So basic idea is that clinician must suspect the zoonotic disease, because at present they do not suspect the zoonotic diseases like brucellosis, leptospirosis. Rabies is obviously suspected usually because of the clinical symptomology, but anthrax, KFD, and other the parasitic zoonosis, cysticercosis, onchocercosis, these are not being suspected. So the training of the rather refreshment of it is very important that clinicians should be trained on those things. Now, we actually have trainings across the country every year. So, a lot of trainings are being held. Not only the sensitization of zoonotic diseases, we also have actually a hands-on training on basically how to diagnose zoonotic diseases. In this medical college, also we under this program we are having this training, so you can participate in those trainings. And we carry out the IEC materials. So basically at the national level, if you just wanted to inform me that National One Health Mission is there where all ministries are coordinating. There is a National One Health Institute is being set up in Nagpur, where it is through ICMR, where the BSL-3 laboratory is there, and they will be coordinating with all the ministries on research aspects and vaccine aspects of the issues related to One Health, especially the zoonosis. What is important is that no program can succeed without the involvement of public, and for that intensive awareness is important, and that's why we have this now community outreach program, where this high risk population is basically the agriculture workers, tribal workers, and the paravets. So all be vaccinated against the rabies. All the animal handler, they should be knowing about the leptospirosis vaccine or the brucellosis vaccine. So this needs to be done through the community outreach program, and we are undertaking that. So these are the so since the mandate of each human health and animal health is important. Just to example of rabies, we are asking for 80% of the vaccination of dogs all around the country, but then it is not in the mandate of Department of Animal Husbandry. They are more focused on the livestock, so they want to improve the productivity of livestock, the more good breeds of the cows and the buffaloes which give more milk. They are not concentrating on the cats and dogs, and so rabies is not an issue for them. So we are advocating that. So the each sector's priority are different, so that's why when we sit on one table, we need to find out the diseases which are of a common priority. So based on this, actually the prioritization was done, and this prioritization can be done at different even at the state level, because every state has different zoonotic diseases. So this was the priority zoonotic diseases, and we have developed the IEC materials, which was launched. Basically, this is available on NCDC website, and it is available in all languages, so you can check it and you can use it in particular your IEC awareness sessions. What is important? The main challenge basically is about the different prioritizations. I mentioned of different priorities of different sector. Secondly, as we say, we all know we don't often meet. So medical, veterinary, and wildlife people don't often meet with each other. They are working in the silos, so they needs to come together as a part of One Health and discuss the issues. Then obviously the logistic. Just to give example of rabies, if you see the animal vaccination, whenever we talk, they don't have manpower for catching of the dogs. If the vaccines are available for the manpower for catching of the dogs, the place and the dog vans and other logistic is not available. So this is just example of rabies. So such a problem is there in each of the zoonotic diseases. And what is important is the political will that this needs to be addressed. After COVID, there is sensitization that needs to be done, but actual implementation is lacking. Just to give example of Nipah outbreak, when there was a Nipah outbreak, the samples from bats and other animals were to be taken. So it was taken by the Animal Husbandry Department. So in the event of the outbreak, at that time nobody was knowing how to take sample. Then they basically took the sample and sent to the Nishad, Bhopal, and the ICMR. But there are very few agencies working on it. So in the event of outbreak, there is a coordination. But what we want is that there should be a regular coordination. That should be institutionalization of coordination. That means every time they should sit together after 3 or 6 months and assess this, not only during the outbreak. So that is particular key for prevention of the zoonotic diseases. So this is basically a way forward for the medical graduates, since this conference is for medical graduates. First, understand what is zoonosis, what is basically One Health. We should, as a medical graduate, learning about the disease and health is important. but learning about the animal diseases, wildlife diseases, which could have impact on the human health, how the biodiversity changes, how the deforestation and climate related changes affect the disease, how the vector density increase, uh, how it is responsible for increased human and animal contact, what is the role of the vectors. So that particular the concepts needs to be cleared in this particular graduation period, so that when you work at every clinician level or in public health level, you will have 360-degree approach to address that particular issue. Secondly, your this research acumen will improve if you understand the One Health perspective of each of the disease which is being detected in the human health population. And lastly, the trainings, if you get trained under this different programs, you will have the lot of opportunities to work in the public health sector, to basically for prevention and control of the issues related to One Health in India, especially the zoonotic disease. So this was, I think, from my side. So thank you for patient listening, and if there are any questions, you are welcome. Thank you.
Thank you very much, sir, for sharing your deep knowledge. It's a great honor to hear from you, sir, and the important. Thank you, ma'am. Once again, thank you, sir.
To all those young, innovative minds sitting out here, we are here with a theme presentation on the topic Cutting Edge Technologies in Research by Dr. Santosh Babu, IAS. Santosh Babu, sir, is a medical doctor turned Indian Administrative Service officer of the 1995 batch of the Tamil Nadu cadre. He is an alumnus of the Government Medical College, Trivandrum, 1985 batch. He is also a Shivini Gurukul scholar from the London School of Economics and Political Science and an LKY fellow and MPM degree holder from the National University of Singapore and the Harvard Kennedy School of Government. He firmly believes that only leadership embedded in integrity and selflessness with the ability to innovate in the governance process can take India to prosperity. His abiding passion has been to transform governance with his jurisdiction to world-class levels using modern management practices and tools that information technology provides. He has about 250 plus transformational initiatives and innovations to his credit, including installing ERP-driven anytime, anywhere government offices, developing and implementing numerous web-based application softwares, establishing India's first rural business process outsourcing units. He has conceived and edited numerous magazines and websites. K-Smart is his visionary project for Kerala. He has been recognized with numerous awards. His best moment so far has been when the former President of India, Dr. APJ Abdul Kalam, quoted his work under the heading Committed Leadership in his speech on the occasion of 7th National Civil Services Day, 21st April 2012 at New Delhi. In August 2019, while serving as a Principal Secretary, Information Technology Department, Government of Tamil Nadu, Dr. Hiren Joshi, advisor to Honorable Prime Minister of India, had telephonically contacted Dr. Santosh sir and invited him to join as the CEO of mygov.com in Government of India. In late 2020, he took voluntary retirement from government service with 8 years to go for retirement. He took the foray into politics and joined Makkal Needhi Mayam as its General Secretary, also in charge of IT, data, policy, manifesto and special projects. He contested as an MLA candidate representing MNM at Velachery Assembly Constituency, Chennai, during the State Assembly elections 2021, but couldn't campaign due to COVID. He managed to get 23,072 votes and came the third. He quit MNM on 13/5/21. He is a consultant for quite a few companies and is also a founder of the Capstone IAS Academy. He works currently in the rank of Principal Secretary as the MD of KFON, MD of KSITIL, and CMD and ED of IKM, and as the head, Work Near Home Project, Government of Kerala. It will be my honor to welcome Dr. Santosh Babu IAS on stage for his presentation.
എല്ലാവർക്കും നമസ്കാരം. Thank you for the nice introduction. Madam Dr. Sara, Dr. Anuja, Dr. Shaji, my good friend Dr. Shekhar Kuriakus, Dr. Ajit, and all the students and teachers and colleagues who are sitting here. It's actually a nostalgic moment for me because, we all did our exams here in 85, 91. So 31 years later, when I'm standing here in the presence of this beautiful institution, I should take an anticipatory bail. Dr. Anuja has put me into a position where she has asked me to talk about technology, so I said yes. But when I got into it, I was so terrified because this is not my area. So let me take that anticipatory bail. If I do something right, you can clap. If I don't, you can just keep quiet. Because I'm in very difficult territory. I've done great work in governance. And if you ask me, research, beyond research, doing many things inside governance. K-Smart is one of the best things that we have done recently. Kerala Solutions for Managing Administrative Reformation and Transformation. The whole idea is to bring governance onto a mobile phone. Is it possible that you need not visit a government office at all? Because, one of the things that we should all realize, and I'm acutely aware of that, is that across all of us, we all have huge differences. The American president, the Indian prime minister, you, me, the man on the street, have but one thing in common, which is the 24 hours, isn't it? So if you sleep for 8 hours, 16 hours is all that is available. 16 hours. So it's extremely important that governance or great governance unleashes time for people to do what they want. So that's essentially the motto with which I have always worked in government. So I have been very comfortable using technology. Can I get the... using technology in governance, but never health department except as director of Ayush, where I brought massive changes in Tamil Nadu, but I was there only for 6 months. One of the things that I'm sorry, I think I just moved. How do I go back? Yeah. So I have never done research. So let me start from there, taking that anticipatory bail, because all of you students here, according to Dr. Anuja, is wanting to do some research. So what do? You basically try to find more information. So let's assume that there's an established body of knowledge. You put it in a circle. So that's an established body of knowledge. You don't need to do research there, right? But if you look at the rim around it, that's a place where you need to research. You are trying to know the unknown, isn't it? So sometimes because we are medical students, we might be near the rim, near the edge, towards this side of the established body of knowledge. Nothing wrong with it, as long as we are able to research. But cutting edge research is actually at the extreme end of the rim. So that's the only difference. If you ask me research, cutting edge or otherwise, so it also means that there's ordinary research. None of us want to do ordinary research, isn't it? We are all trying to improve lives as doctors. So selecting what to research is extremely important. course, keep reading the top journals, British Journal of Medicine, etc. That's the usually practiced method. But more importantly, it's intellectually stimulating to start with your own self. What is it that you want? So that's very important for all of us. Plagiarizing is very, very easy. But you'll be found out one. Second is that it's not going to give you any great joy. All you need to do is to look at the human problems. There are millions. You look at the diseases that we call idiopathic. Idiopathic is what? We don't know the cause for it. So that will be one step to start with, isn't it? Idiopathic, whatever. So many syndromes are there. So when you are looking at research, there's also basic research and there's applied research. Basic research means basically you are looking at it with curiosity, but there's a basis for applied research. You would want to study something big, but what about it? It's not going to bring about a big change. But applied research is based on basic research, and you're trying to solve a real world problem. So what is it that you want to research is something you would like to be intrigued with. So what does it do? Cutting edge research addresses important problems, employs latest technologies. It has a promise of high impact, helps push the boundaries of human knowledge. So one of the things that I have seen with startups, etc., and I'm in the IIT Research Park in Madras, or in the Kerala Startup Mission, I find very few doctors in research. I find 99% of the people who are doing research is actually engineers, right? It's also a fact that none of the doctors have discovered any of these things, thermometer or stethoscope. None of these things have been discovered by us, right? They're all done by the second creator, as it were, who is the engineer. Hats off to all the engineers. But doctors give the ideas, right? So the ideas are based on doctors' inputs. The engineers come out with those ideas and create those products and services. So the process, I'm just trying to come to terms with research myself, is choosing the area of interest. So what is the area? Is it applied research, or is it basic research that you want to do? Then identify the problem, select a topic, and explore the edge. Try to see what is America doing? What is the Illinois University doing? What are the other universities across the world doing? What is the Trivandrum Medical College doing? Is it possible to transcend? Because today, technology has come at a time when we are all together. The British, the Americans are all ahead of us. But today, internet has become a big leveler. We all have access. That's the most important thing here. Right? So the emerging technologies are very, very important. I don't know how many of you use this, but I have used most of these emerging technologies in governance: artificial intelligence, machine learning, blockchain, augmented reality. I was in handicrafts. So I think I created the first augmented virtual reality showroom. Scanning all the lakhs of items and, bringing it on screen and seeing it in a 3D way, lifting 3, 10, 20-ton items onto your screen. And, that's a way of using technology. Cloud, Internet of Things, quantum is another huge area. We can forget about it. I'm not going to talk about all this because it's a lot of material. But there's one thing which I missed here, which is 3D printing, which is called additive manufacturing. I don't know how many of you know that today the Israelis have actually printed out a heart using human cells. Are you aware about that? Please be aware, because this just happened a couple of months back. And I would urge you to read a lot on these things. One of the big things that happened day before yesterday, is that the newspapers and the world media reported that there is 3 times the volume of water inside the earth than outside. Can you believe that? There's a rock. Inside that rock, there is all the oceans put together. 3 times of that is there, 700 kilometers of that. Dr. Shekhar, you should be worried about that, because if all this water were to come up, we would be nowhere, right? So, where are the areas that we can do research? One is obviously in etiopathogenesis. Second is in what are the I get confused with this. Yeah, sorry for that. So what are the areas? Obviously, doctor, what will you do? You're trying to find the etiology. And of course, you're going to diagnostics. Teaching is one huge area where I believe that anatomy can be taught without touching the cadaver, isn't it, ma'am? I remember when we were students, when we reach home, there will be a lot of human material inside our coat pockets. I don't know whether it happens now also. A lot of small nerves and things should be, people put it as matter of, I don't know whether it's happening. But today, with augmented reality, you can actually do dissection without actually dissecting. Because, cadaver, we call it cadaver, but we need to respect the human body or the dead body. So diagnostics, therapeutics, prognosis, and of course, how do you reach people? So the cutting edge technologies. So when I say MRI scan, is it cutting edge technology? It's been there for the last 100 years, isn't it? But please note that in the last 1 month, we had a MRI scanner which has got 11.5 Teslas of magnetic field. The ones that you have in our medical colleges and hospitals, we have around 4,500 across the country, okay? These are only maximum is 3.5 Tesla. 1 Tesla is what? 30,000 times the ordinary, the magnet on the fridge, That's the power of Tesla. And that's why doctors say don't bring your iron, etc., metals, etc., into the MRI room. Why? Because it will be sucked in, right? So the average CT machine, MRI scan today, that is all in our hospitals, is between 1.5 and 3 Teslas. And what they have built in France, it's called ICU VLT MRI scan, has got 11.5 Teslas, which means what? It can actually go into the brain, and Dr. Shaji is sitting here, you will be more intrigued with this, where you can actually see the diseased portions vis-a-vis the undiseased portion to that clarity. To 0.1 mm is what they say. It's been just released by the national organization which deals with radiation, which is, I forget the name of that company, but it's a French company, and they built this. Please read about this because, I was always wondering why this MRI machine makes so much sound. So I always read about this, and then I was so interested to find out that the whole thing is because of hydrogen atoms within our body. The hydrogen atoms actually they undergo a spin. That's actually from quantum physics. It's a quantum concept. The hydrogen atom spins, and that hydrogen atom is made to align with the magnetic field, and that's how communication happens, and that's how the images are created. So as medical professionals, I think we should also be wondering what these machines do. We should not leave it to engineers alone, because we can contribute much more, right? So MRI scan latest is a cutting edge technology. It's going to change the way we look at Alzheimer's, or the way we look at Parkinson's, or the way we look at dementia. Many of these things will become crystal clear as this becomes a commercial entity. Wearables. Most of us are wearing a wearable watch. It gives a lot of information, right? So if you feed in more and more information and keep at it, I think the doctors can be alerted. Even before you get a heart attack, the hospital will realize this person is going to get a heart attack. Is it possible to find out where he is? Is it possible to send that ambulance to the place where he is? And is it possible to save his life? So these are things which wearables can do. Wearables can be biosensors. Now, of course, you do biosensors for your insulin, the diabetes, etc. Whether exoskeletons, sometimes dress wearable. It's there. I've seen it in the Massachusetts Institute of Technology. And wearable injectables. A lot of this stuff is in the market right now. Then, augmented reality, machine learning in pathology. Pathology, what do? You do sectioning, right? You do it in the microscope. Is it possible that we can give live information about a cell while the surgery is on? That's the most intriguing part, isn't it? Is it possible to give that? That cannot happen with the regular pathology because it will take minimum 30 minutes to give a response. Now, that's where we use artificial intelligence, push massive data. All the pathologists here in this medical college across the country is having massive data, push it to this algorithm, and let's come out with patterns. That's how technology is moving today. The pathologists are no longer pathologists, they are AI pathologists. So there's a huge area that we need to traverse. But I see young faces here, and I realize that you have the huge potential to traverse that. Don't be an ordinary doctor. Be an extraordinary doctor. Extraordinary means traverse disciplines. You should be in physics, you should be in mathematics, you should be in sociology, you should be in arts, you should be a painter, all these kinds of things. Then you bring the best of your potential to the latest processes and services and products to the people, for the people's benefit. Then microRNAs. I was intrigued with this, microRNAs. I don't know how many of you know this. MicroRNAs is biomarkers. It's a huge area. MicroRNAs are within the nucleus of each cell. No, all of us have different phases, but we all have the same genome inside each cell. Then how is it that we get skin a different color, muscle is different, bones are different? Is it because of what is called gene silencing? Please understand, there is something called gene silencing by mRNAs. It goes and reduces that expression. So gene expression is happening because of microRNAs. There is massive work happening on microRNAs. Please understand that we in India is also doing a lot of research on microRNA. This is something which is extremely important for disease prevention. Let's assume that we have osteoarthritis. Now, is it possible to detect microRNAs in your synovial fluid? Something which you want to do. It might be available in very, very low quantities. That doesn't mean it's not available. It's available, but you don't have the spectrometry or the device to do it. But it's possible if you do research. So that is in etiopathogenesis. In therapeutics, and how many of you have heard about Neuralink? Anybody heard about Neuralink? Yeah, there's somebody there. So this is Elon Musk's startup. It's called Neuralink, and the product is called telepathy. So what he has done is put this chip into the brain, and all of you have heard of this. Last 1 month, this has been going on for the world, and it's making a big, massive change. It's called the brain-computer interface. This is going to become a reality, but you have the flip sides of it. What about privacy and stuff like that? People talk about it. But today, somebody with a quadriplegia wants to move, obviously, isn't it? So how do you make him move? If his nerve here is cut, is it possible to send through Bluetooth signals from his brain down to the muscles? Isn't that something which should intrigue us? So that's very interesting. So that's what Elon Musk has done with this, not only with SpaceX and stuff like that, but with human beings also. Brain-computer interface. This has been going on for almost 50 years. Not this is a new, but what Elon Musk has done is he's removed all the wires. For EEG and all, we put so many wires. He's just brought it to one coin and put it in the brain. And it's been tested on a human being right now. So this is cutting edge, at really cutting edge. Then CRISPR technology. I know all of you know about this. I have been reading about this for some time because it's to do with genetic engineering. Now, whether you want people who are like me, dark, that's very current these days, to become white and, then CRISPR technology is the best. I think somebody should suggest to that lady that, there is a technology available which can make the black and the white. But CRISPR is what? Clustered, I forget the palindromic repeats. Basically 18 to 20 nucleotides together, which can come and remove. It's a biological scissor. It cuts away the disease parts of the gene and removes it. So interesting, so brilliant. But this has been there since 2009. But now CRISPR technology is being used to see how we can look at psychiatric disorders, how we can look at heart failures, how we can look at many diseases, cancer included. So CRISPR, earlier there was something called TALENS, which is again to do with transcriptase, etc. So CRISPR-Cas9, that's a protein. CRISPR is actually a nucleotide, and Cas9 is the CRISPR-associated protein. And these two come together and splice, remove the power of remove the disease portion. So very, very interesting cutting edge. So I have given some examples. An inhibitor of microRNA 155 for leukemia, that's being tried out. MicroRNA 122 inhibitor for hepatitis C virus infection is being tried out. MicroRNA 29B mimic for fibrosis is being tried out. So lots of areas, things are happening across the world. My suggestion would be that while you do your medicine, while you do your PG, etc., look out to the world, what's happening in some of these advanced universities. And they're all available, of course, at a cost. In prognosis, again, machine learning. As I said, all this boils down to those emerging technologies. Whatever is done in medicine, finally it comes to the front of a computer, isn't it? So machine learning, neuroemerging technology, biomarkers, genetic profiling, all this can help us in better prognosis and prediction of diseases. In reach, obviously, telemedicine has been there for a long time, but these days drones are being used to distribute medicines. Is it possible to bring a new cold chain system? Is it not possible for our students to find out whether in the current cold chain system that we have, is the vaccine getting attenuated? Is it possible to maintain the integrity of the vaccine with a better cold chain system? And of course, social media for reach. So extremely important that we develop that scientific bent of mind. All of you have, I'm sure. But what essentially happens is that we tend to become doctors, cardiologists, microbiologists, etc., etc. Here is one man who left his practice to become a researcher. So that's an area where it throws up all possibilities. You look at government. You know, government is one area where nobody wants change. Correct? Everybody wants you to come to the office and stand before you. The average citizen is paying taxes from which I am getting my salary, but the average citizen will come and stand like this. Why it should be like that? Why should the services not be provided on the mobile phone? That's what K-Smart does. Right now, you know, building permits used to take 30 days to 300 days in Kerala. We have brought it down to 3 seconds. Nobody's clapping. Anyways. That's to wake up, some of you have already slept off with my speech. I've come to my second last slide, which is about ethical dilemmas. You know, when you do all this, people are going to say, artificial intelligence is going to create a huge problem. This is going to create a huge problem. Nothing has ever created a huge problem because there is something called regulation. Government will always come in. What government doesn't understand, they'll put it off. What government understands, they will regulate. You know, for example, blockchain. What is it called? The coins, bitcoins. Government didn't understand much of it, not because they didn't understand, because the power of governments will go down, right? It's a process of disintermediation in blockchain. So blockchain technology is dangerous because there will be no need for RBI. There will be no need for government. Things can be carried out on the mobile phone itself. So where is government? So that's an issue which governments don't want. But as long as it does not impinge on the power, governments would like to regulate. So all these things that are coming out, whether you take genetic engineering or BCI, any of these things, it's going to revolutionize. And I think by the time we retire and you all come into the fore, lots of things would have changed. A lot of water would have flowed down the Ganga. Last slide. So what happens to research? Despite all of this, research will surge because of one thing, human curiosity. We are all absolutely curious, isn't it? We are very curious about what the neighbor is doing, isn't it? That's a kind of curiosity which should drive good things. It should be, why see, for example, I've seen this hall as a student. Nothing great has changed. I mean, some of the changes are there, ma'am. I agree with you. But couldn't this be a world-class hall? I mean, that's something which I always worry about. Why should a government office look like a government office? Why can't it look better than Infosys? It's something which we should all be worried about. So that's the thought I would like to leave you with. I would like to thank Dr. Anuja. She's my classmate. When she called, I said yes, because I was in the middle of a meeting. I didn't know that she was putting me into this precipice. But I think I managed. You are kept quiet. It's a nice feeling here to come and speak in the university or the alma mater where you studied. This is a great institution of excellence. Lots of great doctors graduated from here. Of course, most of them are abroad, but lots of them are here also. Dr. Sara, I would like to thank you for your hospitality. Dr. Anuja, Dr. Anu, Anthony, who was reading out my profile. Let me wish all of you the very best, and excellence is the word. Integrity is the second word. These are things you should carry along with your life. Come life, death, integrity and excellence should not go out. Thank you. God bless.
Thank you, sir. Your session was full of energy and valuable information to our young researchers. It will be a great pleasure for us to listen to you again in our future events. I invite Dr. Shaji KS, our Research Dean, Kerala University of Health Sciences, our former Head of Department and Professor, Psychiatry Department, Government Medical College, Trivandrum. Thank you, Shaji sir. Once again, thank you, Santosh sir.
The next distinguished speaker to honor us with his presence is Dr. S. Irudayarajan. Sir is the founder chairman of the International Institute for Migration and Development, India, and also chair of the Global Knowledge Partnership on Migration and Development, World Bank Working Group on International Migration and Urbanization. Formerly, he was professor at the Center for Development Studies. He is one of the expert committee members to advise the government of Kerala on COVID-19. He has published in international journals on social, economic, demographic, psychological, and political implications of migration on individuals, community, economy, and society. He is the editor of the annual series India Migration Report since 2010 and South Asia Migration Report since 2017, published by Routledge and founding editor-in-chief, Migration and Development. Sir has published about 314 journal articles, books, and research paper related to labor, migration, and aging labor. Sir will be enlightening us on population aging. It's our honor to invite you, sir, for the presentation. Please, sir.
I want more light outside so that people, I can see they are sleeping, I can see their faces. No PowerPoint, no PowerPoint, so you can make the room more brighter if it is possible. Thank you very much for inviting me, and I'm glad to be here. I've been to this hall sometime for some other meetings and seminars, so hall is not new to me, but I never studied here anyway, so I'm not a medical doctor, so I was told that you are all going to be future doctors. You can only decide whom to kill at what time. So, because when I was in Europe, they said euthanasia, they will decide mercy killing. Yes, time has come. And we are not doing that still in this country, but probably time will come. Maybe, I don't know, for my generation or maybe the next generation, you people will decide time to go. So I think I have to talk to you because this is something very important which is fascinating towards me. So I will see that maybe 20 minutes, what time you people have for me, 20 minutes? 20, 25? Maximum 30. Yeah, before they sleep. Okay. Let me see what I can do for you because everybody is asking me, sir, where there is no PowerPoint. I said people who have power and point, they don't need PowerPoint. So I have both power and points, so I don't need PowerPoint. So I just, because when they invited me, because I was looking at the program and looking at the thing, I thought I am in the wrong place, I should come or not. Then I decided I should come here because you are the one going to handle these old people in the coming days. And some of you who are sitting here, you should realize that you always should think ahead of at least 10 years. That's where I started off. But when I landed up, I'm a migrant from Tamil Nadu, so I can't speak Malayalam well. But still I sit in the Malayalam studios. Yesterday I was in Durdarshan. I sit, but I don't speak Malayalam. So I came as a migrant from Tamil Nadu here. I did my study in Mumbai. I landed up in Center for Development Studies, I don't know, right or wrong. When I arrived there, I am trained in economics. I have my basic degree in economics and my PhD in demography. And I know some people in Achidamina Center, all of them I know. Dr. Thangappan was my student learning with me on demography. Now there are a lot of people whom I know, my juniors, my known people in the health science department. When I came here, I asked them that what demographers have role here in this state. What I will do here. Because when I came to Kerala, Kerala is number one in human development. Why? Kerala people live longer. Even the children thinks when my father will die, they are not dying. I met one man in America. He told me, I'm waiting my father to die because then only I can sell the property and take back to America. I thought COVID came. They said, that house somebody died, that house. But my house, nothing has happened. Because he was waiting. But then, because of your medical technology, you give him first surgery, second thing, you are making people to live. Living longer, but I'm not a medical doctor. So I thought, what I will do there, living longer. And then an average woman in Kerala, when I came here, producing just 2 children. Of course, now they come to 1 child. Everybody had only 2 children. Then what is the demographer's role there? That is where in 1989, probably 35 years back, some of you are not born even that time, I started looking at aging. And I told them that time, I wrote a first paper called Aging in Kerala, One More Population Problem. You people believe that we have solved the problem because every couple have 1 child, 2 child. Of course, now infertility in Kerala is increasing. 1 out of 10 couples have some difficulty to have babies. Whereas our grandmother, whatever happens, they get 13 children. I have seen some grandmothers still alive, 13, 14. I was asking them, we are talking now about work at home. They are really working at home. Every year they get a baby. And today, even COVID time, I thought at least Kerala people will have at least a baby boom. Work at home, nothing happened in Kerala. There was no baby boom. Some places there was a baby boom. Even in European countries there was a baby boom after the COVID. 3-month, 4-month gap. But here, I don't know what the couples are doing. We don't know. So, fertility has come down. Mortality has come down. Then what we will do? I think that is where the aging is going to be an important issue for people like you who are sitting here. Why? 2 reasons, very simple reasons. Either the elderly are prepared to live. I talked to several elderly. I met one of the man. He said, my father died at 45. I may live maybe 54, 45, 54. Sir, now I am 94, I am not dying. He don't know because he never thought he will live. Many of you sitting here, many of your parents, you ask them, my father died 38, my mother died 30. Arey, you are not dying. Now dying is the people you are going to handle them, they are not going to die. Earlier, somebody is in ICU, then you started preparing where to bury the person, whom to call. Now they go to ICU, critical ICU. I have seen ventilator coming back, good morning. Ventilator coming money also. Because there is no insurance. I saw during COVID time, ventilator coming down, ventilator. Then come home. Come home. It's all because of all of you people. You are celebrating in Kerala. People are living longer and Kerala government. Without adding, unfortunately, you are adding years to the people, but you are not adding life to those years they are living. Adding life. You are adding me 1 more year. You are giving me what is called the cataract to see me well. You are giving me, I had heart problem, you put me something. I can live another 5 years. You are giving me life. But you are not giving me real life. That is where the social science come in. Today in Kerala, after reaching 60, how many years people can live? Do you know that? Any one of you know? After reaching 60, how many years people can live in Kerala? 23 years they can live. And mother's age, you have to look after them. And after reaching 70, they will live another 11 years. My God, they may not be able to hear. They will have multiple disease, multiple morbidity, multiple handicaps. Of course, some people feel it is good for them. They don't see. Some people say, ah, good, my mother don't see, very good, clap the hands. I went to meet one doctor, he said, I have done 100,000 cataract operations. I said, why you are not looking at hearing? Then I was doing a old age home study because I am having a panel data following 5,000 elderly from 2004, almost 20 years. Many of my people have died. We have only 1,500 people now because they were 60 plus in 2004. At the time, 60 plus means somebody 80 plus will be 100 plus. So many people died. And I went to one house, I saw the daughter-in-law and mother-in-law. Mother-in-law, daughter-in-law, they are happy in the house. Impossible. How can have two queens in one house? Like a honeybee, there will be only one queen. There cannot be two queens. Two queens enjoying very nicely. So I thought I will do a documentary on how the people are living. Then I asked what is the secret? Secret is that the daughter-in-law told me, mother-in-law don't hear. No problem in the house. She said, if all the old people, their ears are closed after 60, there will be no problem in the society, no problem in the house. That's why either the children will go and tell the doctor, I want to, my mother is not. Doctor will specialize how to keep the people here because nobody interested. But everybody interested because your own mother will be a servant to take care of your granddaughter. My mother should see why. No, look after the grandchildren. Hearing, no problem. Doctors. And dental care. I was talking to people, dental care. Nobody bothers. I asked one man, are you taking your mother is not selling all the time? No, sir, 80 ayala, sir. Any other than sir. 80 ayala, samay aayi. Ivarana pidichu vechirukkaavara. Ee doctors ana avaru pidichu. Allenga avaru anne poi kaano. Ningalana avaru pidichu vechirukkaana. But are we giving them life? And after reaching 80, you will live 6 years. After reaching 90, you will live 4 years. After reaching 100, you will live 1 year. Currently, our former chief minister is running that stage. He has completed 100. 1 year is average. He can live more. It's all average years. Neither they are prepared, nor children we are prepared. We just grow. That is where it's coming. The problem of living longer. I think that is you people have to keep in mind. Second thing, which is also you should all think, because all the time when the doctor comes, they will ask me, show the hand, I have a problem. They will not ask me who lives with you. Somebody can put. I went to see an eye doctor. I said, I just drove my car and came. I want to check my thing. Sir, you came alone? I said, I came alone. No, if I put something, you cannot drive. Okay, sir, thank you very much. I am going back. Who is at home? When I stopped one old man in the road in Prasad Nagar, a man who was 65 to 70, I just stopped him. I asked him only one simple question. Where do you live? Where do you live? Where do you sleep? He said, I live with my son. The big statement he made. After half an hour I was standing, I saw one old man, looks very. I stopped him. Where do you live? He said, my son lives with me. See the difference? My son lives with me. Other man says, I live with my son. You have to look at it in your medical field. Today in this state, 5% of the elderly are living. Can you people help them out? Living alone, nobody to bring them to the hospital. Somebody come living alone. 5% of the elderly people, of course, more women than men. Because women live longer. I don't know why they live longer. I also don't know still now. They say biologically they are strong. For what? I have no idea. 80% of the 80 plus in Kerala are widows. 80% of the 80 plus in Kerala are widows. But all widows are not like Sonia Gandhi. Sorry. Widows have so much problem in this state. Sometimes even just 1,000 rupees. Living alone. What you can do as a future medical doctor for those elderly who are living alone. Today 5%. When you reach 40, it will be 7%, 8%. Because this state is now, I call them a state with elderly people. This is like a dying state. Because Kerala population cannot grow beyond 40 million. That's it. Like we talk about France defaces population. You will have a declining growth rate. Thanks to the internal migrants, they are managing you now. 30 lakhs people, I was told yesterday, I was called to Durdasan to talk against the migrant. I said, sorry, I cannot talk against them. You need them. Kerala needs them, like Dubai needs Malayalis. Kerala plumber is in Dubai. We need a plumber. He comes from Orissa. Sorry, you have to find out people who are making crimes. But you cannot brand everyone who are coming from interstate migrant as you look. 80% of them are what? Living alone. I saw young boys, 19, 20, 21, not married, wife is away. I told interstate migrant life is much worse. Interstate migrants living life in Kerala is much worse than Aadu Jeevitham. Aadu Jeevitham, we are talking about that. Nothing wrong in that. We are talking about how the Malayali Nasim has suffered in the Gulf. Did we know that you have interstate migrant, you have a specialized ward here? A fellow who falls from the construction site, I told them, people who are dying in the construction site are all migrants. They are setting blood for your state. One fellow killed somebody, one fellow did something. That's why I told them, there were 12 disciples with Christ. One betrayed him. Can you call all the 11 as betrayer? No. No. So we have to look at it. Thanks to migrants, Kerala is still growing. Kerala is still growing. You will have declining population. But who will be growing in this state? The highest growth rate today in Kerala is 80 plus. 80 plus is the highest growth rate in this state. 5 to 9, negative growth rate. You should check. I asked one doctor some time back, he was running a private hospital. I should not name the person. He was running women and children hospital. I said, you say only women, children, there will be no children. What you will do? Your hospital will be winded up. You will take only pregnant lady. Please welcome. There will be no pregnant lady. What you will do? No, sir, we will do something. What you will do? We will start removing uteruses. We are doing it. We will play with them, sir. Don't worry. We will make our money. Fine. But fertility has come down very seriously. So 0 to 4 negative growth rate. 5 to 9 negative growth rate. When I told 25 years back, I told the Kerala government, your children coming down, you have to close primary schools. And they were jumping upon me. Closing primary schools? I said, yes. I said, yes, you can bring somebody to pluck your coconut tree, but you cannot bring some girl born there 3 months from Assam to come and study in your... Kerala had 600,000 births. Not very long, 20 years back. Today, last year, we had less than 300,000 births. 50% decline of birth. You have 0 to 4 decline growth rate, 5 to 9 decline growth rate, 10 to 14 decline growth rate, 15 to 19 decline growth rate, and we are reaching 20 to 24 decline growth rate. Population is declining. So you are going to your future. You got to dementia, specialize on heart problem, diabetics. You all should consider NCD. You don't spend your time on maternity. But I was told in the medical book, you have some chapter called geriatric. Nobody look at that. You all go to pediatric. Women, Because easy to have cesarean. Go there. I went to one hospital, Tamil Nadu, they said there are today 40 cesarean. 9, 9:10, 9:20. Tuck, 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 tuck. Not like that you can do with old people. You cannot do 5 hour surgery, 8 o'clock, 8:05, another 5 hour surgery. You need lot of attention. Many of you will going to concentrate on the thing. Even if you today, you go to the OP in this hospital, look at it. How many people are coming? What is the age group? And you go to look at the children's hospital, how many deliveries were there 20 years back, 10 years back, 5 years back, now? And what is the cesarean rate? Very, very high. Very, very high. That means the current, my daughter is much worse than my grandmother. Grandmother had no cesarean. They got 8, 9. That you can see in your own eyes. Today, if I go to a marriage, who is marrying in the age of 32, a boy and a girl will be 28, I go to the marriage, I see them, the boy says, this is my father, this is my mother. The girl says, this is my father, this is my mother. My grandmother, father's mother. Only my mother married me. You can see in your own eyes, people are living longer. Look at the album of your grandparents. Ask them, there was no marriage album, of course. You ask them, in their marriage time, is their both parents were alive? Today, not only parents are alive, grandparents also sitting in the front bench. Not 1, 2, sometimes 3 also. My God. And in Patanathata, for one grandchild, there are 4 grandparents. Poor grandchild, my God. The poor, one grandchild, 1 grandparents. You should put in your medicine. If that type of parents coming to you, what you will do? 1 grandchild. Grandchild is a very... Where do you get? Of course, you can get somewhere like our Nayandara did, maybe it's easier. Quickly I go, yeah, next month, yeah, take 2, 1. You want 1, sir? Take 2 also. What will be your future? People, they're already born, unfortunately. People who are 60 now were born 60 years back, they're already there. Today, who are already sitting in the standard 1 will be 60 years after now, unless tsunami comes, unless COVID comes, everybody dies. Because COVID will not treat people differently. I think I was telling them, because I was part of the COVID committee, one good thing COVID did. It treated everyone equal. We never treat everyone equal. It is the Home Minister. You cannot go to the Home Minister. But COVID will go, spend a week. Amitabh Bachchan, I am coming, sir. Finance Minister of Kerala. That is one lesson all human beings can learn, how to treat everyone equal. It never thought, oh, it's a Muslim, I will not go. Oh, it's a Muslim, I'll go to more COVID. Or this is scheduled caste, scheduled tribe. Or this is, no, it went to every place. Treated everyone equal. So aging is going to come up in how you are going to handle them. You are going to look at them only medicine. Or looking at the social thing because you are very busy. You want to see 10 patients. You don't ask them about anything. And many people come to you to talk. Many people come to you to talk. I did a survey recently. I went to one house near Ullur. I should not even tell you. I went to one house. Inside there's a one old lady, big house. She was asked me, you are doing a survey? I said, yes, I'm doing a survey on old people. They said, normally Kerala, they never do old age survey. They do only women, children survey. I said, I am doing. Come. She made a coffee. We had a talk with her. When I came out, the neighbor asked me, sir, where did you go? I said, I went to them. Oh, she is mad, sir. அவளுக்கு வட்டான சாரே சார் அவட எப்படி இருந்து ஐயோ வட் சாயா ஒன்றும் எரிஞ்சில்ல loneliness, mental health is also part of the WHO defines health as including mental health, not just physical health. Today mental health is very poor in Kerala. I told the UNDP, if you take number of suicides in Kerala per population, Kerala will be the last in the Human Development Index. Last, because now we are number one. We say everything number one. Sir, suicides, it's okay. Literacy, number one. Infant mortality, number one. People report, sir. It's a reporting problem. Why reporting problem? They report at least suicides. I met one house I went recently in Prasanagar, 93-year-old man committed suicide. I thought he will live one more year. Why he waited for, he waited 93 years, why he waited? Suppose a boy says, my girlfriend left, I'm dying. Okay, go ahead, man. Good luck for you. But 93-year-old man, shameful. I will treat as this as a shameful for the Kerala society. And recently I was shocked. One of the leading economists of the Kerala state, Kunjaman, he was telling me, sir, living alone is a problem. Like that, I never knew. And then he died. And I did not know. I was in Hyderabad when I came. After a week, there was a function. Then I asked somebody, what happened? Sir, you don't know. He committed suicide. I told the Kerala economist, you failed. You failed to keep these people. And we celebrate living longer. Clap the hands. We got the Kerala government got a prize. Chief Minister will hold in the election also on the back. Kerala. Elderly. You should give them long years. And I also want to conclude now with one important thing which is happening. Some of you maybe know. Already mentioned in the earlier talk. Many of the people are leaving Kerala now. Earlier, when I came to Kerala, people study in. That was the trend. 1960, there were 3 trains were going from Trivandrum. Trivandrum, Chennai, Trivandrum, Bangalore, Trivandrum, Mumbai, Trivandrum, Delhi. These are the 4 trains. All people left. Still they are there in Chennai, Bangalore, Delhi, Mumbai. Malayalis are there who went in 1960s. That's why Kerala called money order economy. Of course, I went to post office. They said, I want some money order. Sir, you don't know, sir, money order has been abolished. Kerala was called money order economy, that was abolished. And now, people used to study in other states and then go out. Today, our young people who are 18, 19, 20, they are leaving Kerala. I am worried about their parents and grandparents. I am very much worried. Many of the children who are leaving are one children. One child families. Today, when I am talking to you, 30% couples in Kerala just have one child. I don't know how many doctors sitting here, they say, I also have only one child. Leaves, what will happen to the grandparents? That's why we have to now think linking the youth migration and the elderly. The caregiver is not there. At least the daughter-in-law was taking care of the mother-in-law because she is here. But today, the things are changing. The young people are not there. I went to the Pathanamthitta Kottayam area. There are a lot of old people. I went to one house. I met a lady who was 88. She was living alone. 88-year-old lady. I asked her, how many children you had? She said, I had 3 sons and 2 daughters. I got 3 sons and 2 daughters. I asked them, where are they? My first son, Anthony, is in America. Third son is in Italy. Daughters settled in Dubai and Kuwait. She is alone. Husband passed away. She is a widow for last 15 years. Then I asked her, when you had your first baby when you was 23, you holded the Anthony in your lap. Do you remember Anthony any time? If you remember him, what do you do in the house? I just want to feel, I want to go back and see my earlier age when I had my first baby. Now you are 88. She said, sir, I have Anthony in my house, Matthew in my house, and also another man name is, I think, some name. Anthony, Matthew, and maybe Peter. And then I have a daughter, Mary, and Catherine. All of them in the house, sir. Then I thought, nobody is there, I don't see them. I said, where is Anthony? She started loudly calling, Eda, Anthony, odi vada. ഒരു പട്ടി വലിയ പട്ടി അവിടെ നിന്ന് പറയണം. അടുത്ത പള്ളി വിളിച്ചോടെ മാത്യു അടുത്ത പട്ടി. Then Peter മൂന്നാമത് പട്ടി പറയാണ്. ഞാൻ പറഞ്ഞു പട്ടികൾ. She said they are my friends. If I remember Anthony, I call this പട്ടി സാറേ എൻ്റെ മകനക്ക് ഇത് അറിഞ്ഞൂടാ സാറേ, അല്ലെങ്കിൽ അവൻ എന്നെ അടിച്ച് കൊല്ലോ. പട്ടിക്ക് എൻ്റെ പേര് വെച്ചിട്ടുണ്ടാ നീ? 3 പട്ടി വീട്ടിലെ പട്ടിയുണ്ട്. ഈ 3 പട്ടിയും ഈ ഡൈനിങ് ടേബിളിൽ അവരെ ചുറ്റിയിരിക്കുകയാണ്. ഞാൻ പറഞ്ഞു, വേർ ആർ ദീസ് ഗേൾസ്, യു ഹാവ് എനിത്തിങ്? യെസ് സാറേ 2 പൂച്ച ഉണ്ട് സാറേ. മറിയാ ഒരു പൂച്ച കുതിച്ച് കുതിച്ച് കുണ്ട് പൂച്ച. അവർ ഡൈനിങ് ടേബിൾ മുകളിലെ 2 പൂച്ചയും സൈഡിലെ 3 പട്ടിയും. ഈസ് ഫീഡിങ്. എടാ കളിയടാ. Impact on migration on the old people is going to be very huge. Very huge. He told me, sir, if I die in Kerala today, I will be in the mobile mortuary for 7 days. இருக்கும்போது வரல சாரே, செத்தா പറയാൻ நான் வந்துட்டே அடக்கணும். கேட்டா வச்சிருந்தா மதி, എവിടെ വയ്ക്കും? മൊബൈൽ മോർച്ചറിൽ വയ്ക്കും, ഞാൻ പൈസ തരാം. ഇരിക്കുമ്പോൾ അമ്മ ഉണ്ടാന്ന് ചോദിക്കാതെ ആൾക്കാരാണ് ഇന്ന് കേരളത്തിൽ നമ്മൾ മാറി വരികയാണ്. And now, thanks to COVID-19, some children telling in America and Canada, വരാൻ പറ്റൂല, please do online burial. ഞങ്ങൾ അവിടെ നിന്ന് കണ്ടുകൊള്ളാം. This is the stage we are talking about, where we talk, celebrating Kerala, that we are living longer, which you all contribute. When you contribute that, please see to it, you give them life to those here. I'll stop here. Thank you very much.
Thank you, sir. It was wonderful. The jokes, along with the information-packed talk, did not allow us to sleep. It's a great opportunity to listen to the words of a great, knowledgeable speaker like you. Thank you, sir. I invite Dr. Vasanta Mallika, Professor, Department of Community Medicine, Travancore, our token of gratitude to Irudaya, sir. Thank you, ma'am.
One child.
Thank you, sir.
Next, presentation, climate change. Our speaker, Dr. Shekhar Lucas Kuriakos, is the Chief Resilience Officer, Kerala, Member Secretary ex officio at Kerala State Disaster Management Authority, and Head of Kerala State Emergency Operations Center. Academically, he is associated with Center for Disaster Resilience. To his credit includes the implementation of India's first officially funded disability inclusive disaster risk reduction program undertaken by any SDMAs, which is recognized by the National Disaster Management domain. He is a University of Twente, the Netherlands Research Fund Scholarship for PhD research. Faculty ITC, University of Twente, the Netherlands, and the Indian Institute for Remote Sensing, ISRO joint for policy studies in the Netherlands. He is a member to the External Advisory Committee of the U Horizon Europe Research Project Paratus, promoting disaster preparedness and resilience by co-developing stakeholder support tools compounding. We welcome you, sir, onto the stage.
Thank you for that nice introduction. Good morning, everyone. Talk of Irudaya Rajan, sir. It has been quite a morning. Thanks for inviting me here. If you would just put on the presentation that I had shared with you, I gave it to the gentleman there on a pen drive. Am I mistaken if I am looking at the Vice Chancellor of Challenge? Technology, sir. I gave it to him in a pen drive, no? That boy gave me the pen drive. So thank you. Sorry for that delay. I'll start with where Irudaya Rajan sir stopped. Kerala State Disaster Management Authority, based on the papers that he published, started looking at aging and rescue in the age of aging. When speaking of disasters, all of you would start thinking of rescue that we do in floods, landslides. So let me start with that because that's the low-hanging fruit which we can tap on for transferring what I want to tell you. We started looking at two aspects. One is definitely aging, and two, persons with disabilities. These are two challenges that the state has with respect to starting from rescue from a DM perspective. 2018 floods. Luckily, we had only one. Those of you who participated in that rescue operations will know that when State Disaster Management Authority issued a priority of rescue, the first was persons with disabilities, the second was elderly, and the third was pregnant. So we are very sensitive to this fact. And if you look at this scenario of rescue in itself, it's not you, the doctors, who are going to rescue. Here's that friendly neighborhood you have, or the enemy neighborhood you have. Both will come to your rescue when it is in times of crisis. And then the fire and rescue service, the civil defense, the Apta Mitras. Do they know to rescue them? Where is that material which teaches them on how to rescue these people? Where is that material? I have not seen one instructive material which will educate our rescue workers on how to rescue a person with disability, or a bedridden person, or a person who is elderly, who is at the age of 80. For example, my mom, who is 75 years old, who suffers from acute arthritis. You can't just lift them and go. You can't just ask them to run. You can't ask them to swim. So this is a crisis to all of you in here, is, and particularly the younger public health professionals, future public health professionals, to come and work with us, and let's develop a very practical, simple document, a material which we could use to educate Do you want to go in 2020, 2030, or are you wanting to push it further, maybe 2070? That's the very simple tipping point where we are, and we actually have tipped over. We actually have tipped over. There is no going back. There's absolutely no going back. Doctors would be reading big books, I know. I've had been in this campus as a young student activist, so in the buildings I call Dr. Rani. Drop him once. Please. Cool weather, and we had heat. It's just an example, something that will help you to understand what it does. So we have many health impacts, and I'm not going to go into the health impact. He's nominated as the nodal officer for advising us on health matters. We work very closely. But we look forward to having more integrated relationship with the younger population here. I'll give you an example of what we did in the times of COVID. Times of COVID came. I was asked to prepare the contingency plan of the state. So what is the business continuity? And remember, Kerala notified COVID as a state-specific disaster before the government of India took it up. We were the first to showcase. I had lengthy discussions with the Ministry of Home Affairs in convincing them that this is going to be a disaster and that a disaster management perspective has to be brought in. So when we moved the file to notify it as a state-specific disaster, and luckily we had Dr. Venu, again a medical doctor, available as our principal. Not just about Kerala during COVID. And 12 during COVID. Just care that it is plans. And so I was like, where we are going to go decrease, what is the government? Yes. Available course on what many years I went. We were all surprised. You should imagine for a bacteriology and no numbers come. They were interacting. All these are not numbers. Said okay. Then it was easy for numbers. I get big. Me, who has to? Only they will have. Bunch of money that they have. Was really nice. Years published in 29 and we are Orange Book chapters which were and the public and going to try. And you will run. You can, believe me, month if 200 times more carbon than what we emit now. What would it do? But what should poke you is not those graphs. In places where the RCP 4.5 is shooting above the RCP. Do you notice that? Until I tell you, you would not notice it. But that's where what Santosh sir said, your inquisitive mind. Yeah. Sure. So here, this actually changes a lot of things for you. It simply means that even if you start living in the Stone Age from today onwards, you're still going to have a higher heat regime than now. All these tables are available, so all of you can pick it up, go to that local body, collect all the public health epidemic data or all that lifestyle disorder data and correlate it with it. Just look at it, just have a simple mean statistics derived or a simple correlation worked out. You will see what comes out. And I cannot tell you what you will see, but you need to look at it. Nobody has looked at it, and that's why I'm saying you should look at it. Some essential planning needs, and again here, flood return probability maps of 10-year to 500-year return probability. And here you can see actually which are the hospitals that are exposed to 10-year floods as against 25 to 500-year, and we have it also for climate change scenarios. So a lot of and this is done for also temperature, precipitation, all that. So with this, plan your health infrastructure. Infrastructure is currently planned based on, but when you put it there, and if you don't take that precaution of looking at whether it's a flood prone area, whether the temperature situation there is going to be rapidly increasing, you are going to invest more and more, and it will become it will not be cost beneficial for the state, for the investments that you make, for the people who are going to work there and all the people who are going to be your clients there. We have these plan and the lightning action plan. This will also help you to do a lot of actions. We also do a lot of disaster management plans. So 14 district hospitals we have completed. There's an app that is going to come. And once the app is released, it is going to be a mandatory business for every hospital starting from CHC, PHC. So all of you will have to do. So to conclude with, IPCC report, please have scientific evidence is unequivocal. Ever before this IPCC report that IPCC told that there is no more turning back. There is no more turning back. Book that storyline is very clear. This is the first time that the collective science community from climate science, earth sciences have come forward and said, no more. You can't reverse it. You just can't reverse it. So you need to adapt. And how do you adapt? It has to be transformational. You can't just stop. Look at the buildings that you build. Look at the investments that you make. Look at the kind of treatments that you deliver. A lot of behavioral changes will be required. You need to prepare. Have you done it? I don't think that Trivandrum Medical College ever submitted a DM plan to State Disaster Management Authority because we are the ones to approve it. Look at it. And when you plan your physiological hazards, no legacy epidemics and emerging diseases, all this needs to be considered in the light of climate change. And last but not the least, this is something that I had been suggesting and pushing. You really need to have a health dome coming to you. All this data available to all of medical professionals so that you can correlate the environmental parameters and climate parameters along with the public health data that you have. With that, I say thank you.
Thank you, sir, for instilled in our minds the need to take care of our environment and maintain a balance in our nature. I invite Dr. Leela Ittiamma, Community Medicine Department, Government Medical College, Trivandrum, and SU the certificate and memento to Dr. Shekhar Lucas Kuriakos. Thank you, ma'am. Thank you, sir.
You gathered here today. Here we mark the
I invite Dr. Tom, Education, I invite our ma'am, please.
അമൂല്യമാണതിനസ്തിത്വം അജ്ഞാതമാണതിനാധാരം അമൂല്യമാണതിനസ്തിത്വം അജ്ഞാതമാണതിനാധാരം അനന്തമപാരമത്ഭുതകരമാണതിൻ വികസ്വര വൈവിധ്യം അനന്തമപാരമത്ഭുതകരമാണതിൻ വികസ്വര വൈവിധ്യം
പരിപാലിക്കും
ഞങ്ങൾ തിരിനീക്കുന്നവരേ ഞങ്ങൾ പ്രപഞ്ചചേതന വസുന്ധരയ്ക്കായി കനിഞ്ഞു നൽകിയ സമ്മാനം പ്രപഞ്ചചേതന വസുന്ധരയ്ക്കായി കനിഞ്ഞു നൽകിയ സമ്മാനം ഓരോ പ്രാണതലങ്ങളിലെഴുതിയ നിഗൂഢമന്ത്രരഹസ്യങ്ങൾ തിരിച്ചറിഞ്ഞൊരു ശാസ്ത്രമിതെന്നും തലോടി മാറ്റും വേദനകൾ നിതാന്തജാഗ്രതയോടരികത്താൽ കാവൽ നിൽക്കുന്നവർ ഞങ്ങൾ നിതാന്തജാഗ്രതയോടരികത്താൽ കാവൽ നിൽക്കുന്നവർ ഞങ്ങൾ കൂടെ നിൽക്കുന്നവർ ഞങ്ങൾ സർവേ ഭവന്തു സുഖിനഃ സർവേ ഭവന്തു സുഖിനഃ സർവേ ഭവന്തു സുഖിനഃ
Please be seated. Our principal, Lynette Madam, has always been a huge support to all our ventures. I invite Dr. Lynette J. Morris, Principal, Government Medical College, Trivandrum, to welcome the August gathering. I welcome our Vice Principal, Dr. Srinath Sir, onto the stage.
Honorable Vice Chancellor, Kerala University of Health Sciences, Dr. Mohan Kundamel sir. Respected Director of Medical Education, Thomas Matthews sir. Dean Research, Kerala University of Health Sciences, Dr. Shaji K.S. Vice Principal, Dr. Srinath. Superint MCH, Dr. Sunil Kumar B.S. Superintendent SAT Hospital, Dr. Bindu S. Other distinguished guests, delegates, students, a very good morning to one and all. Before I move on to my official duty, I would like to appreciate and congratulate Dr. Anuja and her team for having organized this 14th National Students Research Conference. I have been seeing the hard work that has been going on for the past couple of months to bring this conference into a reality. I congratulate the whole department. Now let me move on to my official duty. First of all, I welcome our Honorable Vice Chancellor, Dr. Mohan Kundamel sir, who has consented to inaugurate this conference. Despite his busy schedule, he always makes a point to come to our college, being an alumni of this college, and he always participates in all our activities. I welcome you most heartily, sir, into this conference. Next, I welcome our beloved Director of Medical Education. Sir is always busy, but still he has consented and made his presence in this and has consented to give his presidential address for this conference. We welcome you, sir, heartily into this conference. Next, I welcome Dr. Shaji K.S., Dean Research of Kerala University of Health Sciences. We welcome you, sir, into this Medical Student Research Conference. Next, I welcome Dr. Srinath, the Vice Principal of Government Medical College, Trivandrum. We welcome you into this conference of this student medical research. Next, Dr. Sunil Kumar. He is the superintendent of Government Medical College Hospital, and he's a neurosurgeon, and he has consented to come and grace this occasion. We welcome you, sir, for this conference. Next, Dr. Bindu S., who is the superintendent of SAT Hospital. She's a pediatrician, and she's also, besides being a busy person, she has consented and has come to grace this occasion. We welcome you to this conference. I also welcome each and all distinguished guests and delegates who have traveled far and wide to take part in this conference, and also all the students who have made this conference, without whom this conference would not have materialized. So once again, I welcome each and every one of you into this conference. Thank you.
These flowers, which are now presented to the guests, were prepared by Mr. Manoj, who is physically challenged. He is in wheelchair for the last 13 years. We thank him.
Dr. Thomas Matthew, Director of Medical Education, is a member of our community medicine family. So, it's an honor for us that he is here with us in this occasion. He has been a part of our journey from the beginning. It's our privilege to invite Dr. Thomas Matthew. Please, sir.
Honorable Vice Chancellor of Kerala University of Health Sciences and Kerala University, Dr. Mohan Kundumal, respected Principal, Research Dean, Vice Principal, Superintendents, HOD and Professor of Community Medicine, other professors, the Community Medicine team who is hosting this national conference, respected speakers, dear students. It's really a privilege and honor for me to be with you as we are witnessing the 14th National Conference on Students' Medical Research. Names are very important in research. I will just take my time to mention a few names who have been instrumental in making this an event, a history, and a success. This started as a conference in 2008 with the ample support from our Guru, Dr. C.R. Soman, and his Health Action by People, and Dr. Vijay Umar and Dr. Rajmohan taking the lead. Dr. Ramdas Pisharedi, another student of theirs who was the principal. The team, along with Dr. Leela Itiamma and Dr. Sara Varghese, they took up the challenge of continuing the tradition, making each conference a success year after year till 2019. In 2015, the KUHS also supported the program, took it up, and they owned the program as a university program under the leadership of Honorable Vice Chancellor, then Dr. M.K.C. Nair sir, and also Dr. Hari Umaran Nair, who was the Research Dean. This tradition has continued. Dean of Medicine, who is now the Vice Chancellor of 2 universities in Kerala, our own alumni and our own mentor, Dr. Mohan Kundumal sir, has continued the tradition, took up the challenge, supported us, along with the Research Dean, Dr. Shaji. There are a lot of other names also I would like to mention, but due to paucity of time. But this has been a dream coming true, which has progressed from through lot of hardships, difficult times, which of course my teachers like Dr. G. Shasi Haran, who is in the audience, will tell us. The superintendents, Dr. Sharmat, Dr. Nisaruddin, superintendents of SAT Hospital, Dr. K. Elizabeth, she herself a great renowned researcher, and Dr. Susan Udup. They were all helpful in bringing this workshop to this stage. So it is the right time to thank all of them, to uplift whatever they stood for, and for making research a top priority, not only in the medical college, in all medical colleges, in medical education, and also in the state. This was happening hand in hand, or even surpassing the efforts of bringing up research among faculty and researchers. Research among students was given priority, and those who are in the audience and those who are conducting this workshop, they have all been either trainees or trainers of these national conferences in the previous years. So it's a real pleasurable moment for us. We also would like to thank the organizers or the team for making this something much more than a conference. Like there are sessions, there are workshops. For this conference itself came as an offshoot of research methodology workshops for students and PGs in those years. So this is something which we are proud of, which we have given credit to, or which have led to lot of impetus in bringing out students into the realm of research and further objectives. So after remembering these past days where we used to stand here, we conduct the conference in the same hall. We had done this in the thick and thin periods of Nipah as well as COVID, also in various other modes. As part of the public health family, I extend my hearty welcome to the speakers, the participants, the students who have really yearned to make it for this workshop and this conference. And I hope that this message which these conferences highlight will help us to bring and take research forward, especially when the university is also very keen involving the private sector, other disciplines like dental, nursing, pharmacy, where a lot of research are going on. So I thank or put this to the credit that we appreciate the efforts of the Vice Chancellor, the Research Dean, and the university, who is also they have made this also as a priority. They have supported this. And together, I think we will lead this for much more research, much more innovations, and much more fruitful clinical and academic life. Thank you very much.
Thank you, sir. Now it's time for the most auspicious occasion of the day, our lamp lighting ceremony. I invite Dr. Mohan Kunumel, sir, to light the lamp. Let this be our guiding light throughout our conference.
Dr. Mohanan Kunnumal is a distinguished figure in the medical field. Sir has held key positions such as Dean of Medicine and Governing Council member at KUHS, with extensive experience including roles as Principal of Government Medical College Manjeri and Professor of Radio Diagnosis at Government Medical College Thrissur. Dr. Mohanan has earned recognition as the best doctor in the state in 2016. He is renowned for his expertise in radio diagnosis, also have guided 19 research papers and published 11 articles in international journals. A fellow of the Indian Academy of Medical Specialties and a former member of the Medical Council of India, Dr. Mohanan has been honored with the Dr. P.J. Alexander Memorial Oration Award for his outstanding contributions to the medical field. Now, I invite Dr. Mohanan Kunnumal, Honorable Vice Chancellor, Kerala University of Health Sciences, to deliver the inaugural address. Please, sir.
Good morning. എല്ലാവർക്കും നമസ്കാരം. President of today's wonderful function, Dr. Thomas Matthew, the Director of Medical Education, the Principal, Dr. Lynette J. Morris, Dean of Research, Kerala University of Health Sciences, Dr. Shaji K.S., Vice Principal, Dr. Srinath, Superintendent of the Medical College, Dr. Sunil Kumar, and SAT Hospital, Dr. Bindu, and the organizer of this wonderful function and Professor of Head of Department of Community Medicine, Dr. Anuja, eminent faculty members, teachers, and my dear students, especially the undergraduate students. It's a happy occasion, happy moment for me to come back to my college in the same stage where I stood in various capacities as a student leader, as a activist, as a teacher leader, now in a different form. This is a very important occasion for the university, and I congratulate everyone associated with the 14th National Conference on Students Medical Research 2024, and with your blessings, I declare this conference inaugurated. Today is 6th of April, and tomorrow is 7th, which is World Health Day, and it's a very important day for all of us. And the theme of this World Health Day is My Health, My Right. So, World Health Organization, WHO, declares that the health of each person is his right. And it is right also. And in 1948, when WHO was formed, on that day itself, it was said that health of every person is a fundamental right. And in fact, Indian Constitution, Article 21 says that the right for health is a fundamental right for human being. So this is a very important thing. But then how do you ensure health? So that is the question. And we believe that we are the people who are ensuring health. So what are the investments we have made? In India, you have got 700 medical colleges. In India, you have got more than 1 lakh MBBS seats. In Kerala, you have got 33 medical colleges. But is it enough? Or is it the only thing with which you can ensure health? And as we all know, the WHO definition of health is not absence of disease, but quality of life as well as mental, social, and physical well-being. So are you ensuring it? And how do you do that? And when the Health University was formed almost 13 years ago, it was said that it is the duty of the Health University to ensure health of the state. Are we doing it? We are creating world-class professionals that everybody agrees. The professionals created by the Health University, we have given almost 1 lakh certificates, degree certificates to our graduates. That means 1 lakh health professionals have come out from Health University who have become great doctors, who have become great nurses, who have become great paramedics. But then what is our contribution in creating knowledge? I should admit that our contribution in creating knowledge is very, very less. And is it only in Kerala University of Health Sciences? Being the president of the Association of Health Universities in India, we have got about 17 health universities. And none of the health universities in India has got contributed anything significant in creating knowledge in health research. And of course, the reasons are there, because none of the health universities have got a hospital. Nobody is owning a hospital. Nobody is having faculty. Whether it is the oldest health university in Bangalore, the Rajiv Gandhi University or MGR University, they're all just affiliating kind of office. And therefore, this has to be changed. We have been telling the government at the national level that this has to be changed. The colleges, the hospitals, which we are giving affiliation, should become part and parcel of the university. Otherwise, we just cannot do, cannot do research. But then in between, what will you do? You enable research in the affiliated colleges. So you help the affiliated colleges. But then you start helping the affiliated colleges, then there is something called audit. They say that how can you give government money to somebody else? Now we have identified government colleges. So you link with government colleges. Honestly, this is what we are right now doing. And this is why we are doing it in Thiruvananthapuram Medical College, the first medical college which continues to be the best medical college in the state. We are doing it in Thiruvananthapuram Medical College. This is why we are doing it. And I thank the Department of Community Medicine, the principal, and the DME for organizing this in a wonderful way. So, undergraduate students should come to research. Of course, everybody knows that postgraduate students should do research. That's why they are doing a thesis. And again, many people prepare a thesis with somebody's help, copying, plagiarism. And now we have come out with a plagiarism tool also. So these things were happening. And you cannot blame students because you don't provide them facilities. You don't provide them mentors. And suddenly you ask them to do research. So it's the duty of the university to provide facilities, to provide mentors, and provide training. And this is what we have been doing the last few years. Research methodology training we have been giving to the postgraduate students, and undergraduate students also we are going to give research methodology training. Online program has already been prepared by Dr. Shaji and team, so this will give. In addition to that, there must be some incentive, because all of us work for incentive, with incentive. So we are going to introduce a financial support for undergraduate research. 1,000 students under Kerala University of Health Sciences every year will be given a financial support of 10,000 rupees each, which we have decided. And I'm not officially declaring this because elections are going on. But everything is ready. The moment the election process is over, we will identify. Now, actually, we are going to open our website. So you can apply for that. And all the details will be set by Dr. Shaji, and subsequent communications also you will get. And this is a small start. This is a small start, so that we will, then again, PhD program. In fact, I think more than 500, 600 people are registered for PhD under Kerala University of Health Sciences. When I joined, it was only very few. Now 500 or 600 people are registered for PhD. And many of them will be excellent. I don't say everything will be good, but many of them will be excellent. And some PhDs have already been submitted. And I have charge of Kerala University also. In Kerala University, every year, we have got 500 PhDs coming out. I don't know whether anybody knows that, 500 PhDs. I don't say everything are good. You have heard about certain PhDs are pure plagiarisms. We all know that. But then there are excellent works, absolutely excellent works, especially in science, absolutely excellent works. And I heard what Idirajan was saying, that our children are going away. In fact, these children are going away because their excellent work is taken by Norwegia. It has been taken by Scandinavian countries. It has been taken up by US, and they are working there because we are not giving them any job. That's a different issue. But then, so the point is that knowledge is here. our students are good. If you give them an excellent environment, you will get an excellent result. And this will happen to Kerala University of Health Sciences. Excellent publications will come Kerala University of Health Sciences. And in order to publish, we are coming out with a journal also. Kerala University is coming with a journal, and in that journal, you will be able to publish. And of course, if you feel that it's a much excellent article, you can publish anywhere in the world. And for publishing also, we are going to support you. We have decided that the postgraduates who are going to publish their papers in recognized journals and they submit to the university, we will give them again a financial support. That also has been decided. So this is what little we are going to do in the available scenario. The real solution is that every university should have a hospital. Every university should have a researchers. But if that is not possible, we will assume that you teachers are our own teachers and you conduct research. Whatever way you need support, we will do. The students, even though you are in an affiliated college, we will consider you as our own student, and you conduct research, we will support you. And with these few words, I once again declare this wonderful conference inaugurated. Thank you.
We would be honored to have you, sir, to do the official launch of our souvenir. Thank you, sir.
Now we move on to our felicitations for the day. I invite Dr. Shaji K.S., Dean of Research, Kerala University of Health Sciences, to give the felicitation.
Dear friends, I'll make it very brief. Take this occasion to express some of my views. I think you heard from the Honorable Vice Chancellor that we are going to run undergraduate courses with research as an important part of the curriculum. And it might be tempting, and I'm sure some people will, because of curiosity and urgency, might start doing projects. But then you should remember that you should become scholars first. I think Dr. Santosh and Dr. Shekhar was mentioning about how important is that you should be in a position where you access the current evidence in great detail. Unless you know the cutting edge, you will be, permit me to say that, lots of rubbish gets published in the name of research. So we must avoid that. I'm sure Pratap, the orator, will talk to you about the importance of doing it well when you do research. And I take this opportunity to once more declare that the university and the Office of the Dean Research will be supporting you in every respect. Thank you very much.
Thank you, sir. Now I invite Dr. Srinath S., our Vice Principal, to give the felicitation.
Respected dignitaries, my dear friends, so I'm very happy to be here as a part of this academic feast here. And I congratulate Anuja and their team for already such a wonderful event. This is something different, like that. In all conference, there will be some topic will be dealt with the speaker. But here it's different that the students are more participated. And when you think about the research in previous years, it's made concerned with the postgraduates and some of the staff members. But here, it's something different. The students are motivated and they are organized to do some research activities, and I feel that they are doing extremely well beyond the studies. If you give something extracurricular and like this, they do better. And I hope that next year also this will be more academic, and maybe some staff members also should be involved, make them to present the topics also. Hope that this will be a good feast for you. All the best.
Thank you, sir. Now I invite Dr. Sunil Kumar BS, Superintendent MCH, to give the felicitation.
Respected dignitaries on the dais and off the dais, I am actually very happy and proud to be here because I see so many undergraduate students in the audience. The thing is that while we are studying MBBS, there are very few people and out of 200 students, 2 or 3 MBBS students will go for research. And from my batch, only 3 or 4 students was there, and now they become huge in the research, in the field of research. And it's happy to see the undergraduate students here. And I should congratulate all department and the organizers for conducting this one. And just one more thing to say, to the students, our concern regarding research and our help to that students is, I think it's not adequate. We are not helping them or not encouraging them properly. The trend is changing. Now it was the old thing, and now the trend is changing, and I can see the changing trend. And one more thing, it's difficult to get all this research. When we submit a paper, the paperwork is so difficult to get it signed from the authorities. The process is very long. It will take time, at least 6 months, 2 months, 3 months, 6 months. When we give a research paper for our board or IRB or ethics committee, it will take more time. We will have to cut short that time, and we should do in any way. It will be very fast, so that the student can start the research very early. And that's the thing I will have to say. Thank you.
Thank you, sir. Now I invite Dr. Bindu S., Superintendent SAT Hospital, for the felicitation.
Most respectful dignitaries on the dais and off the dais, and my dear colleagues and dear students. As everybody said in this event, then it is a special conference, mostly concentrating on the undergraduate students. And you all know that in this world now, the communicable disease and non-communicable disease new diseases are emerging, and this research work and evidence-based practice is very important. And I always have an admiration regarding the research people, and always this Anuja and Indu, and my Sara madam, because and Rajamohan sir. The basic things now during the pediatric classes, always I will think sir is remembering all the data and will tell the year of appearance, all these things. But evidence-based research and importance should be imparted to the undergraduates, and the interest for research should be there from the beginning. It should not come by the year of PG. So I wish this conference will be a wonderful thing, and it will be more useful to the undergraduates, and it will be, I appreciate and all the best wishes, and I thank the organizing team for giving me this opportunity, for giving felicitation for this function. Thank you all.
Thank you, ma'am. Now, I invite Dr. Anuja U, Professor and Head of Department, Community Medicine, Government Medical College, Thiruvananthapuram, to deliver the vote of thanks.
Respected dignitaries on and off the dais, after a gap of 4 years, we are here hosting the National Conference for the Medical Students Research. Research is the need of the hour, and such a platform imparts opportunities for young budding researchers. I feel honored and privileged to propose a vote of thanks on this special occasion. I would like to thank all the honorable delegates who blessed us with their presence, and I am thankful to all our speakers who made this day memorable and with their insights and knowledge. Words are not enough to thank their support to shape the conference. On behalf of the organizing committee, I convey my deep regards and heartfelt thanks to our Honorable Vice Chancellor, Dr. Mohan Kundumel sir. Even with his busy schedule, sir blessed us with his presence and all the support for making this program. Thank you, sir. At this juncture, I would like to thank Dr. Shaji K.S., our UG Research Dean, Kerala University Health Sciences, for his presence and his blessings. Thank you, sir. I thank our beloved DME, Dr. Thomas Matthew, sir. He has been constant support for this event right from the beginning, or when we thought of these things. Sir gave all the support for conducting this program. He has been guiding us and encouraging us always to achieve this. Sir, I express my sincere gratitude on behalf of the organizing committee. My special thanks to our principal, Lynette Morris Madam, who was a constant help and guidance that radiated a source of energy with us. We'll always be grateful to you. We will always be grateful to you, Madam, and thank you for all your support and help. Our Vice Principal, Dr. Srinath sir, Superintendents of SAT and MCH, they are actually supporting us for proceeding with these research activities, because all the research data collection are happening in clinical departments mainly. So I extend my gratitude to you, sir. An event of this kind cannot happen overnight. I have been fortunate enough to be backed with a team of very motivated, energetic, dedicated organizing committee comprised of all the staff and students of community medicine department who are actually restlessly working for the past 2 to 3 months to make it happen today. I thank all of you. Then we are all here, or we succeeded in coming up with such a program and making it a success because of our teachers who actually helped us to shape us like this. Some of the teachers, Sara Madam, Leela Itema Madam, Jisha sir, Rashmohan sir, Jayagita Madam, Vimala Madam, all of them came here to bless us. Thank you. Thank you, teachers. Thank you. Then our students, you are actually the leading force who are actually lead us to make all these things happen, because without your support we may not be able to do all these things, because you are the backbone of all these programs. You cannot translate wisdom and insight into another person. The seed is always there. A good teacher touches the seed, allowing it to wake up, sprout and to grow. With these words, I conclude my words, hoping that many new seeds may sprout at the end of these 2 days. Thank you. Thank you.
Thank you, ma'am. Now we have come to the end of our inauguration ceremony. Thanks to all our esteemed guests. Tea is being served in our food counters. Delegates, please ensure that all are wearing their identification tags.
being so much there for the students as well as whatever it has given me. So diving right in to the talk, we'll just discuss a little bit of the work that I've been doing in TIFR and then go into the need for why clinicians should be doing a little bit of basic science research. So this is the lab that I work in. It's next to the Arabian Sea. It's called Hutmund. So because it is literally a hut beside the sea, my advisor is Professor Vidudha Vaidya. She won the Infosys Prize for Life Science last year. She works on regulation of emotions in the brain and how circuits modulate emotion. She's the kindest and the nicest advisor that one can ask for, and it's on her behalf I'm presenting some of our data today. This is our team, and our team is an interdisciplinary team comprising of Dr. Darshana Kapri and Dr. Prachi Tiwari, who are engineers. Mukund Sharma is a chemist. Asta Angarika are biologists. Dr. Shashana, Dr. Ullas, Dr. Ashok Vaidya, and Dr. Vidya Vaidya are again biologists who are senior professors. So, and me as a doctor, we are a team of a wide range of expertise thinking about how the brain works. So we'll dive into today's story, which is on the horns of Ammon. So this is the Egyptian deity Ammon, which has horns like that of a ram. And this is how the ram's horns look. And this is how the human hippocampus looks. It's like the ram horns in the human brain. Now, what does this structure do? What does the hippocampus do? Early insights come from clinical studies on patient HM. So it is Henry Gustav Mollison. HM had intractable epilepsy, for which Scoville performed surgery to remove both hippocampi. Post that, a psychologist studies the patient and finds that he can remember all what he experienced in his early life, can't remember recent memories, can't make new memories. So this was early insight that said, this is an expert. I can think of my grandfather, walking with him, he was very small, I think lots of descriptions, but he's asked, is your father still alive? And he says, I'm not sure. Father had died 3 years back. If he watches a movie, he'll keep watching the movie again and again because he forgets what he has seen just before. So the hippocampus is a circuit critical for consolidating short-term to long-term memory. Now, we'll come to why memory. Why do we have something known as memory? And one philosophical take on the human system is whatever we are as human is wired on top of evolution as a time scale of growth and evolution, which is you have primitive circuits in a lizard that helps it escape from a stress. A lizard senses a threat, it darts. A lizard sees an appetitive fly, it darts its tongue. On top of that, you have the mammalian system where threat detection systems evolved, and now we have emotions on top of this for us to realize that our immediate reactions are threat detectors. But if it goes haywire, we end up with a whole lot of neuropsychiatric disease. So imagine a cheetah chasing a gazelle. Now the cheetah has to remember, once it sees the gazelle, it has to run faster. An adrenergic response comes in. So it's running, the blood supply to the muscles increase, energetics in the muscles increase, and it's running. Once it catches the prey, it has to remember the context in which it caught the prey, so it can get the prey again. Now think of the prey. That has to remember, okay, I'm going to run. I have to escape this particular organism. I'll run and escape, and then remember how I escaped. So in both contexts, you have memory being critical for the organism, being coupled to a stress response in this case, or an appetitive response in the case of the cheetah. Both of them include a change in energetics, because if you want the muscle to function, you subdue the gut. So in the periphery, stress responses modulate energetics. Our question was, in the brain, since it's opening up a window of memory, are energetics getting altered in the brain that helps you remember in a context like stress? So that's our principle, and when you talk about energetics, we can't not talk about mitochondria. Mitochondria takes in metabolites, pyruvate enters, TCA cycle, electron transport chain, ATP is synthesized. The mitochondria synthesize ATP and provide energy. Our question was, does norepinephrine, the neurotransmitter classically linked with stress, attention, sleep modulation, regulate bioenergetics in the hippocampus? And that's what we set out to answer. So this is the molecule. In the human, you have, is there a pointer? So in the human, there is a bunch of neurons in the brainstem which arborize extensively through projections. So imagine you smile. You have a facial nucleus which sends a projection out to your muscle, which is a simple projection to the muscle spindle. Here, this neuron branches out to so many regions in the forebrain that a single neuron fires multiple regions in the brain gets activated at once or inactivated at once. That is why most of the neuropsychiatric diseases, the drugs that act on impinge this system because it's a state-level change of function. So we went on to answer this question mechanistically, and this is where I want to drive the idea that when you have observations in the clinic or observations that you think about, to mechanistically answer them, one needs to look at animal models. So we chose our animal models of choice, which were, again, rat, that is a big white animal, and the mouse, which is very small. This is the rodent brain. As you can see, there's the olfactory bulb, the cortex, madam? Okay, I think I'll just, so there's the olfactory bulb, the cortices, the the cerebellum and the brainstem. And the rodent brain is much smaller than the human brain. It's much smaller than the human brain, but circuits are conserved. So the rodent is a good model for us to now ask the question that we want to ask. This is the hippocampus. It looks like two bananas in the rodent. And we use a cell culture system where we dissect out the hippocampus from embryonic animals. We mush it in an enzyme that digests it, and we plate it onto a dish. So we have taken hippocampal neurons and made a dish out of neurons. Now you can apply your drug, you can apply whatever you want to see how neurons respond. Why not do this in the animal? Animals, you have neurons, you have glia, you have oligodendrocytes, you have blood, you have ECF. Here you've created a reductionistic model where you can answer how do neurons respond to norepinephrine. So reductionism is critical for looking at function on cells, which we can later scale up to ask what it does in the animal. This is how it looks, beautiful neurons. These are the cell body and the long processes, the axon, and around the cell body one can see the dendrites. These are neurons of the hippocampus in a dish. Then we come in to ask, okay, embryonic day 18.5 you culture neurons, you let them grow till DID9, then you apply norepinephrine for 8 hours. And what we read out for is mitochondrial DNA. Mitochondria is endowed with its own DNA. The nucleus also has its own DNA. We compare a gene from the mitochondria and see how many copy numbers of that gene are present relative to the nuclear gene. This gives us an idea about how many mitochondria are there in the system. So on cultured neurons, this is the first data point. Control, you can see with respect to control, 100 nanomolar norepinephrine gives you an increase of mtDNA levels, and 1 micromolar gives you a further increase of mitochondria in the system. So when you bath apply norepinephrine, neurons are creating more number of mitochondria. Our next question was, does it translate to function? So we then looked at ATP levels. So we use a luciferin kit, which is you lyse the cell, ATP reacts with D-luciferin to give a bioluminescent compound. We assessed luminescence and we found that ATP levels also increase in a dose-dependent manner with norepinephrine, which is norepinephrine not only makes new mitochondria, it makes new functional mitochondria that the cell is more energized. This is a novel finding which has only been explored in the periphery. This is the first time somebody has looked at energetics in the brain regarding monoamines, which are key regulators of emotional responses. So we have done to see that this does not hold true in cortical neurons. Dopamine and serotonin do not do this in hippocampal neurons. So it seems to be specific to the circuit. It seems to be specific for norepinephrine. Now, just to extrapolate, knowing that there is norepinephrine, dopamine, acetylcholine, serotonin, how these differentially regulate circuits to alter bioenergetics is a question we are chasing further. So if you have systems which can differently modulate circuits and make one more energetically active than the other depending on context, in a combinatorial manner, we can now drive plasticity, which is changes in these cells at different places depending on context. This is the idea that we will be going to further down the lane. Then we wanted to ask, what is the receptor? This is where we use pharmacology. So the drugs that we learn for MBBS, we use it to derive function in the brain. So we come in with propranolol, which is a beta blocker, and we ask, if you now have control, norepinephrine mtDNA goes up. With propranolol, there is no baseline effect, but if you treat propranolol and then come in with norepinephrine, the effect goes away. Same for mtDNA as well as ATP levels, hinting that it is a beta adrenergic signaling that's driving this effect downstream of norepinephrine. We asked multiple different questions down the lane, but one critical question that we asked was, what is happening to mitochondria being produced? So you want to produce something, you need to now first transcribe it, translate it, and then put it into the mitochondria. So we asked whether transcripts coding for the electron transport chain complexes go up in our system. And in 30 minutes of applying norepinephrine, you have lots of genes that code for the subunits going up. So 30 minutes, transcripts are up. 8 hours, mitochondria are up. They are more functional. So there is a driving of a gene expression program that upregulates energetic function only in the hippocampus when norepinephrine is on board. Now, do these effects hold true in vivo? Now we know the dish is an artificial system. Now, if you upregulate norepinephrine in an animal in a physiological context, you get these same effects. So we came in with atomoxetine, a drug used to treat ADHD, that blocks reuptake of norepinephrine at the synapse. What this drug does is you imagine a noradrenergic neuron with multiple projections everywhere. At all those projections, reuptake is inhibited. So at all synapses where NE is supposed to be released, you have upregulation of the monoamine function. And with atomoxetine, we came in with the paradigm. With atomoxetine, we see an increase in mtDNA on the first graph. On the second graph itself, 3 injections of atomoxetine gives us a rise in ATP. When we gave propranolol in drinking water, the primary effect was abrogated, saying that whatever if we saw in the dish, we could get it in the animal, which is a rarity in translational science. You may find some phenomena in the neuron in the culture which holds no real relevance in the animal. We were fortunate to stumble upon a finding which is relevant across scales. Now, just one, why not do this? Why go for cultures when you can just do this in the animal? Just imagine testing all the receptors, all the monoamines, all the regions. You have to sack animals batch after batch. The culture gives you a high throughput system to screen for your molecules and then come to the animal. Second, you want to tease apart what is downstream of the receptor. In culture, you can come with multiple blockers and ask, okay, is GS signaling affected? Is cyclic AMP affected? Is a transcription factor affected? By in culture studying pathways. So that's why a culture system still holds relevance when you can do all of this in animals, because of want of time I've not added. Now what are the functional implications? Okay, mitochondria is going up, function is going up in the hippocampus with norepinephrine. Story is nice, but what does it mean to the system? So we came in with the context of memory. This is the hippocampal circuit. The input of the hippocampal circuit is what is labeled as MPP and LPP, talks to one set of neurons in the dentate gyrus, which talks to another set of neurons, which talks to another set of neurons, which sends input back. Flux of info from all the sensory cortices through the hippocampus is critical for declarative memory, which is memory of your events. I went for a walk in the evening, I read something in the evening, I did something later. That is declarative memory. It's also critical for spatial memory. Now, in a rodent, you can't ask declarative memory. You can't ask the rodent what it did in the evening or what can you remember. You can't. So we come in with spatial memory because in the rodent, declarative memory becomes a problem. So spatial memory is a key finding by John O'Keefe. They won the Nobel for this. In CA1 neurons, a bunch of neurons in the hippocampus, a rodent in an arena maps the space in a single neuron level, which is you record from a neuron and you ask the rodent to arrange the territory. It will go to one spot, the neuron lights. If it goes away, the neuron does not light. So there is a map of the surrounding in the region of neurons which is specific for the location. It's an incredible system as to how when something sees a field, it can map the field directly into the hippocampus. Humans, this has been difficult to test because humans, you can't ask a patient to run around Trivandrum and navigate space and say there is a pathological lesion. The reverse has been done where hippocampal volume in taxi drivers who are able to navigate better have been seen to be up. So the human evidence on this is correlational because we can't do causality with this. A declarative memory, we have great human evidence, but not rodent evidence, highlighting the significance of translating between systems when one wants to ask a particular question. So now we'll check. This is our apparatus. This is all. We have stuck these shapes to buckets, PVC pipes, and we have put it around a maze. There is a hole in the end of the maze, and we put the rodent in the center. The rodent is supposed to learn from the shapes that the escape hole is there. So we put the rodent, it will see the shape, and it will learn that for it to escape, you need to go in a particular direction. So we handle the animals, habituate, we train, and then we finally test. This is how it's on the first day of training. So it's looking everywhere. The escape hole is below. It's not able to escape. So can you play? This is when it has learned. Now watch, it looks that way, sees the shape and directly goes to the hole. So the animal has learned that that is where the escape hole is. So the percent time, this is after learning. Then what we do is, the final test day, we remove the whole. And then we ask, is the animal spending substantially more time in that quadrant? So after training, on the test day, we take the whole away and ask, is the animal spending time in that quadrant? And our initial paradigm works. This is the time spent in that quadrant in the trials. And on the final day, you see chance is 25. All the animals are spending about chance time in the quadrant. So our paradigm is done. Now we come in with our drug, and we see that time spent in target quadrant increases when you give atomoxetine. We had knockout animals which were deficient in mitochondrial function. They could not make mitochondria. So the ideal experiment to do is, animals which can make mitochondria if you give atomoxetine, what happens? Animals which can't make mitochondria if you give atomoxetine, what happens? We could not do this experiment because the knockout animals were deficient baseline. They did not learn. They were just running around the cage. Which is why, when you think of questions, even if you have the tools have to be used appropriately. Your knockouts may be wonky because they're developmental knockouts. Whatever the gene does is not done it functionally during development. So this is where we went with a correlational approach, where we then looked at mtDNA levels and ATP levels and saw, okay, both of them are going up with atomoxetine, and we cross-correlated these to find that mtDNA and ATP levels correlate with the time spent in the quadrant. So better the animals learn, more ATP and more mtDNA in the hippocampus. Then we saw that the correlation is more strong in the group that were given atomoxetine. This gave us correlational evidence of something which could hint at something causal, but we don't establish causality with this. This is where we are at in our work now. So what are the ramifications of this work now? We want to take this work into asking, if you have traumatic brain injury model, in a stroke model, in a hypoxia model, how would atomoxetine now give you an upregulation of energetics in the hippocampus and give you either protective effects or pro-cognitive effects? And one area that we have working in the lab now is early life stress. So this is a rodent which is bedded in a nice cage. Below is a mother rodent which has to take care of the pups in a deprived cage. What we see is that if you raise the pups who are raised in the deprived cage to adulthood, they become anxious and they have despair-like phenotype. So early life stress in humans is linked with anxiety and despair in the adulthood. Early life stress in the rodent recapitulates some of these findings. And if you look at the hippocampus in these animals, this is the control with early life stress. The beautiful arbors that you saw in the first image vanish. The tree is not as full, hinting that there is some hippocampal deficit with early life stress. What in our lab we are trying to do is reverse this effect with the mitochondrial boosters. Getting our work that norepinephrine increases mitochondrial bioenergetics. Now can you boost mitochondria itself to reverse some of the pathology that affects hippocampus? We have promising results which Pratik is working on, and we'll be publishing that next year, which is quite relevant for translation from a nutritional perspective. Can you boost nutrition? Can you supplement nutritional mitochondrial function in the early life to save some of these children who've gone through early life stress? This is the angle we are working at. We are far from any preclinical validation, but it's a promising area of work. So finally, that is the work, and we are talking about how we were able to trace a phenomena in the cell to a function in the brain, that is cognition. We note that we have not been able to get mechanistic insight about how mitochondria is regulating cognition, which is how it is with any emergent phenomena that one studies. What happens in the level of neurons? What happens when they talk to glia? What happens when they talk to oligodendrocyte? What happens when they talk to the ECF? What happens when the brain talks to the liver? What happens when the kidney talks to the brain? What happens when the heart talks to the brain is emergent. At each level, there is something to be learned at that level, but if you know A, B, and C, you don't know A plus B plus C. That is the problem of physiology. That is the problem with medicine. You know the components that make up a system. You know the components very well. You don't know what comes out of the component. And in the human physiological state, it's across multiple levels of emergence. That requires one to study each level for what it is. So I don't claim that we have solved X, Y, Z, but at the emergent level of at least neuron to circuit, we have some insight. Finally, my last slide is incremental, rigorous. We have lots of time that clinician scientists spend. Not everything works because of emergence, but observations and phenomena are in the clinic. The lab does not have observations and phenomena that we can gain biological insight from. So if you have ideas that link mechanism, we must use clinical models. You can inform biologists or do some biology to unearth mechanisms, it tell you about treatment possibilities and help you understand biology. The reverse contribution is more likely because with emergent scales, treatment is difficult, but gaining new biology from clinical observations is something that is possible. So lastly, I would like to thank my primary mentor, my go-to Dr. Karta sir, and Karta sir is somebody who has been a mentor throughout my journey. Whenever there is a lack of faith, I turn to Professor Karta. So I want to thank Karta sir, Asher sir for all his clinical help. In the second year posting, he said, it's up to you to decide whether a place you're at is hell or heaven. And you decide it's heaven, it becomes heaven. So and Aravind sir for reminding me that finally all that you do is for the benefit of the people. So these are my clinical mentors, and this is something that I got through my journey at Government Medical College Trivandrum, and this is final acknowledgements to my institute. I've already said it in the beginning. Fatima madam, Doris sir, Devika madam, Aju madam, Vandana madam, I'll name everybody because I want to know Umesh sir, Geeta madam, Lakshmi madam, Indu madam, Sindha madam, Anish sir, Libu sir, Anil Kumar sir, Tony sir, Indudi madam, Silga madam, Sharada madam, Anna madam, Noble sir, Sindhu madam, Thomas sir, Arun sir, Jayan sir, and Arna madam. All of them have not only provided me personal help, but when we started the student research organization, the doctors in the super specialty clinics, without treating us like undergraduate medicos who don't know anything, respectfully helped us mold as researchers. So Noble sir, Thomas Ives sir, Sindhu madam, and they all guided student research projects, and if we went to them and asked, can you help us, they outrightly helped us. So I end with this, is that this college will provide you everything you need if you ask for it. It's been a fantastic journey in Trivandrum Medical College, and I'm proud to stand here as a graduate of this institution, to have gained so much from this institution, and I hope that I can someday give something back to this grand institution, to the people who have made not only my lives, but the students here, a memorable and a cherishable experience. So thank you very much, and that's all from.
Thank you for the talk. We are sure that this session was inspiring for the young minds present here. I invite Dr. Indu PS, Professor and Head of Department, Government Medical College, Kollam, to present the memento and certificate to Dr. Amog. Thank you, ma'am. Thank you, sir.
Moving on to the next session, we have Dr. Pratap Tarian. Dr. Pratap Tarian, MD, MRC Psychiatry, is a distinguished professor of psychiatry at Christian Medical College, Vellore. He leads the South Asian Cochrane Network and Center and is renowned for his expertise in systematic review authorship and editing within Cochrane collaboration. Dr. Tarian plays a pivotal role as a program partner for the Effective Healthcare Research Consortium and holds esteemed positions at Liverpool School of Tropical Medicine and University of Malaya. As an associate editor for trials and contributor to various medical journals, he significantly impacts the field of evidence-based medicine. Moreover, Dr. Tarian actively contributes to Clinical Trials Registry India and serves on the scientific advisory group of the Indian Council for Medical Research, demonstrating his commitment to advancing medical research and practice. Today, Sir is here to orate to us on the role of reliable evidence in informing contextualized health decisions. We invite you, Sir, on the stage.
Good afternoon. It's a pleasure to be here, and I'm particularly grateful to the Dean of Research in KUHS, who was my batchmate. We went for the exams together. I almost failed, he passed. But we did pass together. I'm really surprised to see where he is today. Very good. Good job. So what you listened to last time is fantastic because it tells you the gamut of research that happens. And science is cumulative. So what was inspiring to me was the passion with which the previous speaker spoke. And somebody who speaks with that much passion is clearly interested in research. Unfortunately, when I was a medical student, I couldn't give a toss about research. I didn't know anything about it. And the reason I got into research is when I became a clinician and I had to answer clinical questions. When I was in the UK, I found people with schizophrenia lying in the wards for months on end. And I asked them, listen, in India, if they're not responding, we've tried everything, at least we'll give them ECT. So then Cochrane collaboration was starting off, and I was asked to answer this question, doing a systematic review to see, will ECT work? That is how I got involved in research, because I wanted to answer a question. And what I will cover in this oration is 5 interconnected themes aimed at medical students. Some of you may know this, but I'm trying to put it all together. What constitutes reliable evidence, clinical evidence that is? What are the levels of clinical evidence, and what are the study designs and outcomes which determine the level of evidence? And the role of evidence synthesis in informing health decisions, and how do you contextualize evidence which everyone says you should do to decide, do you want to do it? And finally, let's see how we can utilize this in our day-to-day work. So, the nature of evidence. Evidence actually refers to verifiable facts and data that supports whatever you're doing. However, over the past many years, you've realized that the sources that people use for evidence varies. And in today's world, you have words like alternative news, fake news. And now that you have the rise of AI, we are in for a nightmare. Unless we have some basic idea as to what is the kind of evidence that we want to actually improve clinical outcomes. This term has been bandied around for a long, long time, more than 30 years, and it actually has a very good premise. It's the way you can integrate research evidence with your clinical expertise and the values of your patients. So if you look very carefully here, the clinician is at the center of evidence-based medicine. But without the evidence that you can get from reliable research, the clinician flounders is just experience. So it's a good way I think we should start. I don't know if anybody wants to answer this. How would you define what is research? What's an accepted definition of research? I think it's a good question to ask, no? When you're talking about evidence and research. What is research? Well, it's commonly defined as the attempt to derive generalizable new knowledge or to confirm or refute existing knowledge. You're saying something doesn't work. But you're using this by addressing clearly defined hypotheses and using rigorous scientific methods. Are you happy with this? One of the first things I want to tell you is, do not accept anything at face value. Whoever says it to you. Ask yourself, what is wrong with this definition? I have a problem with it. It doesn't tell you why are you doing research. If you don't know why you're doing research, you'll end up with this. Some of you, not many of you, will be old enough to remember, this is the doc of doctors on trial after Nuremberg, after World War II. He's a German scientist. Remember at that time, German scientists had come up with the first ethical guideline. And they had a hypothesis that there is a race that is inferior to them. And they used scientific methods to see whether torture, deprivation, what are the effects on the human body. This is also research. But clearly that's not what we want. So I'd like to redefine research as an attempt to derive generalizable new knowledge, etc., in order to understand the human condition, which is exactly what you're trying to do. How do our neurons work? What are the connections? And we also do epidemiological research to see what is normative data. And to maximize the methods to maximize human potential, which is why we use analytical research, translational research, health systems research, and qualitative research. And of course, we use scientific methods. Now you may well ask, living in a country which is so dependent on faith, what is the difference between evidence from science and faith? You're allowed to ask this question. And often when I do, I get this answer saying, faith is believing in something without the need for evidence. I totally disagree. I actually believe that scientists and philosophers are trying to answer the same quintessential questions. Who are we? Where do we come from? People of science use the methods of science. What are we doing here? People of science use the methods of science. Then there are other questions where we diverge a bit. Where do we go from here? People of science have decided we're going to destroy this planet and go and live in Moon and Mars and stuff like that. That's why we have astronomy, rocket science. Philosophers answer that differently. And one question we are increasingly asking, who's going to clean up after us? So we have ecological research, environmental sciences. So what differs is the methods that we use to arrive at our conclusions and the level that we say we are sure this is the truth. But even having said that, we'll realize that the truth keeps changing as our knowledge increases. And also keep in mind, scientists also have faith. I don't think any one of you are structural engineers, but you're very comfortably sitting here with many floors above you, confident that engineering will not let you down. When you hurtle down the highway at 140 kilometers in a German car, you know nothing about what's under the engine, but you have faith in science. Right? So scientists have faith in science. And at one point in time, scientific research was meant to be a sacred activity, like philosophy. And scientific researchers are traditionally considered as seekers of the truth. Therefore, research integrity was a natural consequence of this tradition. But the problem now is, if you want evidence to guide clinical practice, you have to ask yourself, can the evidence be trusted? And we now know through many, many publications that a lot of publications cannot be trusted. And our job is not to accept that as a fact and figure out why is it so. So I wrote an article some time ago which summarized what we knew. The first problem is that there are vested interests. Of course, we know that industry has got a lot of vested interest in profit. But what we often don't realize is academia has also got entrenched beliefs, which will not allow a young researcher to question those beliefs. You'll be a pariah. That is also a problem. There is unnecessary, inappropriate, or poorly designed and poorly reported research. You'll read it, you'll believe it, but it will not help your patients, right? And many of these publications are designed to deceive you by the choice of what dose a comparator gets, when are you giving it, just to make sure that there's no equipoise. It is stacked up to fail. And one of the biggest problems I see even today is such a lot of over-reliance on p-values. And statistics can be easily manipulated and report your results in a very selective manner. And there's also a lot of undisclosed conflicts of interest and ghostwriting. I don't know whether you know what the meaning ghostwriting is. I used to believe it was the head of a department who had nothing to do with the paper who claims wants to be the first author. But that's not a ghost. The ghost is a person who had nothing to do with the study but wrote the paper. It's usually a PR company for a drug rep. They write the paper and it looks like some famous guy wrote the paper. And everybody believes it, right? And there's another term called disease mongering, manufacturing disease when you've saturated the market for your drug. When I studied, the cutoff for hypertension, diabetes, cholesterol were all much higher than it is today. When drug companies realized that we have saturated the market, we need more sick people. So they invented pre-disease, right? The problem is the drugs that work in disease conditions don't necessarily work in pre-disease conditions because your risk of having those outcomes is very low when you're in a pre-disease condition. But companies made profit and doctors get on board. You go to your doctor, he'll say, no, borderline, you better start this drug. Tell him, sorry, I'm not going to take it. I'll try something else. That is our job as clinicians, to be gatekeepers between what people want us to do and what we should do. Right. Now, I wrote this for the Indian Journal of Medical Ethics because I believe that science and ethics are inseparable. You can have ethically conducted research which have no scientific merit. To begin with, that is unethical. That's an important thing for any university looking at research to see how can we ensure that research and science go hand in hand. The other thing to ask ourselves, we are all so keen to have more and more research done. Long time ago, just after the Cochrane collaboration was formed, Doug Altman, who was one of their seminal statisticians, said, we need less research, more relevant research, right? So Cochrane's founders all got together and looked at a lot of papers in high-impact journal and divided them into 4 quadrants. You can have stuff like what you're trying to do, which is to advance scientific knowledge. Or you can have stuff which actually translates into practical applications. Or you can have both. But the vast majority of papers, 85%, are pure waste. They do nothing. Why? Why are they being published? We all know the reasons, right? So if you look at Lancet, and I urge you to do this, there is a whole series of articles addressing each stage of wasted research and what you can do to overcome it. The first one is, the question you should ask should be a relevant question. Most of the time we ask very low priority questions, and questions not relevant to your community, right? Or probably depends on who's funding it. The second thing is the importance of outcomes. Now, when you choose an outcome, you look at some other paper and say, they chose that outcome, I'll use the same outcome. What you should ask yourself is, who is that outcome going to help? If your aim is to improve health outcomes, then those health outcomes should be patient-related health outcomes, not clinician-derived health outcomes only. The third thing is, before you do anything new, do a systematic search to see what do we already know. Then decide what are the gaps that I need to address. That's one of the first things we have to do. The second thing is, when you decide you want to do something, every research question has an appropriate design that will reduce the amount of bias in your results. Will give you true results, right? So first thing you have to ask yourself is, I want to do this, what is the best design for my study? And then the next question is, when I report this study, what do I need to have? Thing is, if you excluded so many people because they don't fulfill your inclusion criteria, then the results are not generalizable. They're very, very select. So people need to understand this when they design their research. The third thing is, research committees and ethics committees have a major role in how good research is. We'll talk about that later if there are questions. Finally is that many people never publish they go to conferences, but they lose interest in the results because it is not very exciting. Or if they do report, they report selectively. Some parts of the data and not the other parts of the data. And more of these interventions don't describe exactly what they did. So nobody can replicate it. And many of the outcomes which you actually wanted to do, you don't report because they're not statistically significant. So you don't then look at what you've done and say, okay, where does it add up to the overall evidence? So there are a lot of reasons why. You will not know, can you trust that with your mother's life? We are all involved in this. So I'd like to start with research saying, no matter how much pressure you're under, this is an important lesson to begin from the beginning. There is a slippery slope from ignorance, error, not getting caught, getting braver, and conning everybody. And when will you get caught? when you start publishing in high-profile journals. The history of science is full of that. You trace people back and you'll find their very first research paper was also wrong. It's a career of research. And even in my institution, I know one of my juniors was at Duke University. He got caught after he started getting NIH grants, huge amounts of grants. Happens to everybody. Be careful. Research can get your career burnt and you will kill other people. The problem is we need evidence. You know what happened during the pandemic, no? Hydroxychloroquine, this thing, that thing, right? People will die if you don't give them the right treatments. So for better health outcomes, we need reliable evidence, and this evidence should be relevant, it should be very focused, it should have studies addressing that question, and those designs should be appropriate, and the reports should be such that you can get a reliable answer. We'll focus a little on that. Then you should have complete evidence, not just one study, but all the studies addressing the same question. And then we should look and see, are the methods of all the studies such that you can trust the results from all of them, or are some so bad that it's going to skew our results? Then we also have to make the decision, is it statistically significant by a p-value, or is it likely to help you, and by how much? And how sure are you that it will help you by that? That's the question we want to answer. And then when we look at all the synthesized evidence, we need to see what is the overall effect. Is it saying that this intervention is much better than that? Are all the studies saying the same thing, or are some saying different? And if so, why is it working differently in another study? And once you know all the answers, you'll say, okay, use it, it helps you to reduce death by so much, I'm very confident of it. Then Shaji will bring it to his research committee, or the medical superintendent will say, should we use it? And there's a whole other thing, series of events which take place. The evidence is there, but can we afford it? Do we want to use it? Do we have other alternatives? There are a lot of other things that come into place. So when you're looking at the levels of evidence, people always think that RCTs are the top. No, not at all. It depends on what question you're trying to ask. Most bias means what? It's not that if I have a case series, it didn't work for that person. He's happy, he got better. The problem is if I start claiming everybody has to use that, then I need more rigorous standards. Then you have to have a control group and things of that sort. So for every question that you're asking, there is an appropriate, best evidence design. And over and above that is the cumulative evidence from all other studies addressing that same question. So this is what we mean by levels of evidence. It doesn't include all designs. For example, an equally important part of research design is qualitative questions. When you're asking people, what do you feel about what's happening to you? Equally important, because it's their reality. And there are two paradigms here. The quantitative paradigm believes that reality is what is more important, it is very subjective. And what that person believes matters. And then in this paradigm, there is no one truth. There are multiple truths. And it depends on who you're asking and what situation they are in. So these are equally important. You can have a treatment, you say everybody should have DOTS for TB. Then you'll find that some people don't take DOTS. You think DOTS doesn't work. Actually, DOTS may work, but the problem is this person feels stigmatized by going to a DOTS center. So you can find out why are you not going to a DOTS center. Right, so both paradigms are extremely important. One is the quantitative paradigm is to generalize and to predict, whereas the qualitative paradigm is to contextualize and to understand reality. So I'm going to give you some examples of why you can combine both in the work that you're doing, where you're trying to not go from having a theory and coming to a hypothesis, but start understanding things and then use that to create a theory, right? So this is a postgraduate thesis that does it need to be enabled or? Right. One of my postgraduates published this theory, this paper in the British Journal of Psychiatry during the MD thesis. And it became part of the question that we were asking, how common is postpartum depression in the community? How common is antepartum depression when you're pregnant? And does becoming pregnant protect against depression or increase the risk? Why do they become depressed after childbirth? There could be hormonal, cultural, multifactorial reasons. Are there protective factors? Are these socio-culturally determined? These were the questions we didn't have answers to for our community. There was literature elsewhere, right? But none of the local community people were even bothered about postpartum depression. They thought that, oh, this is a lot of women. Women become depressed. Actually, some felt it has an evolutionary advantage because they can take a break, right? So then the other question is, how do you manage them? Pharmacologically or psychologically or socially, right? So we started a design where we use sequential, exploratory, qualitative and quantitative methods. We first did a study in the local hospital in our literature, looking for what are all the established guidelines from abroad in India. Then we did a cross-sectional study to see what would be a sample size that we might need to study. Then we did focus group discussions with villagers, health visitors to find out what are the potential cultural reasons that we could have. And we came up with a list of risk factors. We did a cohort study. We assessed 359 women in the last trimester of pregnancy and after delivery, 6 to 12 weeks. We did a clinical assessment of depression by a psychiatrist, and then we assessed risk factors before and after. Apart from the usual risk factors, we added in some cultural ones. Not getting along with your in-laws, your parents, not having any help at home, being very poor, wanting a boy, and being disappointed, which is what our people said, these are problems for us. And then when we did our results, right, we were able to see what is the prevalence of antepartum depression, first column, 16.2%. What is the recovery rate? That for them, childhood was a good thing, they recovered. And then we had a group of people who were depressed before and after, chronically depressed. And we got our incidence from subtracting the remaining. These are people who were never depressed before, only in the postpartum period. Now obviously the risk factors will be different for the incidence and for the prevalence. So we looked at the incidence risk factors, univariate analysis and stuff. First of all, it's important to realize from a clinical prevalence perspective, if you are depressed before delivery, there's a good chance you'll continue to be depressed after also. So that's an important thing clinically. Second is, when you look at the logistic regression, these 5 factors had odds ratios more than 2, double the risk, and all together, put them together, identified 95% of this population. So these are the factors which are modifiable. And we did some other studies as well, trying to change attitudes of villagers about the male child. Of course, that doesn't work, because the men will say, if this woman is accepting me or telling me Y chromosome and all, if she would accept my Y chromosome, there'd be no problem. You can't talk to men. But we also discovered through focus groups that financial improvement for women will change the attitudes of men towards them, because then they're no longer considered a burden. So these are things you can learn from community work using qualitative work. The other thing we found was, we were in our department dealing with a lot of violent people. You know that, right? We have 300 patients in the outpatients. You're a duty doctor. You go there and will be trashing the place down. 45 minutes, 1 hour will go before you can get him down. So we wanted to look at this as a department. That's an important thing. If you want to do good stuff, everybody gets involved. Offer everybody authorship, whoever wants it, but you take part in the study, right? So the first one, published in the British Journal of Psychiatry, was again a community. All of us were co-authors. We looked at haloperidol promethazine, which all of us were using, versus lorazepam. And the second one, we looked at haloperidol promethazine versus olanzapine. This got published in the BMJ. Now, the interesting about all of this is that at the time of doing it, the NICE guidelines, and everybody was giving different things, but NICE guidelines said use olanzapine, lorazepam, right? So we thought we will do a trial, but when you look at the literature, we found that most of the existing studies are sponsored by industry. They all use the rating scale to assess the outcome, overt aggression rating scale. I had never heard of it. When I looked at it, it's a 21-item scale. If you go to an emergency department, someplace hitting everybody, and ask them these 21 questions, you know what's going to happen to you. We said, this is not an outcome which is relevant to us. Moreover, they had excluded everybody with comorbid conditions. We can't do that. We have to treat them also. And apparently patients signed informed consent. You're wondering, which kind of patient are you talking about? Our patients are not going to, if they give you informed consent, they're manic, and they're saying you do what you want with me. Not valid. So what we then did was, we did a pragmatic randomized control trial, which was, we excluded nobody. If the doctor says he needs an injection, he's potentially included, and his relative has to agree, right? We had the routine work, what we normally do, we did. And we had no sponsor. It cost some 10,000 rupees per study. We still did randomization, blinding, everything, just like you would normally do for a randomized controlled trial. And we chose outcomes that our patients and our nurses and our junior doctors wanted. So what we did was we finally, for the first study, we got a patient, an MSc nurse to ask patients who bring disturbed people, what should we do for your patient? Your relative is so disturbed. He said, sir, he hasn't slept for 5 days. I believe if he sleeps, he'll get better. We asked our junior doctors, what do we want? They said, sir, within 15 minutes, he should be out. I said, what do you mean by out? Said, he should be not disturbing anybody, you can sleep, but he should be like that for 4 hours, so I can finish my OPD and come back. So that was our primary outcome. Tranquil or asleep at 4 hours. We defined it, and then we had many secondary outcomes at various points in time, and we did all the blinding and all that stuff. This is a good design, it's worth looking at. And when it got published, the NICE guidelines came out, and they said, we know that haloperidol, promethazine, and our sister trial using midazolam in South America, are safe, but we have not used it here, so we can't recommend it. Good, that's contextualizing. They are not taking evidence from us. Good. Then we did the next study for versus olanzapine, which BMJ did. And there also we did the same thing, and they chose tranquil asleep at 15 minutes and 4 hours. This time, we did inter-rater reliability using videotapes, tranquil asleep, how disturbed, all that stuff, to improve the validity of our recordings. Both times, it showed that haloperidol promethazine is superior to lorazepam and olanzapine. For outcomes, we are interested in. We want the fellow asleep immediately, should stay asleep there. Doctor should not have to be called back. Those are relevant outcomes for our outpatient departments. In the West, they don't want people to be sedated. They want people to be alert. They don't mind sending doctors back, right? Those are different outcomes. But, interestingly enough, when the next monograph came out, 2015, they now are also recommending haloperidol and promethazine. So here I've demonstrated that the river of evidence can flow both ways. We can contribute to global evidence. If you contextualize, because they also need, many other countries also find it useful. So from this I've learned that evidence-based medicine is a myth. It assumes that there is reliable evidence always, and that evidence alone means you do it, right? And it assumes that evidence will be available, affordable, applicable, and that's what you want. But evidence-informed healthcare could be a reality. It acknowledges that there may not be good enough evidence, but at least you need to know what is the evidence to decide what you want to do. And it acknowledges that even if there is good evidence, it has to be contextualized based on the benefits, harms, costs, preferences, and any other alternative you want. So that's what we learned from these things. Evidence only informs your decision. You make the decision. Right. Now, I want to give you another reason to, and many of you will know this, but some of you won't. And for you, it will be an eye-opener. I'm going to use an example of a clinical problem I had when I came back from the UK, just after I got involved with Cochrane. A friend of mine called me and said, listen, I lost a child before, and I'm going to probably, my obstetrician says I'm at risk of premature delivery. The child may die of respiratory distress. And guy is saying, try some short steroids. I'm very scared of, this is in 2000 something. I'm scared of steroids. Do you think it'll help, or do you think it'll harm? Now, where will you go for it? First thing I did was ask my professors. It was brand new, nobody really knew. They gave me their opinion. Then I asked drug reps. That's where normally people ask, no? Steroids, they also didn't know. Then I said, I will find the evidence myself go to PubMed. But you know, if you go to PubMed and write some rubbish words, you'll get 1.1 million hits in 3 seconds. And you won't go beyond the second page. So you got to answer the question, ask a question in a way that can be answered. So I said, in mothers at high risk of premature delivery, well, a short course of corticosteroids compared to no steroids prevent or reduce neonatal deaths. So you define population, intervention, comparison, outcome or outcomes, and the time point, neonatal period. Then you got to ask your study setting. Do you want high income, low income, or any setting? And the final S, what study design? Clearly for this RCT. And sure enough, I found an RCT. Reported in pediatrics in 1972, looking at glucocorticoids in the same condition. Now my job is to say, what are the results? Okay, you help me. This is the design, mothers delivered, steroids, no steroid, outcome neonatal death. This is your 2x2 table. 532 mothers got steroids, 36 neonates died, 496 did not die. 538 did not get steroids, 60 died, 478 did not die. There is a difference. How important is this difference? That's what we have to do, right? So the first thing I did was looked at how you dominate. Normally you will do the null hypothesis. There really is no difference. And you've got to prove that's a test of proportions it is. And you've got one proportion and the other. And you want to see if there is a distance, can it be due to chance, right? And you express it as a probability that this result is or is not due to chance. And if you take a p-value is less than 0.05, you're saying this is considered statistically significant, right? And any of the tests, t-test, ANOVA, you'll end up with a p-value. Now, all of you know what a p-value means, no? Let's see if you really do. What does it mean? If you get a p-value of 1, you're 100% sure this is not due to chance. If you get a p-value of, is due to chance. If you get a p-value of 0, you're 100% sure it is not due to chance. So if you get a p-value of 0.5, no clue. Could be anything. You want to be surer than that? So if you get a p-value of 0.1, you're 90% sure this difference is not due to chance. And a p-value of 0.05 means you're 95% sure this is not due to chance. So therefore, when you say I got a p-value less than 0.05, you're more than 95% sure this is not a chance difference. Hold that thought and look at these columns and rows. I've got two rows, increasing sample size in the columns, control, treatment and control, right? And below that, I've got the number of people who responded in each of these and the response rate. Now, if you look at the response rate, that's the true response rate. So many people responded. You'll find it's fixed. 80% of the people given treatment got better. And 40% of the people given control got better, irrespective of sample size. Right? That's the response rate. Double the efficacy. But when you have only 5 in each arm, your p-value, you're only about 71% sure this is not a chance difference. And then when you get to the magical number for PGs, 30, right? With a difference of double, that much more effective, you find that you're about 97% sure this is not a chance difference. When you get 100 in each arm, your p-value is less than 0.0001. You will report that as highly significant. And the person reading it will think highly effective. Doesn't mean that. It just means you're more than 99.9999% sure this is not a chance difference. It was highly effective even when your p-value was 0.29. Your sample size was too small, you couldn't show it. That's a type 2 error. So, if you're looking at response rate between two drugs for antidepressants in 6 weeks, what is the actual response rate? 1%. But you can get a p-value of highly significant, depending on your sample size. Right? So what you need to keep in mind, that there are some things which are statistically significant, but clinically unlikely to be important. P-values don't help you differentiate that. You need another measure. So that's why we go to estimating the effect, right? We don't worry about hypothesis, we want to know how effective is it. So you look at risk ratios. This is intuitive, right? What is the risk of dying? How many people died among those who got steroids? What is the risk of dying without steroids? How many died without steroids? That ratio is a risk ratio. Common sense, right? And you get a number, 0.61. What does this mean? Now, it all depends on how you're phrasing your outcome. So if you're saying, it tells you which is better. One means no difference. If you have an unfavorable outcome, undesirable outcome like death, relapse, anything less than 1, right, means the intervention, the experimental treatment is better. Anything more than 1 means the experimental treatment is worse, right? If you have a favorable outcome like alive, improved, you have to reverse the interpretation. That's one thing, which is better. Next is how much better. If you get a relative risk of 0.42, it means the intervention reduces the risk of that outcome by 58%. 1 minus the relative risk. 100 minus the relative risk expressed as a percentage. It quantifies the improvement, right? If it's 1.42, it means it increases the risk of that outcome, of a negative outcome, by 42%. Intuitive. But you have to also have confidence intervals with it. Now, confidence interval is a measure of, if you repeat this numerous times, you get a range of estimates in which you will find your value. 95% of the time, you have to keep repeating it. But basically, it's a measure of uncertainty. It says one trial doesn't represent everybody. But it can be a measure of precision. Because the narrower the confidence interval, that means your sample size is greater and you have more confidence in what the range of effects could be. And especially if it does not include 1. So if it is 0.5 to 1.25, your confidence interval, it says it could be 50% better or 25% worse. That means I don't know. Automatically your p-value will be more than, will be not significant. If clearly on one side or the other side, it is significant. Either it helps, definitely, upper extreme, lower extreme, or it doesn't help, right? But what is more important is, I want you to look at this. When you read any paper and you see confidence intervals like this, what is the lower limit? How far away from no effect is it? If it is 0.73, it means at least a 27% reduction. That's good. If it is 0.99, 1% reduction. From a randomized controlled trial that you control everything in. In the real world, you control nothing. You may not get that. So a minimum clinical importance is something you have to make. I want at least a 30% reduction or 25% reduction, depending on the outcome, to say, I will change my practice. The least estimate. That's the way to look at it. Now, if you look at these values, your risk ratio is 0.61. That's the relative risk. But you can also get the absolute difference. How many neonates less? One risk minus the other, right? And then you can derive how many mothers do I need to treat with steroids to prevent one neonate dying compared to not treating with steroids. Just the inverse of the risk ratio, right? So you also need the confidence intervals. Of course, there are formulae, and of course, I know you love formulae, but an alternative way of looking at it is download some software, free software, Excel sheet, you bung in the numbers, it'll give you all the results. All you got to do is interpret it. When a friend rings up, I can't give her numbers. I have to speak to her in English or Malayalam or any language you want. Convert the numbers into language. So this risk ratio, rule of thumb to interpret. What is the outcome? Death. Undesirable. Anything less than 1, steroids are better. 0.61. Steroids are better. How much better? 100 minus 61. 39% reduction in the risk of dying. Right? What is the best estimate? 100 minus 41. 59% reduction. What is the least estimate? 10% reduction. That's how I'll explain it to her. At the very least, there's a 10% reduction in the risk of the neonate dying if you use steroids compared to no steroids. Or I can look at risk difference. Multiply that by 100. Say out of 100. If you treat with steroids, there will be 4 less neonatal deaths per 100 births. 0.044 into 100 is 4.4, round it off. 4 out of 100. Do that with the confidence intervals. That gives you the number of neonates per 100 who will die less. Absolute number. And you can also find your number needed to treat to benefit. Which one would you choose if my friend were to call you? Which would you choose to tell her? Same results, different ways of showing it. Now, if I were to go by the results of a systematic review, clinicians and patients like the relative risk. But Shaji sir and Vice Chancellor sir would want to know number needed to treat to benefit, because what is the actual cost I'm going to be incurring for benefit, or how many actual people I will be, so I can tell everybody I saved so many children. Either way you do it, doesn't matter, same result. I chose to talk about relative, but I must tell you one more thing. This is very important. They can be very dangerous. You can get a relative risk of death of 100% increase in death from comparing 1 out of 10 deaths versus 1 out of 20 deaths. You'll get relative risk 2, right? Your risk difference is 5 more deaths per 100. You can get the same relative risk comparing 1 out of 1,000 versus 1 out of 2,000. Same number of zeros have increased on both sides. But now your risk difference is 5 more deaths per 10,000. Why is that? Don't tell me number of zeros, I told you. Both sides number of zeros have gone up. So what is the control group reflecting? What is the risk of dying without the treatment? Your baseline risk, control group risk. In the first, 1 out of 20 dies without treatment. In the second, 1 out of 2,000 dies. They probably don't even need the treatment. Right, so that's the important thing. Absolute benefits depend on the baseline risk, whereas relative benefits don't. So in another way, I'll just try and explain to you that if you have a high risk of having an event with an effective treatment, you need to treat fewer people to get benefit. If you have a low risk of having an effect with treatment, you need to treat many people to have any benefit. Okay, so if you look at the small NNT, it means the treatment is very effective. The difference in the treatments, one is much better than the other. If you've got a large NNT, it means the difference is not very much to choose from. So if you have a 1% difference between drugs, you'll need to treat 100 people to see any benefit. If you have a 10% difference between treatment, 2 drugs, your NNT becomes less, right? And one of the things to keep in mind is we need to know what are the NNTs for different conditions. So if you treat 15 people with insulin for diabetes, 1 more will get, prevent neuropathy. Same with acute MI. But it also depends on the baseline risk. Look at what the NNT is when you're treating a person with a low baseline risk and a high baseline risk. You're pre-diabetics. Right? Depending on how low the risk is, you'll have to treat a lot of people, you're wasting resources. Okay. So in summary, p-values are not the end-all and be-all. You need effect estimates like risk difference or a mean difference, as well as the absolute benefits. And depending on your baseline risk, these will change. Your absolute benefits will change. You also need to have confidence intervals, the upper and lower of the confidence interval. If they include no effect, 1, or if it's a continuous measure 0, it means you don't know, statistically non-significant. If they do not include no effect, then statistically significant. And it depends on how far from the lower limit the confidence intervals. So depending on that, you have to have in your mind what is the minimum clinically important before I change my mind. So moving from evidence to practice, should I tell my friend to take steroids? I've shown very clearly that this result is statistically and significantly important. Should I tell them to take? Anyone? Yes? My answer is, how do you know you can trust this evidence? It could be pure rubbish. That's called internal validity. How true are the results? That doesn't change whoever reads the paper in whichever part of the world. That's the truth. Then you can say, can I use the evidence? External validity. Do they apply to me? That will change depending on context. So for internal validity, what you need to know is, what are the factors that can change the results from the truth? And that depends on the bias, the methodology of the study, built-in bias to interpreting the results. Or it can be due to chance. But you and I know how to rule out chance. Confidence intervals, p-values, it's not chance or not. So we have to know what are the methods of every study design which actually contribute to biased results. And that's been worked out for every design. And for randomized controlled trials, these are the conditions that we have to look at. We have to assess each paper. Have they described this? Have they done that well? There is a methodology and all of that. Because if you get that wrong, your results are likely to be wrong. Fortunately for me, this particular paper was free of the risk of bias. So now I can move to the third stage. Can I tell my friend to use steroids? What do I have to do here? What you as a clinician do every day is the same thing we do in evidence-based practice in a slightly different way. I need to know what these three things I've already told you. I trust the results, an important outcome for the patient, right? People will say, this trial was done in New Zealand. Will it work in India? Two questions here. Is there a biological reason to believe it will not work in India? No. But what about adverse events like sepsis? So there is emerging evidence that if you give it in a program and don't worry about sepsis, neonatal sepsis can go up because of infections. But she is an educated woman. I can tell her, as long as you follow hygienic practices, the benefits outweigh the risks. Safe, that is the issue. Then is it affordable, cheap? Is it available over the counter? Is it practical? You don't have to get admitted or anything of that sort. Do you have any other alternatives? At that point, nothing. What is the last question? Normally I would say I'll give you $100, but for you $100 is nothing, so I can't afford more. So. Any other question? What is the preference of my friend? We very rarely ask that. We tell them what you should do. But having got all this information, we can share this information with her and make a shared decision. My suggestion is, based on this, worth trying. Right? But then there's one more question. Do you have all the evidence? I have one trial. And in the real world, unfortunately, other things happen. I'm showing you the results of ligands in a graph. Vertical line, no difference. Right? The point estimate is 0.61. The width of the confidence interval clearly tells you that the lower limit of the confidence interval is far away from no difference. It works. But I found another study, same PICO, smaller sample size, wider confidence intervals. I don't know. Now what do I do? One for, one I don't know. That's when I came across the logo of the Cochrane collaboration. Those days, they had found 7 trials because they systematically searched. 2 of them, one of them is ligands, 2 favored steroids, 5 did not. Now should I use 2 for, 5 no or yes? That's called vote counting. Right? The problem with vote counting is people will say that the ones which worked are large trials, narrow confidence intervals. And the ones which didn't work are smaller trials. All very good. But will you offer it to your sister? If you will not offer it to your sister, it's not a good way of looking at evidence. Right? So at the bottom, they pooled all the relative risks and confidence intervals, increasing sample size, gave more weight to the studies with narrow confidence intervals, so they are proportionally responded. In vote counting, big trial, small trial cancel each other out. In meta-analysis, the bigger trial is given more weight in the pooled analysis. Clearly tells you steroids save lives. Okay, so that lady has new respect for me. She thought I was a psychiatrist. Now I can tell her child will be saved and the child is alive today. So evidence-informed healthcare is a 2-stage process where you use evidence synthesis to see what is the real evidence we want from all that passes as research, and then we develop guidelines or policy documents. Separate process. Okay, and evidence synthesis basically means finding all that's been done which are very comparable, putting them together and seeing the combined result just to give us new information or tells us it doesn't work. That's basically what you're trying to do. So you can use qualitative methods or quantitative methods. The approach is the same. And it basically is like a review article, but with a very clear method section. You have a plan, you have a protocol, and everything is done. Like doing a new study, except that you're studying other studies. So it's got a very clear protocol structure, which you can read up on later. And it leads to, from basic science, theoretical, methodology. You come from that, you'll come with one study. Then when you find it starts working in a few studies, you want to do a trial. When you do trials, then you want to combine all the trials done and see what is the pooled result. Then you see actionable, what is actionable in all of this. That's the path that is being followed. So it's very clearly a methodology where you're trying to reduce bias in the way you assemble everything and see how can I look at the way the biases of the study affects the pooled results. And how much confidence do I have in that pooled result when I tell you use it, right? Now, meta-analysis is an optional part of a systematic review. If you have studies which are similarly looking at everything, you will pool them for each outcome, similar comparisons, and that's called a forest plot because it's got a forest of lines, right? And each of those lines is each study, and you're trying to see across the studies what is the average result across studies. Main advantage is you have much more power than the individual study. So if you look at that, there are 5 studies ranging from 1998 to 2010, right? Each study, the number of people who died among the people given these interventions are taken out there. And you can see totally 51 given drug A died out of 930. Now when I say average result, I'm not comparing 51 by 930 versus 72 by 920. That's also an average. There the problem is they're not randomized across the trials. You'll break the power of randomization. They're only randomized within the trial. So each trial's result, the relative risk and confidence interval is calculated. And then that is a graphical description versus the line of no difference. The point estimate, the size of the point estimate reflects the amount of weight given to that study. If you look at the size of the point estimate, which study gets the most weight? The last one, pi. 60% of that study's result is pulling the results of the final pooled analysis. Why is that? Large sample size, a lot of events, especially in the control group, this leads to a narrow variance, the standard error that is used to calculate confidence intervals. So let me translate this by saying, if you get a narrow confidence interval, it gets more weight. Right, because if you look at the third study, Jasani, that's the next highest sample size, but it's got the least weight. Why? Widest confidence interval. The event rate there, compared to the event rate in the other arm, makes it a wider confidence interval. Anyway, what you need to know, that's how it's done. The pooled effect, what does it show? Death is a negative, you don't want it. So drug A is better than B. How much better? 100 minus 70, 30% reduction. How sure are we? It could be a 50% reduction, or at the very least, it will be a 1% reduction. This is statistically significant. Why? Because if you look at that, that's a test of significance. P is 0.04. But is it clinically relevant? We don't know. 1% chance of it being 1%. The other thing when you look at a meta-analysis is that we need to make sure that we have actually done it within the systematic review, because there's a whole process by which we are addressing all the problems that can happen when you just take some studies and pool them together. Then the final thing is, when you get the pooled result, you should see, are they consistent? If they are not, they don't represent an average result. Very quickly, I'll show you how to do that. You look at the confidence intervals, they don't overlap. Right? If you look at Jasani, he's going in the opposite direction. So it's obviously a different kind of result there. Something is different there. Third thing is you look at the chi-square test for homogeneity. Your p-value tells you the difference in the results in the trial. You're 99.99999% sure this is not a chance difference. There's a magical number called I square. 87% means 87% of the difference within the studies exceeds chance, cannot be accounted for by chance. Only 13% of the difference is due to chance. 87%, something is different in these studies. Right? When you get that result, we want to evaluate it further. So what we can do is try and see why is it that some studies are doing better than the other, looking at their characteristics. In this example, we found that studies which had no cardiac risk factors and the studies which have cardiac risk factors are showing different results. Without cardiac risk factors, there is no heterogeneity. All the studies are saying no difference, consistently showing that drug A reduces the risk of death 0.34. Least estimate is now 0.53. Very clearly important. That's how we use these results. We also need to make sure that this pi is not full of bias, because it's influencing the results so much. So we have to look and see what is the effect of bias on that. Once you've done that, I now have to give you a report. What is the final result? And this is where evidence footprint is important. This is a term coined by this gentleman from WHO. I had a big fight with him, and then we got together and wrote this article saying any policy document needs to have an evidence footprint. Why? Resources are involved, and low-income countries have competing priorities for their resources. Why should I put my money into it if it does not work? Where is the evidence? So there's a process by which we try and look at the evidence, where we look at a summary of findings from a systematic review that's given to policymakers. And what goes into the summary of findings table is we need to know things. What is the evidence? How good is it? Is it likely to be clinically appreciable for all the important outcomes in terms of relative effects, depending on the actual comparator and the population you're going to use it in, the absolute effects based on baseline risk. And how confident are we that this is a true estimate, it's likely to be seen in clinical your practice, and further research will not change the result. That is what I want to know. Then I'm confident in this result. And there is a way you can do that. So we apply to each important outcome. We choose 7 outcomes which are important. And then each outcome we say, how critical is it for decision making? Only important and critically important outcomes we choose. Like for example, an outcome viral pneumonia with high mortality, critical important outcomes, we will select them. We won't take the low important. It's not going to change practice, right? Similarly, we do not want proxy indicators like HbA1c and all, because they change, but what their effect on the clinical outcome is uncertain. So we want clinical outcomes, right? And then once we've done the meta-analysis and risk of bias, we take these outcomes and say, this is the numerical estimate, and our confidence in that numerical estimate, we start grading based on these parameters. Can we trust the risk? All the studies, there is no bias. Or there are some important biases, so my confidence in that result is reduced. Does it apply to my setting? You know, they didn't include this population, that population, which is very important for me. My confidence is not directly applicable. You reduce confidence. The trial's results are all inconsistent, but I can explain it in a subgroup analysis. So I'm confident. Or you can say, the upper limit I would use, lower limit I'm not so sure. So there is imprecision. You can reduce that. Or there were only 2 studies and hardly anybody had an event in that. Then I really don't know. Or you can say, and I found all the evidence. So these characteristics will decide whether you downgrade evidence from a randomized trial, right? It can, they consider to be good quality. You can reduce your confidence in them to very low quality. Similarly, observational studies are considered to start because of selection bias, and if they're done badly, they can be downgraded further. But if they're done well, you can have more confidence in the results of observational studies because there is a clear dose-response gradient. There were some confounders, but if that confounder was not there, the effect would be even much better, and stuff like that. And you end up with 4 levels of certainty, right? And what they basically mean, high certainty means you can say, this treatment will have this effect. You're confident in that. If for some reason you reduce your confidence, you can say it probably will reduce the risk of death, but because of this, we're not that sure. And that's the way we are saying, the way we actually become confident in that. That is used by a policy group to make these judgments, and they'll say, strong recommendation, nobody will have any problem using it, or a conditional recommendation because of the trade-offs, based on what quality evidence. So any guideline document which does not have a recommendation saying, do this, strong recommendation based on whatever quality of evidence, has not gone through a rigorous process. That's a fact, right? So this applies because there was a lady in Sri Lanka in 2002 when I was active doing all this stuff. She asked this question, why is it that in India, Sri Lanka and some other countries in the world, in this region, we are using 5 days of primaquine to kill hypnozoites after killing the blood form of malaria with Vivax malaria with chloroquine. WHO says you should use 14 days, but we are only using 5. So she got in touch with the Cochrane Infectious Diseases Group, and I was working with him, so we helped them do this review. And her summary of findings table, she found studies comparing 5 days of primaquine following chloroquine versus no primaquine, and found that it's as good as giving no primaquine, no difference in relapse rate. The studies where 14 days of primaquine following chloroquine was compared to no primaquine, 14 is far better. And this is a direct comparison, 5 versus 14. It shows clearly that for the outcome of parasitemia, if you use 14 days of primaquine following chloroquine, you will have 21 relapses per 1,000 over a period of 6 months. If you use 5 days, you'll have 183 more relapses per thousand, from 49 more to 742 more, based on the systematic review. And the confidence was, we are moderately confident in this evidence. And they also said the reason why they are not confident is because these trials did not have children. So we do not know what the effect will be for children. But if you're only treating adults, high certainty, this works. Now, this was what we then presented to the ICMR. When Nina Valaicha was in malaria control, I told you, no, I went and met her. And we gave her a one-page summary of what this meant, right? And shortly after that, the drug policy changed. And not only that, Park and Park, textbook of social and preventive medicine, also changed the policy. So, you can actually do research which changes policy. The problem was, when I looked at the malaria guidelines, it doesn't quote our review. So I do not know whether they really changed because of the review. There's no evidence footprint. But they said WHO guidelines. So we looked at the WHO guidelines, and there they talk about strong recommendation, high certainty evidence, use 14 days, right? And they give you a table of all what 14 days should be used, and 14 is better than 7. That's one from our review. And they referenced it. And this is the table from the review. So that's how reviews can actually make global importance. So the role of evidence, I'll just sum up. You need systematic reviews, which gives you a judgment and a prediction based on what has been done. But you also need your local evidence. What is your baseline rate? What is the relapse rate in your country? Then you make judgments based on this, on the expected harms, opportunities, etc., and the trade-offs. What are all the trade-offs I'm going to do? Then you make your policy. I'll give you a very good example of this. WHO came out with a malaria guideline for falciparum malaria, and Ghana were trying to update their essential medicine list. By then, the recommendation for WHO was strong recommendation, high quality evidence to use intravenous artesunate versus quinine, compared to quinine for children. Problem for Ghana was they're used to using quinine. They had a consultative process. They looked at their local evidence and global evidence, and their policy, which they published, we will use quinine in preference to artesunate. And their reasons were, artesunate may be better than quinine, but quinine is also good. They may lose some 23 per thousand, but if we don't use quinine, if we use artesunate, we will have to take money from somewhere else. And other people will die. That's called the opportunity cost. I have a fixed budget. I have to use that for so many other things, right? And it's difficult to make sure that we can continue to get artesunate. So they said, till the situation changes, we know artesunate is better, but we will use quinine. So this is what I meant. Evidence informed their decision. So I could go on forever, but I'll just leave you with some final thoughts as young people. I would suggest that you read about all these methods. What in each question, what is the design, and how do you evaluate the design? There's information out there. If you look at User's Guide to Medical Literature, whole series of articles on that, right? I think you should move from just-in-case learning, where everybody crams stuff into your head so you can retrieve it just in time. In case I need it, I need to mug this up. And ask yourself, just in time. In your clinical practice, you have a question. Follow that question. Find out where to find the answers to that question. Make a list. I don't know why he's saying this. Remember, earlier on they used to give lumbar puncture. After lumbar puncture, they'll say you have to lie horizontal. St. Chalmers. And he gets to have his portrait painted in the National Art Gallery. So one farewell we were giving him, he said, Pratap, I don't have a picture of you. Can you send me a picture? So all of us sent pictures, and we hang in the National Art Gallery with him. So he says, the Cochrane collaboration is about collaboration. It's not about one man. So when you start your careers, form research partnerships. You've got mentors. You're lucky. Any institute, college should start a mentorship scheme. Right? Undergraduates should be given a mentor. It really works. It really works. All of us were mentored. Anyway, I may have overshot my time, but I don't care. Thank you very much. Thank you for this opportunity.
Thank you, sir. It was a delight to hear the oration. I now invite Dr. Anil Kumar TV, Professor and Head of Department Psychiatry, Government Medical College, Ernakulam, to present the memento and certificate to our guest. Thank you, Anil sir. Thank you, Pratap sir. Now it's time for the lunch break. The lunch counters are open in our COK hall. I would like to request all our guests to move towards COK. Please take your tags with you. It holds the key to your lunch. A general reminder, those who have
Royal College of Surgeons at Edinburgh. He also has completed FACS from Fellow of American College of Surgeons, USA, FAIS from Fellow of the Association of Surgeons of India, FIAES from Fellow of the Indian Association of Endocrine Surgeons, and FMASI from Fellow of the Minimal Access Surgeons of India. Dr. Santosh sir believes that healthcare is all about taking care of patients' concerns and providing the best treatment to all in every way possible. He was always keen on upholding this noble profession throughout his entire career. He has served as a surgeon in different hospitals nationally and internationally, including Pushpagiri Hospital, Tiruvalla, Hospital of St. Cross, UK, Leeds General Infirmary, UK, Regional Cancer Center, Thiruvananthapuram, and Malankara Orthodox Syrian Church Medical Mission Hospital, Kolancheri. He also is a life member of Indian Society of Gastroenterology, Kerala. Currently, he is the medical superintendent at Lord's Hospital, Kochi. He also is the head and senior consultant of the Department of General Surgery, Lord's Hospital, Kochi. We are privileged to have you here, sir. We welcome you for the oration. Now I invite our chairs for the oration. I invite Dr. M.K.C. Nair, sir, former Vice Chancellor, Kerala University of Health Sciences, former CDC Director, former Professor Pediatrics, and now Chairman of MR. We have Dr. M.V. Pillai, specialized in internal and clinical oncology. He is a clinical professor of oncology, Thomas Jefferson University, and he is the governing council of MRS Menon Research Foundation. We have Dr. John Panikkar, sir, a renowned ENT surgeon in Thiruvananthapuram. He is the chairman of Trivandrum Medical College Alumni Association. With this, we start our oration. Over to you, sir. Sir, over to the chairs.
Good afternoon. This is a program that has been started by community medicine years ago. It is well supported by Kerala University Health Sciences when I was the Vice Chancellor. It's a very prestigious project. That is the MRS Menon Foundation oration along with this, because maximum number of postgraduates will listen to it and may get enthused. At least few of them may get so enthused that they may want to be like this giant who is giving the oration. Santosh John Abraham, incidentally, he happens to be my student. What is MRS Menon Foundation? Basically, if you look at Trivandrum Medical College, I have been most impressed by two people. Of course, both are not my teachers, but I was impressed. Matthew Roy, sir, for academic brilliance as a teacher, clinician, and MRS Menon. The way he will come dressed and show. As an youngster, I was so enamored by him that I wanted to become like him, which of course will not happen. So he was the most charismatic leader. Then we had anything happens in this campus, you need one great man, and that is called Dr. John Panikkar, alumni, and alumni, plus alumni. So together, of course, and for any function of academic nature, we always have fellows from US. He will fly in from US. We started this program, and Libo, many others, Anish is there, so many others. We started the MRS Foundation, had a long discussion how to go about and all. What is the objective of the foundation? Basically, it is to promote research at undergraduate, postgraduate, and faculty level, bring in collaboration with our own alumni working abroad, as well as bring in interdisciplinary research. And we have, programmed the whole thing, and this is the first meeting of academic function of the MRS Foundation. So, Abraham, you are really lucky to be the first one. Okay? I believe you feel like that. Yes or no? Thank you. So, most welcome, sir. Please.
Okay, my name is Dr. M. E. Pillai. I am an alumnus of this college. I'm so delighted and proud to be associated with such a dramatic and revolutionary program like training our medical students into modern methodology of medical research. This couldn't have come at a more appropriate time. When I come here every year, I go to all these affiliated institutions like RCC, Rajiv Gandhi Center for Biotechnology, Institute of Advanced Virology, ISRO labs, ISER labs. But I came to the realization that there is virtually no crosstalk. Everybody is working in silos. And this is where Dr. M.R.S. Menon comes to our mind. Although he was a distinguished surgeon who could help Dr. P.K.R. Warrior develop our cardiac surgery department, he was loved by every specialty. His interpersonal skills, his affability, his unique capability to get along with people, sense of humor, everything was highly admirable. I was actually a postgraduate student in medicine, but I was a great admirer of M.R.S. Menon. When M.R.S. walks in, everybody will look at him. Such a charismatic personality. Now, what I'm trying to emphasize is your personality may not matter much, but your interpersonal skills is an absolute must in biomedical research. Nobody is going to do any research work alone. You need to identify a place where somebody is doing an RNA sequencing or somebody is working on artificial intelligence. Bring them along. You may not be doing that right away, but that's the way things are coming. Couple of sentences. You may wonder why modern medical science is different from many other branches of science. This is the only branch of science which constantly struggles to disprove its validity. I repeat the term. Modern medical science is constantly struggling to disprove the validity of something already in practice. Take, for example, when I was in the medical school here, the gastrojejunostomy used to be the standard treatment for recurrent peptic ulcer. Okay, and you treat them with medical treatment, it doesn't work. Go to the surgeon, they do highly selective vagotomy, gastrojejunostomy. Where is it gastrojejunostomy now? Because studies showed that H. pylori is the cause of peptic ulcer in the majority of patients. Australian scientists. Now the technical surgery is out. We can treat H. pylori with medication. Same thing, when we were in medical college, after massive heart attack, you were prescribed absolute bed rest. Now the patient is back on ambulation on second day, unless there is a pulmonary embolism or something like an uncomplicated MI. The cardiologist or the internist will put them on an exercise from day 1, day 2. They wouldn't allow you to be in the bed. Thalidomide was thrown away as a drug which can cause fetal deformity. We pulled it back for treating leprosy. Then we refined it and we are using it for multiple myeloma with dramatic response. So there's a constant struggle. This is the only science which constantly struggles to ratify or invalidate an existing theory or concept. It doesn't happen in Ayurveda. It doesn't happen in Ayurveda or homeopathy or Unani or Siddha Vaidya. That's where they are lagging behind. This attitude of constant search for the ultimate truth is a never-ending spree. And that's what you are entering into medical research. And congratulate all the organizers behind this great venture, especially the Department of Community Medicine and Alumni Association and Dr. M.R.S. Menon Foundation for organizing such a dynamic program with 250 registrations, now bursting through the beam with 400 registrations, something which we would have never had seen 25 years ago. Hearty congratulations to all those organizations. Now, a couple of words about Dr. Santosh John Abraham. He is a proud alumnus of Trivandrum Medical College, graduate and undergraduate and postgraduate. He was the first surgical oncologist at the regional cancer center here. Okay, and then from there, his constant desire to follow a pursuit of excellence drove him out. Not that he didn't like the alma mater, but he was in search of an excellence. When he didn't get it here, he just sought it outside. He became the president of the Association of Surgeons of India. I understand he is the second Malayali to to occupy that position. And he's an academic surgeon. I checked with some of his colleagues, and he has organized a group in Kochi called Musings. The word musing means you are thinking constantly, introspecting about thoughts and your actions and making sure that you're doing it right. So there is an urge to do things better. That's the whole motto behind the Society of Musings. Again, I congratulate him for continuing his pursuit of excellence in spite of working in a non-academic hospital. You don't have to be in an academic hospital as long as you have scientific mind. You may be surprised to see that some of the breakthrough research and biomedical research have all come from non-academic centers. It's actually the mind that matters. So if this organization and meeting can inculcate a search for truth, an inquisitive mind, that's all it matters. Now, he's going to talk about breast cancer, how the scenario of breast cancer has changed from the date of radical mastectomy, became simple mastectomy or modified radical mastectomy, simple mastectomy, lumpectomy. And I'm going to read what came out in news today. Omission of breast surgery in selected breast cancer patients with excellent response to neoadjuvant systemic therapy. It's coming from European Journal of Surgical Oncology, March edition. What we are coming to mastectomy, into a day when at least surgery, neoadjuvant the tumor, complete pathology remission, and local radiation. They did breast cancer, published in the New Surgical Oncology. First journal, how cancer from radical mastectomy to a minimalist approach. Do the minimum if you can and save the patient. That will save from morbidity and in April 2024. So you can imagine how much the things have changed. Congratulations. I also believe that a time has come that the barriers of research between government and completely demolished. I wish a day when students from medical colleges can go and work with academic surgeons like Dr. Santosh John Abraham, pick a topic of interest, make him the mentor, and that's how the whole world has progressed. Congratulations to the organizers. Welcome to Dr. Santosh John Abraham.
All of you. Hello, sir. And actually, as the president of the college, proud and congratulate the Community Medicine Department of Toronto Medical College as well as the Kerala Health University for making this conference here itself. This is the I know a lot of students come from many other medical colleges, and this is the oldest medical college in Kerala, the pioneer medical college. And actually you all must have heard of Kerala Health model. And actually the foundation for that Kerala Health model was laid in this medical college by the alumni who has come out from here. And that's what I want to say as introduction. And regarding, as M.B. Prasad said, because he said, Dr. M.R.S. Menon sir was my own teacher also. And he was a fantastic personality, not only as surgeon, and very, very bold surgeon. I had seen him operating directly. And also, he has done the first open heart surgery in Kerala. And started doing it here in Toronto Medical College when the facilities were very, very meager. MRS Menon sir's brother-in-law, Dr. Madhu Mohan, former professor of surgery, is here. Madhu, please stand up. And we are thankful to Madhu Mohan and the family of MRS Menon. Actually, his son, Vinod Menon, is in UK, and Madam also happened to be in UK because it happened to be her birthday. Otherwise, they all would have been here. And, I think tomorrow they are celebrating Madam's birthday. So I am also thankful to Dr. Madhu Mohan for being present here. And again, Santosh John. Actually, I think, I don't know how many as Malayalis has become the president of the ASI, which is the Association of Surgeons of India, which with thousands of members. All surgical specialties are there. And he was the student of MRS Menon sir while he was doing the PG only. Unfortunately, in 1987, Dr. MRS Menon sir left us. So over to Dr. Santosh John Eyebrow. Thank you.
A very good afternoon. I bring in first to all of you surgeons of India, respected chairpersons, faculty members of the Department of Social and Preventive Medicine, officials from the Kerala Health University and Allied Sciences, Alumni Association of Trivandrum Medical College, MRS Menon. I'm indeed grateful to all of you for bestowing to deliver the first oration of this great man, Professor MRS Menon, who incidentally has performed the first open heart surgery in government medical colleges in the whole of the country outside. It was a great. I was with him, and he has inspired many of his take up cardiac surgery, but then decided my. He was the first. MKC of but Professor of Surgery, Dr. B.K. Madhu Mohan, guided by tutelage. Dr. Kedunath, former Professor of Pediatric Surgery. We were classmates from school days onwards, and we both were the panelists, and we have been tutored by him to deliver so many things. I also would like to recognize Professor Sri Kumar and Professor Vishwanathan, who has come to grace this occasion. Can you just play this video? When I was asked to talk about something in, can I hit the volume?
ഒരു മർഡർ ഇൻവെസ്റ്റിഗേഷനിലെ ഏറ്റവും പ്രധാനപ്പെട്ട ഒന്നാണ് വേർ വാസ് ഹി ഓർ ഷീ കിൽഡ് എന്നുള്ളത്. എനിക്ക് അന്വേഷിച്ച് തെളിയിക്കാൻ കഴിയാതെ പോയ 4-5.
I know all of you know this film, Anveshipin Kandattum. When I was asked to talk about a research, I asked one of my PGs, because it's the first time I'm addressing an undergraduate students on research topics. Because my core area, as has been illustrated earlier on by people who have introduced me, I'm a pure general surgeon, loves to be known as the general surgeon, and still continue to do general surgery. But obviously I have some interest in various organs, and one of them is, one specialty is surgical oncology.
seek and you shall find. This is the, when I asked this, one of my PGs, I do run postgraduate course, DNB course, we have 5 students per year, and one of them suggested that why don't you speak, put this as a title and speak about this. Always in your career, please ask why and when, how, etc., etc. I just wanted to be very informal. How many of you know this quotation? If you have known about this quotation, please raise your hand. Yeah, only hardly less than 1%. Only less than 1%. Right? Friends, Romans, and countrymen, I have come to bury Caesar, not to praise him. My job is to deliver the research, but not to teach you English. But unfortunately, this very organization, this very alumni has taught me English, thanks to many of my teachers, including Professor Madhumohan. And I'm sure that you will know about this thing when the Shakespeare, that was Shakespeare, another Shakespearean quote, and we had the tragic play by Hamlet and William Shakespeare. He quotes that to be or not to be, when Hamlet realizes that his father was killed in a conspiracy where his mother and father's younger brother, who later on took the crown, was instrumental. Why bring this in a totally irrelevant, you might look irrelevant, because this campus, please understand that to become a good doctor, you should know, you should be first a human being capable of communicating and identifying yourself with your patient. However much you know about your subject, you are going to be a failure unless you are able to put it across. And this alumni, this very campus, and please think that literature, sports, everything is going to build you into a perfect human being. And I request all of you to pay some attention to other than academics. Science is on one side. You should enjoy your music, you should enjoy your art, you should enjoy everything that is around, and there is a lot to enjoy. I just picked up few names, few pictures. These are eminent writers who are alumni, contemporary writing. Dr. Rajshekhar Nair, former head of the Department of Neurology. Dr. B. Iqbal, former Vice Chancellor. They are still writing a lot of things. Coming to performing arts, you have my own teacher, Professor Ambikatmajan Nair, and you have Thomas Matthew, who was a year junior to me, who is the current DME, suppose. Dr. Matthew Roy, sir, has been illustrated as one of the best physicians this country has ever seen. But there is another dimension to him. He was a basketball player, and he was represented Kerala as well as Kerala University. He spent his time in basketball court. I don't know how many of you remember the person who is sitting in the middle, Professor Madan Mohan, best outgoing student from his batch. He has captained the Kerala Ranji team, and he was an opening batsman, a pediatric surgeon of eminence. We are no longer having his presence here. Jimmy George started his medical career here in this college, but then he went on to, leave the course and went on to become an international volleyball player. I just wanted to mention these because just don't think that your subject is going to be the end of your world. You become a doctor with a good communication to the patient. Unless and until you do that, you will not be there. I have taken the subject of breast because it has metamorphosized over a period of time, and on a post-lunch session, talking to you, core research would be an absolute bore, and I'm sure that you would sleep off, so I thought I'll just show some clinical pictures so that the interest is kept live. Breast in the past, in the prehistorical era, was considered as a local disease, as a bulging tumor, but at the time when the Greek has come in, Hippocrates said, look at the last line, those who had the tumor excised perish quickly. So the science at that point of time itself was divided into a local disease and a systemic disease. We were the same when this gentleman, I would like all of you to read about this gentleman. This gentleman is William Stewart Halsted, one of the most celebrated surgeons ever born, ever written in the history of surgery. He was a born Wyvern surgeon in the suburbs of New York. He was a very genuine man. He tested the effect of cocaine as a local anesthetic to become a cocaine addict. He did the first cholecystectomy on his own mother in a kitchen table in the middle of the night when she was found to have the typical Charcot striate. He is the first man, much before the blood groups were found out. He drew his blood and gave it to his sister who was having a postpartum hemorrhage. That was William Stewart Halsted. He rose to become the professor of surgery and founded, along with the great four or the great three Ws, to become the first professor of Johns Hopkins at Massachusetts. But let me tell you, his favorite operation was nothing other than Story of the Goiter. That is the title of his autobiography. He had the fortune to get trained under the flamboyant William Billroth, and as well as a very, very, very meticulous Cocker. So he had experienced both the styles. Before he came back from Europe, people never realized that he switched over from cocaine addiction to morphine addiction. Then breast cancer, according to him, was a loco-regional disease. His theory was the tumor starts at one single point. It has a predictable pattern of spread through the lymphatics, and it is filtered at the regional lymph nodes. Once the first regional lymph node becomes full, it just goes to the next level, right? So this is called the Halstedian theory. And according to this, he said removal of the entire breast tissue along with the lymphatics and regional lymph nodes as an en masse would be the cure for a breast cancer. This held its view and his position over a decade, over a period of 7 decades, from late 18th century to somewhere around 1960. People went on to do supraradical mastectomy, where supraclavicular nodes were removed, ultraradical mastectomy, when internal mammaries were removed. It was a morbid operation with disfigurement, lymphedema, and development of lymphangiomatosis, carcinomatosa. When we were students in surgery, radical mastectomy was still on vogue. And whenever the students are getting a chance to do a mastectomy, they will stand on the opposite side, allow the theater light to be shown from the side, and we have to see the light has to come to this side. If there is a fat somewhere, that is an incorrect operation. We were asked to remove the fat. It's a thin skin flap, never to, it automatically said that it has to necrosis. Necrosis of the skin followed by skin graft was a routine thing, and that was considered to be a successful radical mastectomy. Today, we never allow the skin to necrose. The observation that has led, and you have studies to prove that good skin flaps are required. The skin graft is again a contraindication for irradiation postoperatively. Surgical observations were local recurrence, metastasis, death still continued after the radical surgery. Less radical operations gave exactly the same results. Surgeons became less and less radical. Pétis mastectomy came into vogue when we were all students, wherein I'm sure that you all know the radical nature is lessened by retaining the pectoralis major, which contributed to the anterior axillary fold. The pectoralis minor was removed. In Scallon's mastectomy, pectoralis was divided and pectoralis was resutured. And in Auchincloss, pectoralis minor was also retained. And John Maiden, a great name, who has contributed to the development of the current transverse incision, because the incision also matters and the total outcome of the patient. Mastectomy still remained a choice for many years. But in India, still mastectomy has got a high incidence. I mean, it has to be done in a large number of cases because of the multifocal disease, adverse tumor breast volume ratio, unacceptable patient's desire. Many times we consent the patient for conservative surgery. On the day morning, either the husband and the patient will come and tell you, I don't want to take any risk, kindly remove my whole breast. This is a deep-rooted thought in the society that removal of the entire breast is going to give them cure. It's not. It's not. So that is something which we need to do. The mastectomy leaves behind a lot of disfigurement. It alters the self-esteem of the woman. Dress code gets changed, the sexual behavior gets changed, and the answer to this on one side. I just want to bring in a universal, a compact, thing for the development of various aspects of breast surgery. Breast reconstruction used to be the answer for this. We were one of the beginners starting the breast reconstruction, and I've done a lot of this breast reconstruction. Before I show some pictures, let me just tell you that it's a highly consumer-driven product. It is a very sellable product, but it is nothing but a transfer of a lump of fat from breast, belly, back, or buttock. So it is not adding to the cure of the patient, but only address the cosmosis of the patient. So the first of our foremost was, to create, that's a reconstructed breast. The nipple-areolar complex is removed. You are basically worried about the volume of the breast that is reconstructed, the inframammary folds to give a good breast. When the patient bears the brassiere, it looks almost the same. But once you remove the brassiers, the patient will have a deficient nipple-areolar complex, which may not be appreciable to many as far as the cosmosis is concerned. So what do we do for that? These are all some of the reconstruction. Excellent inframammary fold, good bulk, but deficient on, nipple-areolar complex. Do we need to really remove the nipple-areolar complex? If the tumor is having a good biology, if the tumor is away from the nipple-areolar complex for more than 2 centimeters, you don't have to remove. We have done about 480 cases of mastectomy, studied the nipple-areolar complex histopathologically separately. We have laid down criteria where to retain the nipple-areolar complex. Today, in a good number of patients who require mastectomy, skin sparing, nipple sparing mastectomy can be done, and you can take the flaps. There are so many flaps which are available. Predominantly, we do transverse rectus abdominis muscle flap, and this, and then the level of the, this is the point. You won't have it. Okay, fine. Okay. The lower incision from are brought up. Now, this is reconstruction we have done with axillary clearance. The incision you can plan in such a way that that is the kind of incision that you put at the end of the day. If the skin is to be excised in large volume, you can do that, and you can reconstruct the skin also from there. This is the kind of mastectomy and reconstruction we can do today. And I'm sure that you would appreciate that it is almost looking equal in its appearance, and even the erotic sensation of the nipple-areolar complex with its sin can be recreated by preserving the second and the third intercostal nerves which are going to supply the skin. So all these things over a period of time has been addressed. Whenever you have a problem, you have a look at the problem and find the solution for that. So we have published our data in Indian Journal of Surgery, and these are all people who have worked with me at that point of time. In 2003, Dr. Pushpangadan is a consultant urologist in UK. Ramesh is a plastic surgeon in UK. Harun Thomas is a breast surgeon in Irshad. All of them are alumnus of this institution who later on worked with me after their MS. Irshad is a lead robotic colorectal surgeon in UK. So when we started, we never understood that point. When I was not trained in the flaps, the breast reconstruction. So we started with vertical incision. So from vertical incision, that incision is not that sightly. So we had to, after getting the knowledge that the flaps can survive, we moved to horizontal incisions. And the horizontal incisions, as you all know, the large number of perforators are from the periumbilical area. So we used to put incisions there. From there, we migrated down to the level of fan steel incision, which can be hidden, and you can't see the incision at all right now. So I don't think we have time to go through this videos. They are all various kinds of flaps. It is not necessary that you take flaps from abdomen. Indian women do have a good abdomen post-delivery, and that is where you get the maximum fat. So large majority of our reconstructions are going to be from transverse rectus abdominis flap. But then there are people who don't have that much of belly fat. You can actually gluteus minor, and that flap can be brought in up to the they are all different flaps which are done microvascular. Since we have started doing breast reconstruction, you can see the incision, the first one on top, the transverse incision, that was done long ago, and you can actually see that was in 2005. This patient developed a malignancy on the opposite breast years later. So that breast also was reconstructed. Patient had an incisional hernia that was repaired also. Latissimus dorsi is not an ideal flap unless and until there is a large skin that needs to be covered. And still you can bring it to normalcy by putting an implant there. We have our share of problems. Don't think that all surgeries are, absolutely fine. We have flap necrosis. We have lack of ptosis. We have, the fat necrosis coming in. And this is a young girl whose flap has been harvested. She was a person who was not having given birth to any children. So very low fat harvest. Zone 4 has necrosed. So those are bad results. Yeah, okay. So this is a nippler-areolar complex preserving, skin preserving. This thing, she has lot of necrosis of the nippler-areolar complex, skin paddle, and all, even on the recipients, the donor side, we had problems. I need to change here, is it? Just change. Yeah, when smaller volumes of breast needs to be removed, again we have techniques to reconstruct that change. Yeah, then came the era of Vernozzi, who said we will only have breast conservative surgery with an adequate 1 centimeter margin. Slide. So again you plan your incision based on your skin crease. Slide. Today, with lot of executive checkups and awareness amidst the women, we have mammogram detected non-palpable breast lumps. So you can have computer-aided biopsies. Slide. We also go through wire guidance. Wire guidance is that these are people who are a Birat's 4 or Birat's 5. Then you put a wire guided by image, and then we follow it for the wire guidance. Slide. Coming to nippler-areolar complex reconstruction, all those women who had a large breast that is reconstructed, nippler-areolar complex is not there, so you can have different techniques. On this side, you have seen a technique where we have used labia minora because the skin looks very close to the nippler-areolar complex. It's a free graft of a labia minora here. On that side, they will go for an inferiorly pedicle flap. We'll go for a tattooing of that flap with the nipple later on. Slide. Patients implants. These we put implants below Coming to axilla, that is what this one slide. Today we don't that to that you use or a tag so that it is slide lymph nodes. So take over this Fisher systemic result of he said the first disease to start TMF regime for long and today 4 cycles of deep road by on timing on to wherein government you advertise the flight. You have to fathom there is all path was wherein one side you have very disease, if it's a less malignant disease, you go for local therapy, flight. Then now 5 testing. So sequencing has in the course of time. Single agent elderly women surgery is also radiology with early detection of various lumps and brats and grams. Also, AC has come into the picture. And single partial breast sedation that will stop the patient's agony to go to a 25-day long radiation for that patient's life. Still, in 2024, we see these kind of patients, very advanced. They are educated, they go for alternate therapy, thinking that all chemotherapy, all surgery, and all radiation are all extremely painful and costly. They are, but then this we cannot allow to continue. Flight. We need to have awareness to improve, early detection to improve, limited surgical intervention to win the confidence of the patient. Multimodality treatment shall not be for a huge cost. It has to be for patient affordability. If Indian president cannot be treated just like a driver in any organization or a private driver. So individualized medicine is very important. Proper sequencing is also important. Slide. So what do? We do these kind of awareness program with cancer survivors coming into the picture, and these kind of things, and this will help the patient to come forward for an early detection for a better. How do we promote this? Self-breast examination, clinical breast examination, quadruple assessment, sonomammogram. The reason why I've concentrated on breast is, let me tell you, the population is aging. There is a female preponderance, and there are 2 breasts for every woman. And the lifetime risk of breast malignancy currently is 1 in 9 women in their lifetime. So there is a huge burden of disease which is anticipatable. So please promote early detection, awareness, go for this thing. Now, as a clinician, is it just the job of the clinician to stop surgery at that level? We also do some fundamental research. The problem with sonomammogram has been the lack of 100% reliability. We have a lot of negativity. So one of my thought process has been the body water, if they are aligned using a microwave, they will have a different pattern. So combining with Cochin University, we have done a lot of primary fundamental research, and we have been able to produce a lot of papers on microwave human-female breast characterization. And these are people who have done doctorate with my guidance. And we have, right now, the IIT Madras has taken over this project as a conversion for a patient-friendly product. So many papers have come on microwave on that from our side. So to conclude, I will just skip through some of the areas where Dr. M.R.S. Menon would have been very happy to see his surgical side. Tracheal reconstruction has been an area of forte for me, various kinds of tracheal reconstruction, and also, it's not working. That's fine. Lung surgery, and also one of the most complex surgeries is esophagogastrectomy, where again we have improved a lot in our technique of Iver-Louis procedure. I'd like to stop here by thanking once again all the people who have been instrumental in getting me this oration, and also thankful to the patient listening of all of you, and to the gracious presence of Dr. Sedunath, Dr. B.K. Madhumohan, Sri Kumar, and Dr. Vishwanathan, and needless to say, Dr. M.K.C. Nair sir and Dr. M.B. Pillai sir. Thank you very much.
Thank you, sir, for enlightening us with your knowledge. Now, we invite Dr. Madhu Mohan, sir, former professor and HOD of surgery, to present a token of gratitude to Dr. Santosh John Abraham. Now, we welcome Dr. Anuja Yu, Professor and HOD, Department of Community Medicine, to present a token of gratitude to Dr. M.B. Pillai sir. Now we welcome Dr. Anuja Yu, Professor and HOD, Department of Community Medicine, to present a token of gratitude to Dr. John Panikkar sir. Now we invite Dr. Mini S.S., Professor, Community Medicine, to present a token of gratitude to Dr. MKC Menon, sir. Sorry. Now we invite Dr. Mini SS, Professor Community Medicine, to present a token of gratitude to Dr. MKC Nair, sir.
Next, we move on to the panel discussion on the topic Early Research in Career, Future and Opportunities. Research allows us to pursue our interest, to learn something new, to improve our problem-solving skills, and it challenges us in new ways. It also helps us to gain academic credits, scholarships, and it helps to learn professionalism, time management, and multitasking. So it is often insisted that every university should have a research wing. Here, we are blessed to have a panel of eminent speakers with immense knowledge pouring in. With this, we are inviting our speakers to the panel discussion. First, I invite Dr. Biju Sauman to the panel. Dr. Biju Sauman completed his MBBS, DPH, and MD Community Medicine from Government Medical College, Thiruvananthapuram, and his MSc in Control of Infectious Diseases from the University of London, and Professional Diploma in Tropical Medicine and Hygiene from the London School of Hygiene and Tropical Medicine, UK. He also has undergone advanced training in health informatics from Oslo University, Norway, teaching methodology from Boston School of Public Health, USA, multi-level modeling from University of Germany, and advances in geographic information system from National Remote Sensing Center, Hyderabad. Dr. Sauman guides PhD scholars and MPH students, teaches public health technologies, infectious disease epidemiology, and database management in epidemiology modules at Achyuta Menon Center. He is the chairperson, Board of Studies, SCTI MST, member Standing Academic Committee, SCTI MST, Council member, International Academy of Cardiovascular Sciences, Executive member, Health Action by People, member of Research Advisory Committee, Center for Environment Development, and Executive member, Center for Advanced Global Health. He also is a member of Indian Public Health Association. He heads the Regional Technical Resource Center of the Health Technology Assessment at SCTI MST. Currently, Dr. Biju Sauman is working as professor and head Achyuta Menon Center for Health Science Studies at the Sri Chitra Tirunal Institute of Medical Science and Technology, Thiruvananthapuram, Kerala. We welcome you to the panel, sir.
Now, we invite Dr. C. Keshav Das. Dr. C. Keshav Das is an eminent figure in radiology, boasting a fellowship in neuroradiology from the prestigious Scientific Institute and University Hospital San Raffaele in Milan, Italy, with an MD and DMRD from Medical College Trivandrum, and an illustrious career, including roles as professor, head of department, and editor-in-chief of the Indian Journal of Radiology and Imaging. He has left an indelible mark on the field. Dr. Keshav Das' leadership extends to serving as president of the Indian Society of Neuroradiology and as a governing body member of the Asian Society of Magnetic Resonance in Medicine, illustrating his commitment to advancing radiology globally. We welcome you to the panel, sir. Now, we invite Dr. Srinivasa BM. Dr. Srinivasa BM is a medical graduate with MD in Community Medicine and DPH. He shifted from medical education to clinical research after 4 years of teaching. After a career of 5 years in NIRT Chennai, he has shifted to malaria research at ICMR, NIMR, currently working as scientist for ICMR, NIMR, FU, Bengaluru. He is a co-investigator in clinical trial and epidemiological study on tuberculosis. We welcome you to the panel, sir. Now we invite Dr. Amok Bhaskaran Jayaprasad. Dr. Amok Bhaskaran Jayaprasad is a dedicated researcher currently pursuing a Master of Science in Biology. Welcome you, ma'am. Dr. Indu PS is a distinguished figure in the field of community medicine, heralding transformative initiatives both locally and internationally. Currently serving as a professor at the prestigious Government Medical College in Kollam, Dr. Indu brings with her a wealth of expertise and a profound commitment to public health. Her influence extends far beyond the borders of India as she actively contributes to the Strategic Advisory Group of Experts Working Group on Dengue Vaccines at the World Health Organization headquarters in Geneva. In this capacity, Dr. Indu plays a pivotal role in shaping global strategies to combat the spread of dengue fever, reflecting her dedication to addressing health challenges on a worldwide scale. We welcome you, ma'am.
We have a special announcement. The NATCON quiz prelims will be starting at 4 p.m. So the registered students should assemble at the registration desk at 3:45 p.m. Thank you.
Thank you. Good afternoon. We have been an illustrious panel from varying specialities, all alumni of our the same institution. I'm sure this is going to be one of the star attractions of this national conference, which hopefully will ignite the young minds, because the usual trajectory is MBBS, then MDMS, DM, MCH, and of course, in between a few move towards research, others take up the career at a later stage. What if we start so early? Amok today morning said, from second year onwards, he thought of research. So first, let's listen to each of the four illustrious speakers. Let's start off with Dr. Biju Soman, who heads the Achuthamenon Center for Health Science Studies. Actually SCT has a unique position in the health system and research scenario of the country, because it's not under the health, it is under science and technology. They have the biomedical research wing, they have the clinical, the hospital. Though when we talk about Chitra, we usually think about the hospital. But in addition, the third wing, the public health wing, Dr. Biju leads it. So let's listen first to Dr. Biju, breaking barriers in UG research.
Thank you, Dr. Indu, co-panelists and my teachers and friends. Today we are talking about undergraduate research, and there was a time when we were wondering whether we should be taxing the students with the research also. Like already the medical curriculum is very extensive, and it's very difficult to find time. But why should we tax them with the research also? But now, over the last couple of decades, we have seen that medical students, when they're getting introduced to research from the very early stage, it has many advantages. First and foremost, actually, it adds to the academic career, and we have seen that people who are indulging in research or getting introduced to research in the undergraduate stage itself, most of them are pursuing their postgraduate career, and they come into academics and research careers and all. But probably you'll see that the research career is not that much attractive in India. But the trends are changing. Recently, Government of India has come up with a national research fund to the tune of 500 crores of rupees. Actually, in the next 5 years, a lot of money is going to come in research, and research career also is very promising. So that's another reason why undergraduate students can get indulged in research. And there are many other advantages. So many studies have looked into the impact of introducing research in the medical undergraduate courses, and in what way it impacts the students who come out. Actually, it's very interesting. It says that not only that it will result in high quality publications from those students once they grown up, but it has some other advantages, like it brings in some sort of humility in students. In research, as we have heard from MP Pillasar, that actually research is research. In modern medicine, we continue to explore and question ourselves and correct ourselves. So that will give us some sort of humility, like whatever we are learning, actually we can question that. Or we have to always have that inquisitive mind in our career, and that gets reflected in practice also. And studies have shown that if you are introduced into research, actually then you'll turn to be good clinicians also. And it will add to your clinical work also. And then you can see that it can sometimes help in the team building. Actually, you have to work with so many groups, and you learn that sort of leadership skills and all. But all apart, I think that most important thing is introducing research. I feel like it should be introduced in the first year itself. Because when we are looking at the barriers, that's the topic which I'm
like Dr. Biju, now we have the family adoption program that's coming up in the first year. And you are heading a public health institute. What do you think are the opportunities at the community level for the first year undergraduate to start off with research? I think it will be open to the audience, because you are the most important part of this panel. So,
if you can, if you have any questions or comments, please raise your hand. And
Anuja, I think we'll open at the end or in between? At the end, after we have a first round of views from our panelists, we'll open it.
I'll start with this family adoption program. Actually, when we are looking at what are the barriers, actually I'm going through the literature and from our experience also, we've seen that one of the major barrier is lack of time. Second is lack of facilities, or lack of proper mentors or faculty members who will be trained enough to guide the students, and lack of facilities, or lack of statistical tools or equipments, etc. and all. When we look at the family adoption program, before the family adoption program itself, we get some tuning into research methods and data collection, and using some of the novel techniques for data collection. For example, we were having this open data kit, or where you need not collect the data in pen and paper and then enter it into Excel and all, but straight away you can collect it in your mobile smartphones. And with that, actually the faculty also will be tuned in a way that when you are doing the data collection itself, actually we will know when you have collected, from where you have collected the data, and the data processing can also be automated. So that kind of thing, and along with that, small equipments like, that now weighing machines are available, no? Weighing machines, if you spend just 3,000 rupees, like a community medicine department can have one or two, almost 5 pieces of homegrown weighing machines, which will give you not only the weight, but the skeletal mass, the fat tissues, the visceral mass, etc. And it might not be that accurate, but these are all something which enthuses the students. So rather than just going to the household and doing the routine socio-demographic data collection and all, now they are offering something. They can take the weighing machine there, and then we can tell the family that this is your weight, this is your BMI, this is your fat level or visceral fat level and all, and this can be followed up. So that kind of inquisitiveness can be brought in. So that's where actually this can work. And then let me add to one thing. And also we have seen Professor Abraham, sir has, Santosh Abraham sir has shown that pictures of breast cancer and all. So breast cancer surgery comes later. No? Now that's where actually when we are doing research, actually we'll get new ideas. Can we prevent breast cancer? So what are the ways of doing it? Actually now there are quite a lot of studies on molecular mechanisms, or endothelial inflammation, chronic endothelial inflammation. How can we reduce chronic endothelial inflammation? Now there is a lot of studies says that mitochondria is very, very important in our health and wellness. So when we are studying physiology or the anatomy of mitochondria, then the Krebs cycle, in what way Krebs cycle is linked with metabolic flexibility and all. So that gives us more avenues to think, or that induces about the so-called basic disciplines which we tend to ignore. Usually in medicine, actually, we are waiting for the basic disciplines to get over so that we can be clinicians and all. So everybody thinks that clinicians doing clinical work is the ultimate thing and all. But when you start doing research, you know that clinicians are being guided by this basic research. And then some of the so-called boring subjects of your basic science become much more interesting. So that's it, another advantage.
Yeah, that is another perspective. I think Dr. Biju has opened up a new area of thought. Of course, that thought is already there because we have many faculty from community medicine as well, of course, other specialities. So starting from early, like, research not only, shapes up a researcher or taking up research as a career, but that even shapes our thinking, influence our, the way we attend clinics and sees patients. Thank you, Dr. Biju. We'll come back to you and we'll take questions in relation to public health research as well. Let's now listen to Dr. C. Kesh Das, the need of the hour of UG research.
You can be here. I just wanted to show you some 3 slides. Yeah. Can you have the next slide? So this is Farid Murad. He's a Nobel laureate. He is the first G. Parthasarathi orator in Sri Chitra Tirunal Institute of Medical Sciences. He's a clinician scientist. So this is way back in 1957 and in United States. Farid, when he gave this oration, he gave a very interesting story. This in 1957 when he finished his chemistry and he wanted to become a researcher, but his mother told, "Why do you want to become a researcher? I want to see you as a clinician." I'm sure most of the students sitting here, and including my parents were telling, you become a very good clinician, become a person who has a lot of skills, either doing surgery or doing some diagnosis. But why do you want to become a researcher? Now Farid, in his oration, told why he's one of the first clinician scientists, why he took MD PhD course rather than an MD course. In US, MD is equivalent to MBBS there. They call it MD. And MD PhD is a totally separate course where research is given an equal importance to medical subjects. So in the 5 to 6 years, you learn both research. Research means right from the methodology part, doing research, having publications, everything is done along with learning subjects in anatomy, physiology, and all our other subjects. So he went for that course and he replied to his mother that if I am a clinician, I am sure I will be able to help a village, maybe a city, about 2,000, 4,000 people. But if I am a researcher, I will be lax and basic thing. And I feel this is the main thing. Perceived lack of recognition was constraint to students opting for a research career. There is no recognition. You do a surgery or you do an interventional radiological procedure or do a diagnosis, you are given a lot of respect by the society. But who gives recognition for a research career? So this was a problem. So this is the main reason why the Western world decided that we have to inculcate that research at a very young age at the MBBS level. In the last maybe 10, 15 years, there have been institutions like NIMHANS who have MBBS, PhD, but there are no takers for it. Number of takers are very less. So this time the NMC, which has come with the new regulations, they have a dual degree program. That is, at the MD level, you do along with MD a PhD also. So MD PhD program, so you get 2 degrees. You get an MD and a PhD. So it's a 5-year course, 3 plus 2, and few of the institutions have started it. But then doing all these things, why do you want to do a PhD? We have in Sri Chitra, Biju will be knowing, we have started the DM PhD, MCH PhD program. What is the whole purpose of doing this DM PhD? I have been asking my students to join this course. Nobody is joining because there is no recognition. Do you get an extra faculty position? If your publications, your 2 publications is enough to just become even an associate professor or a professor. So then why do you actually do whole this thing called PhD? Next slide. So what are some of the solutions? Acknowledge creativity. In the last talk, in the oration we heard, that we Keralites, even in India, we always have a lot of recognition given to creativity, whether it is writing a novel or coming out with a good film. We always acknowledge that. But it is time that we also acknowledge creativity. A person who writes a good case report in medicine or a good case report in surgery should be recognized for the good work that is done. And that is the responsibility of our clinical departments. So if you have a 3rd year or a final year student writing a good report or a good case sheet, he should be recognized. Just like you recognize if he writes a good poem, you naturally recognize it. So creativity has to be an expression, and lateral thinking, all these have to be acknowledged. Then research methodology and statistics is usually limited to the community medicine. As far as I am concerned, in my MBBS, it was only in community medicine I knew about research methodology. But there is a requirement of mentored student projects, because, and there have been studies which have proved that, and the ICMR as well as the NMC is promoting it. That means you being mentored by a doctor, a clinician, a professor in any subject, you mentor it, and you might need a statistic support, you might need a support from the public health people, then you can do interdisciplinary work. And I will show you one interdisciplinary work that we have done with Trivandrum Medical College. And interest in technology. Nowadays, the students who join for MBBS are extremely good in all these computational techniques and all. So virtual reality, robotics, these are new things. So you tell them these things, naturally they get attracted to these newer technological, these things, so bring them in. And between MD and DNB, we have also seen some differences. So DNB people, actually the problem is at no level they are being taught good research, and they find it quite difficult. So when you are in medical colleges, when you have got an opportunity, you should use it. And finally, research and publication awards should be given for mentors and students. If somebody publishes a paper, this should be awarded. This is extremely important. An MBBS student who is coming out with 3 publications, 3 case reports, have to be awarded. When that person applies to a university later on, that publication should be given the value which is needed. Maybe you can start with only small case reports, then you go to some bigger articles, all these things. But recognition is the most important thing. Last slide. So this is a work on virtual reality. You can see the group of students there. These are first-year students and who from Trivandrum Medical College, who came to Sri Chitra Institute. The Sri Chitra Radiology Department was conducting this research. The technology was developed by Indian Institute of Information Technology, Hyderabad, and we were trying it out in MBBS students from here. Dr. Doris and the anatomy department here was mainly the guiding these students, and now we have come out with publications in which MBBS students are also there as part of the study. So what Dr. Doris did, he mentored these students on these research methodologies, and along with Sri Chitra and Indian Institute of Information Technology, and has come out with quite good work which could be a game changer in anatomy teaching. So stereoscopic visualization, of the technique. So some techniques like this, biomedical research, biomedical technology development, all these things require interdisciplinary research. And I have seen that students, especially at the MBBS levels, when you bring technology also to it, because most of them are technology savvy, so they get interested in these techniques. Thank you.
Thank you, Dr. Keshav Das. We'll surely come back to you because he had, from first year, learning anatomy, till the MD PhD program of US and the new NMC regulations, lots of policy implications in his initial views. Now we'll listen to Dr. Amok. We have already listened to him today morning. Amok was asking me whether he should be diplomatic or straightforward in telling us his journey as a UG researcher. Of course, you have to be honest. You need not be diplomatic because diplomacy doesn't always work like that, right? Actually, we would have solutions. If you're talking about problems and problems and problems, actually, I've been learning solution-focused interventions these days. It's a new wave psychotherapy. So problems may be there, but you should be looking at solutions. So you have to be realistic. We are really honored. I think Amok's presentation was a real inspiration for, I'm sure, for all the, everyone in the hall. Yeah, Amok.
Thank you, madam. And no controversial opinions. Just that, so with research methodology training as an undergrad, I was interested from the second year of research, and I used to go for workshops learning statistics, epidemiological methods, how to use the software, how to use methods basically. But that, I think, focus on the methods took away time to invest building foundational frameworks about how the human system is built. So this is interaction with Dr. Karta that changed my view on how to approach research. Of course, techniques are important, methods are important, but whatever we do with the data we get, unless the data we get is coming from a question that has been asked on a creative pursuit, whatever we do with the data is not going to be meaningful as an outcome. So techniques are important, absolutely. Mentorship is important, but building foundational frameworks during your preclinical education by looking at mechanisms of disease, mechanisms of physiology, because it's emergent. Knowing about a neuron will not tell you about how the brain works. How the brain works does not tell you about how disease manifests. About how disease manifests does not tell you how it plays out in society. Community medicine teaches you that second level of emergence from the disease to the community. Biological mechanisms in your preclinical subjects teaches you the previous level of emergence from molecules, cells, circuits, tissue circuits to disease. Building that strong foundation during preclinical training, including, I would suggest, journal clubs where basic research as well as translational research is discussed to know how we understand systems at this scale. Clinical observations at the clinic where you see and understand things that maybe people have not recognized. And then the next level, wherever you choose, thought becomes important, and that's, I've been blessed to work with Dr. Karta in that regard. A small example is during Shankar Sir's posting in pediatrics, there was a case of HSP. Again, purpura, typical HSP. History taking revealed that the patient had a worm infestation 2 weeks back. Now, worm infestation in the gut induces an IgA response. So you elicit an IgA response when a worm is in the gut because it's a mucosal antibody. The IgM class shifts to IgA. But people had not thought of whether that could be linked causally to the disease because it's an IgA nephropathy. We don't know what causes or triggers it. A review back revealed with Sir that there have been some reports linking enteric triggers to the onset of disease. So I think at whatever scales you eventually go on, research methodology education becomes important, but that is only on the overlay of a strong medical education at all the levels of emergence, which is something that...
Thank you, Amok. We'll come back to you. I'm sure you will have many questions from the audience. Welcome back. Srinivasa, as a scientist at the ICMR Institute, Anish the other day was telling that community medicine department is really proud that many of our alumni who has completed MD community medicine, almost every ICMR institute I think in India right now has our alumni. So it's actually our proud privilege to welcome back you to this audience from an ICMR institute as a scientist. You need not restrict yourselves to the funding opportunities to UG research. You can tell anything to augment research at undergraduate level, including the funds.
Thank you very much, ma'am. So who does not want funds? So the tough question. Okay. See, before I start, I would really like to say the undergraduate research has evolved like anything. I remember in 2009-10, when I was a postgraduate in this department, we used to organize this. Our registrations were 140, 150 plus, and today it has doubled. That itself is a indication that undergraduate research has evolved to a different level. And I congratulate you all that you are a part of this evolution. A wonderful thing which has moved on from 150 registration to 300 plus registration. See, maybe my view on research, I have moved away from the academics. So, how much money you spend to kill mosquito in your home? Do you buy anti-repellents, something like that, in your home? No, you rear mosquitoes? I am paid money for rearing mosquitoes. There is something called insectary, mosquito insectary, where we do all sorts of research on mosquito. Every repellent which comes to you, it undergoes a process of research, and we are paid. So, sir was saying about research is less paid, and you can feel happy that rearing mosquito will also pay money. But it's a bigger challenge, and you are welcome to see how we do that. Second part is research as such, and I was saying to someone in the morning, it all depends upon the job market available. If I can quote the recent example, MD microbiology and medicine postgraduates are coming to my known laboratory to learn cell culture and vaccine induction. Because the market, the present pharmaceutical market is in vaccinology. So research, and especially the opportunity in research, depends upon the requirement in the market. And especially, this is the hay time for researchers. And when we talk about funding, we have to know from where to get it, and more than where, how do we approach funding? I think I will talk in detail about the exclusive funding available for medical undergraduates, and I'm thankful to the VC. In the morning I was thinking I had only one option to respond in this panel. So the VC sir gave me a second option that they are going to give 1,000 protocols up to 10,000, which is almost equivalent to the STS which is there in ICMR. Presently, whenever some agency is funding, there are two ways of looking at it. One, if you look to the ICMR website, you can see a lot of call for proposals. And exclusively for medical field, now you have multiple options. How many of you know there is a operational research grant in every zone and every state for one particular disease? Has anybody applied? Can you name that disease? Tuberculosis. Yeah, yes. Tuberculosis OR research has huge funding. Unfortunately, the number of protocols which come to the national OR for funding, they are very less. Actually, I was part of that committee 2 years back when I was working in tuberculosis. That itself is a wonderful area where you can look in. See, rather than looking at where am I getting money, you have to think the other way. If I am targeting this disease and this objective, what are the sources available? And with the present government initiative of opening up the central laboratories, right now I have 4 interns who have come from different specialty who are working on vector-borne diseases, vector-borne zoonotics. So approaching the right people for right source is very important. And if you look at the kind of work a friend is doing, that requires a high-end laboratory. But first and foremost thing, you have to decide what is your objective and what is the outcome which you are planning. Depending upon that, there are multiple sources of funding agencies. Simply, if I can list, STS is one important thing, OR, Operational Research for Tuberculosis, and now MRHRU, special, there are special grants in MRHRU, and most of the time, you can always approach ICMR call for proposals along with your faculty, where it's very easier to get the funding. I'm proud to say we are working with psychiatry. There is a, everybody know malaria causes cerebral malaria and it has high mortality. But what happens to those who are severely affected but who survive? There's a lot of space for working on cognitive impairment due to malaria, and where we have got a grant from DHR, we are working. So it's all up to you to link what area you are working and how to approach. We approach the mental health call for help from the DHR and we have got the funding. So we are working like that. So decide which specialty, which area you are willing to work, and based on that you can reach out to different source of funding.
Thank you, Srinivas. We'll take up questions from the audience. Audience is eminent faculty and young researchers as well. Yes, please. Please introduce yourself and put the question. Yeah, please wait. You will get a mic now.
Good afternoon. I'm Tarnya Rajesh. I'm a final year about to graduate. So my question is to Dr. Amog. The most difficult thing with research is, in my opinion, finding a topic on what to research. So what is your thought process regarding how you find the appropriate research question, how you follow up on that research question, and what is your thought process on how you are approaching that particular question or whatever you're curious about?
Thank you for the question. So I'm not the most qualified to answer that. I will like to pass the question around. But from my take as an undergrad researcher, one is the question often comes from the clinics. So any observation that you see that you think is out of the norm, you can discuss it from a clinical sense and come up with clinically meaningful questions. As I said, it can be at any level of what you want to observe. If it's an observation that holds biological meaning, you can report a case series, follow up a group of patients to look at outcomes and so on. But secondarily is to work with people, and first project is better to work with somebody who is doing work. So getting a mentored experience is critical. Third is forget research, but doing thought experiments help, because you don't need, there are lots of secondary data available. So there are databases of genomes, there are databases with polymorphisms, where if you have a question that you want to ask, you can ask. But you have to think about what it means to the system. For example, there is this Rh antigen. An Rh antibody is inherently IgG. It doesn't undergo a class switch, which means that you're already sensitized to the antigen in some way. Now, we don't know how sensitization occurs, because you're getting a primary IgG response. Now, could certain gut microbiota, gut fungus, or some PAMP or DAMP, which are these molecules on these organisms, mimic the antigen in such a way that you're already primed with a response that now class switches? So these are questions that came up during thought experiments, and this can be done because you have the structure. You can look at homology of structures from the structural databases. So you can ask a wide range of questions, ranging from clinics to preclinical to mechanisms to whatever you see from the textbooks that you read, because we know nothing about how observations in the clinic tie up with mechanisms. Lots of gap. And one textbook sentence can lead you on an adventure or a quest which will open up many questions to come. So I hope it answers.
Would you like to respond, Srinivas? Yeah, I request one.
See, usually what we teach is iterative loop. You look at the risk factor, causative agent. But more than that, you have to see what is the current things happening. In last 1.5 year, the maximum number of manuscripts which I have reviewed is linked to COVID. So COVID is the topic. You take any disease, it is linked to COVID, or its complications, or its outcome. So, as Vijay Kumar sir always says, your ideas will come based on many things. One is reading journal articles. If you have the habit of attending journal clubs, you'll know what is happening. I think I was really surprised. Senior professor was saying about the latest arrival in breast cancer management, which he was reading this months. So this is how you keep yourself updated. And especially in funding, ma'am, the first thing they will ask is novelty. What is the novel thing which you are doing? See, maybe research is the only funding zone where you do not know the outcome. If you already know the outcome, if you already have the proof, why do you want to spend money? So the funder will ask what is the novelty in this, how is going to impact the community or the profession which you are working in. That's
Yeah, I would just say that first of all, you have to get a very good mentor who is ready to spend some time with you. That is the most important thing. And the mentor should be able to tell you how to go step by step. There will be 5 research questions which have come to your mind, whether it is feasible or not. Most of the problem that I face from my students is most of them have many ideas, but it might not be feasible in your situation. So first, feasibility. Novelty is important, so I will ask him to go or her to go to and read all the latest articles on that area and come out and present in front of me about the various things which he had read. And the third, by this study, you have to create a hypothesis. By this study, what more you are going to contribute in answering one of the questions in the medical literature. So these things have to be discussed only with a mentor who can give a lot of time for you. And so you have to take the topic of your interest, not the mentor's interest. That is another thing. Many times what happens is, and I have seen that many students don't like the topics that then it is better that the student moves away and gets into some other topic, mentor. That is the most important thing. That's what I feel.
I have a difference of opinion, actually. I would like to differentiate undergraduate students involved in research and postgraduate or researchers and all. When it comes to research, question is that's the thing. That's the most valuable thing in research. It's not the answers, but the question. But for undergraduate students, I think that your main focus should be, as Amud was telling, to get a grasp of the subject. You should be concentrating on learning the subject thoroughly. So if you want to do research, that's built upon your current knowledge of the subject matter. So it's very, very important. And during undergraduate days, you can get involved in research. That's what the old PSPS approach is like. You need not wait for the question, the most ideal question and all. It will take quite a lot of time, and we can't, actually in medicine, actually when you are entering into medicine, it's a very vast platform. So from there, actually, we can choose our specialty. We need surgery or preventive medicine or microbiology or pathology or whatever is. There's a lot of scope for that. And research career is one among them. But during your undergraduate studies itself, without infringing on your studies, actually you should get exposed to research. For that, actually you can piggyback on ongoing research, or if faculty members having some research, actually getting along with them. That's how we all learned research. Actually, it was not our own research, and we were not getting funding. Actually, funding, of course, there are now more chance of funding and all, but we are not expecting that all 200 or 250 students will get funded projects and all. So it will be a rare group. topic or some disease ends, there researchers who will be looking at very outdated.
Critical or the bottleneck in diagnosing, the latest strategy for malaria is test and treat. So for diagnosis, the most important thing is you want a good microscope and the learned laboratory technician. So how do you add your research component there? That's where AML has come. Okay, and more than that, the next level is now drone technologies. According to the latest Government of India's current strategy, current definition, there are only 31 districts which are still endemic to malaria. And if you mark it in a map, almost all these districts come from very highly dense thick forests. So how do you control mosquito? You cannot send men because already there are no men who are working. So use your drone technology. So, sir, this is the other extreme of research. When you ask about questions, it all depends upon with whom you are aligning. At the basic thing what we want to add is the research is add-on upon your basic learning in medical education. You may become a wonderful researcher without a medical degree. What will happen? Your parents will kick you out. Am I right? So that's add-on. So at the same time, what I'm trying to say is, research is a huge spectrum. When I'm talking about AI, ML and machine learning and drone, that's also research which is happening in public health. The other extreme, what sir is saying is, it should be add-on to your basic medical education.
Thank you, Srinivas. Just one word of, just to respond, there are two important aspects to it. One, now it's part of the curriculum, right? 7 semester, I think it's part of the KUHA's, or the all universities across, there is a 7 semester, there is a research project, there is a mentor, few become a group. And in all, I think when I was here, Amog used to have that students group. I'm not sure whether, I think it must be happening in all colleges. I saw faculty from other colleges also, Anuba, many others. So it must be happening other way. Evenings he used to, conduct mentoring kind of, peer mentoring is very powerful. If we just facilitate students themselves, actually they belong to the next generation, Viju. And their answers, their research questions and their research ideas are ahead of us. There's no doubt about that. So facilitating that is really important. And there may not be for all the 200. But definitely there will be a good proportion. I think that proportion must be increasing. STS, I think, Amog, you did STS when you were here. I think I work now in Kollam. I think Ogul and Devani who are attending the workshop, they also have their STS. I'm sure many of the undergraduates. So those opportunities are growing up. In addition, like how do we facilitate that? I think that was the discussion point. Biju പറഞ്ഞ പോലെ ഈ പുസ്തകത്തിലെ ഉത്തരം മാത്രം നോക്കുന്ന ടീച്ചർമാരല്ലാതിരിക്കാനാണ് നമ്മൾ ഇപ്പോഴും ശ്രമിച്ചുകൊണ്ടിരിക്കുന്നത് അല്ലേ, പഠിച്ചുകൊണ്ടും ഇരിക്കുന്നത്. But there is a point,
Not that I'm saying that some teachers very silly, they are looking at outdated data and all. But as teachers, actually we have a curriculum to follow. And the curriculum, what is the truth now, we have to satisfy that. But in research, actually we'll be questioning now. Sometimes what is truth, for example, the root cause of all chronic diseases starting from cardiovascular disease to cancers and all. Now there is a hypothesis like it's because of chronic endothelial inflammation. And what is the root cause of chronic endothelial inflammation? Whether it's because of our dysbiosis of the microbiome, or whether it is because of some external environmental triggers which causes this problem. Or you know that once you get age, actually micro cancers are there in everybody's body. A 50-year-old woman, 50-year-old woman will have a micro, almost 70% of them will have micro cancers in the breast. And a 60-year-old man, actually they'll have a micro cancers in the prostate. But not all of us develop cancer because of the inherent immune mechanism in our body. Why it is not getting triggered, the immune mechanism is not getting triggered in everyone. So if we can find that out, so there is a lot of hypotheses coming up in that, but that is not there in our textbooks. So new hypothesis and all. So that's why I was emphasizing on the interest group. As Dr. Indu is telling, actually interest group could be mentors or not only confined to your faculty members or outside agencies. Chandrasekhar Karta sir has helped Amod actually. So they could be, that is the interest group. You keep on working with the interest group and all. But one more thing I have to tell you about the timing. Already MBBS curriculum is very crowded. And how will you find time for your research? That's where actually this kind of timing during your community medicine posting and from the first year itself, I think that that's a time when we should be framed about research methods and all, and some of the tools. And the tools which we are introducing, we should be very careful. Tools which have a potential for scaling up should be introduced. For example, if you are learning statistics with Stata or SPSS and all, it's limited. Learn statistics with the R. And there also don't limit yourself the core or the tidy way, the latest things. So that learning will help you later if you want to do geospatial analysis or time series analysis or genomic studies, actually it will help you and all. So to take up the tools which are helpful and all. So that's very, very important. And the sort of interest group, we have seen that those students who are interested, they are sticking on to one topic from the very beginning, they're doing wonders. So they have very good careers and all. But if you keep checking so many areas, like whenever an application comes for a post or project post or a faculty post and all, actually we'll be looking at your research. The published research, if it is all where, if it is not very focused, is everywhere and all, then the impression won't be that good. Actually, when we are judging a person, actually all the research and all the focus areas where he or she was working, everything is in line. Actually, we know that this is a promising guy.
Thank you, Dr. Biju. Shall we take up another question? Dr. Anuja, I think we'll have, yeah.
Just as an add-on to the, so how do you mark a good researcher? This is something again I take up Professor Karta because he comes again and again in my. So he had no publications in the many years he did research when he entered Chitra. So he used to carry around a bucket in his early days, looking at pancreatic tissue, collecting pancreatic tissue to look for precursor lesions of pancreatitis. His work involved going to the postmortem section, taking tissue, coming back. Lots of tissue because the prevalence is small, you won't get it otherwise. Following that, he tried to figure out endomyocardial fibrosis and what causes it. Lots of interesting work by looking at selenium content, linking up with the pathology, but no published work. But Valitansa saw merit in the work and he was given a position even though output was not there. So should you follow H indexes, should you follow output, should you follow papers published, or should you follow somebody who is so innately curious that they wake up in the mind with a spirit of inquiry? And that is something that I think one can develop irrespective of something under the banner of research training. If one is just asking questions and excited about the world around them, I think that will make you, I wouldn't say better because it's a subjective judgment sometimes. And objective measures fail people like that who are crazily out there, but be wild. Think of wild ideas, so in TIAFA we have group discussions where we just pitch ideas and think. One thing that recently came was, you have a cochlea, you have a piano. You have literally frequency coded neurons that encode sound of different frequencies. Now, if you think of musical instruments and music that we create music in the audible range. And the music that we have is in tune with what the cochlea has encoded evolutionarily. So has the instrument been an external manifestation of your inner cochlea, or have we developed music based on what was already there in the CNS? Now, what makes something sad versus happy? If you are running a race, or if, as I said, the gazelle is running away from the cheetah, it's stressed, and the footsteps are in a particular tempo. If you look at exciting, adventurous music, it is of a particular tempo. If you see a cat cry, you will know it's a sad cry if it's in pain. So across scales of evolution, sounds seem to have evolved to tell your auditory cortex and your engrams, much the secondary centers. Some sounds are pleasant, some sounds are not. You have particular frequencies and tempos which you have to recognize for a context. Is music an extrapolation of this? So these are wild conversations that we have that have kind of loosened our CNS to now look at the world a little differently. So I think random thought discussions, you can just do it over chai or coffee or lunch, get together, discuss your clinical observations and observations that you see in everyday life. There are examples from art as well. In Vietnam, there's a painting where there's a woman holding the head of a guy. There's a story behind it. So there is Kandel, who has written a book on art and the brain. And he talks about how painters have depicted emotional links which later researchers have found stem at the same place in the brain. So if you look at the hypothalamus, you have a center for sexual behavior and a center for aggression, which are close to each other. The neurons overlap. Multiple paintings across artists have developed both of them together, despite them not knowing anything about the brain, but looking at humans for what they are. So don't confine yourself to biology, don't confine yourself to textbooks, explore everything around you, art, music, culture, the human condition, to realize what it means to be human and in the context of disease.
That will be just, you will have a lot of questions, but you have to prove it, no? Research needs proof. So we have to have a scientific method of all your questions. If you don't have, then it will remain as questions. But do you think that that is enough for us? That is this thing. It is very nice. There will be so many questions and you have to question. That is the starting point. But more importantly is the questions that you asked, whether I do a correct research methodology. How many of our undergraduates know that? So that is an art of itself, which is never taught in our medical, as Biju was telling, the course is so compact with so many other subjects. Research is a totally different ball game which has to be taught. And it takes time for you to learn the proper methodology. The subject has to be known very well. So I think that that has not happened in the current method what we are following. That is probably the reason why nationally I was talking about that we are at present in India giving no importance to medical PhDs. Are we giving, anybody is having? We are equating MD is equal to PhD. Is it correct? Is it correct to equate MD is equal to PhD? I am an MD degree, most of us are MD holders. But once you get a PhD, you learn how research has to be done properly, which has to be taught. MD is most of clinical skills are being taught. Public health might be different, but most of us, I am from radiology, I have been taught a lot of clinical. I like a radiologist, whatever is clinical skill has been taught. But my knowledge of research is, I cannot do a good systemic review or meta-analysis now. I have to run to you for that. So that is the thing. There is a lack of, we don't have time for that.
1 minute.
Yes.
Actually, I'll just reminiscing like with the PSBH campaign, like the problem solving for better health, which Vijay Kumar sir and Sia Soman sir and all actually they were doing. At that time, actually, I was involved from the very beginning, and sometime we were arguing whether we should introduce it to undergraduate students or not. Like doing research just for the sake of research is not going to help. So real research comes out of your passion for that thing. So that's why some of the best questions, so some of the questions you may have to park during your undergraduate timing. So during your undergraduate times, what is feasible within the time frame, that only you take it. But when you are in that process, there are examples like Paul Longerhand actually, who invented that Longerhand cells. Oh, you can see the insulin was in the discovery of insulin. What is his name?
Best.
Was he was an undergraduate student. The contributions were there and other. So that is 1 in a million time. We can't expect that all 250 of us are going to do wonderful research and all. So people who are inclined to research, actually they're a sect apart. And later, during undergraduate times, all of us should get introduced to research and the research methods, so that those interested will take it up later as a career. So that's my take.
Yeah, yes. Srinivas.
See, again, I come from a different road, it seems. ICMR has come out with a joint venture with the ACSIR, where they want all the medical professionals to get a PhD and all the PhD people to get MPH from NIE. I think NIE course is made compulsory for postgraduate. And yes, sir was saying
BCBL. It's BCBL.
NIE course.
Yeah, NIE courses.
As sir was saying, there is
the ideas that I was saying, we can look at neurons that are excited by in the rodent. We can do C4 labeling that biologist knows. Now we can come to the human and take and extrapolate findings. But these people don't talk to each other. So I think collaboration is critical, and a doctor becomes a central node for collaboration because, I mean, at the end of the day, the observations are seen by the doctor. The biologist does not see it. And so I think where I was coming from was, we find that even with all the programs, we are training methods, clinical research methods, but an incentive to think and talk to people from different fields is less. And I think in undergraduates, if you're just putting science students in the same space as humanities and doctors and having them converse, I think those bridges will break down. And I think that's an area where the current research avenues have not explored into, which is conversation. And I think, I mean, it's a... Yes.
Has the MCQ era, both at the +2 and the NEET, destroyed the thinking of a person? You are just getting knowledge, that's all. A lot of knowledge and you have to reproduce it. No lateral thinking. So there is a real problem that we are facing. That also we have to evaluate. At the UG level, they are looking at the next degree, MD. And at the MD, you are looking at the DM. And writing exams, which never test your lateral thinking. So there are problems which we have to address. It is not that easy like what we think.
Yeah, I remember my doctor was telling that after entrance, when they joined medical college, they had to de-learn the MCQ, unlearn that kind of thing and all. Because otherwise they can't manage. So similarly, yeah, now research is moving towards transdisciplinary or interdisciplinary. That is the way forward. And for that, we have to collaborate. And for that, what is the most essential thing that we should have? You should be thorough with your subject. If you are not thorough with your subject, you can't collaborate. You won't be contributing to that transdisciplinary or interdisciplinary research. So be good in your subject. That's why during undergraduate times, I stress that you have to learn the subjects well. And research, definitely, we should get exposed to the research ethic. Research means the tools and all, but don't devote all of your time to research during undergraduate, unless you are that motivated, that passionate towards a particular entity, and you have way to work with a group and all. Otherwise, focus on your undergraduate studies. That's my advice.
Thank you. Any more pressing question from any postgraduate faculty? I can see, is it a hand? No. No. We'll wind it up. So it was actually lots of policy issues come up, which need solutions beyond this panelist, but there are very pertinent points, and many of us continue to work, and all of us are part of important agencies to carry forward the queries that evolved from this panel. Of course, curriculum has to be flexible enough to accommodate innovations, novelties. Methods do matter. We need to focus more on clinical research. Devoted time matters. Lots of other issues will be evolved. Unlike institutes where the number of beds are restricted, the number of admissions are restricted, in government setting, the patient flow will be very high. Lots of other issues, policy issues. But definitely, the methods do matter, and let's hope the NMC and the new, if I understand right, in many countries, even during undergraduate course, 1 year, while I was in Australia, I found that, if I remember right, it was 1 year. Yeah, it's not off, it's part of it. They can attach themselves to a research institute and do the entire process, attached to one faculty who is a mentor. And the mentor naturally will have a team. They'll identify their areas of research. I think there are some, and the entire process, starting from the protocol, the ethics review, the conduct of research, they have the access to the data, whichever database, everything. So that is also there. So I am not sure India as a country has the flexibility to devote 1 year of our undergraduate course exclusively to research. But as a country with lots of health issues which requires solutions which are context specific. Now we talk about implementation science and implementation research. Research has to be context specific to address our problems. So thank you very much. We hope to carry forward this conversation. We are extremely thankful to all the panelists. I feel honored. I thank Dr. Anuja and the entire team for giving this opportunity. I feel honored to be part of this panel. Dr. Biju Soman, who is Professor and Head Achuthamenon Center for Health Science Studies. Dr. Keshav Das, who is Professor and Head of Imagology, Radio Diagnosis. Sir, actually, like electives as part of MBBS course gives another opportunity, since your Chitra is within the campus. I'm not sure, even if it is a small number, that's what's one for Google's query, right? Yeah, so there might be institutional policies whether you so those are the opportunities. So several opportunities. So I think these conferences should be venues where such conversations, as Amok was mentioning, there has to be, we should have dialogues and conversations. We may not have, quick fix solutions to everything, but as it evolves, of course. And I also thank Dr. Srinivas. It's a real pleasure to see you back, Srinivas. Hope you will, many of you, if you give, Anuja, if there is an opportunity to provide their contact on mail ID, because some of the young researchers might would like to, take guidance from all the speakers. And finally, Amog. It's truly inspiring to listen to you. I really love the way you talk about research, right? And communicate to the youngsters with such a passion. So with that, I hope we can wind up this session. Thank you, everyone. Thank you for the wonderful questions, and thank you.
Thank you for the informative session. We thank all the panelists and the moderator. We thank you for motivating us for pursuing early research in our careers. Now, we welcome Dr. Anuja Yu, Professor and Head, Community Medicine Department, to present a token of gratitude to Dr. Biju Soman, sir. Thank you, sir. Thank you, madam. Now we welcome Dr. Mini S.S., Professor, Community Medicine Department, to present a token of gratitude to Dr. Srinivasa B.M., sir. Now we welcome Dr. Asha K.P., Professor, Community Medicine Department, to present a token of gratitude to Dr. Indu P.S., madam. Now we welcome Dr. Anil Kumar TV, Professor and Head, Department of Psychiatry, to present a token of gratitude to Dr. Amok B.J., sir. Now we welcome Dr. Indu D., Professor and Head, Community Medicine Department, to present a token of gratitude to Dr. C. Keshav Das. Thank you all.